Dr. Ambrose Rimmel and I actually went to Colorado State University together. So I've known her for some time. I don't know if we had any rotations. I think we did have at least one. Yeah. So always thought of her as wicked smart. And of course, she's an oncologist today, so she must have been. From her bio, you may have read a couple things, but I want to highlight a few more. She is from North Dakota. So we have a North Dakota native. That's wonderful that someone went away, got educated, came back. She did her BS, her PhD at Colorado State University before she went on and did her DVM. Then she did a rotating internship at North Carolina State University before she became a resident back at the Flint Animal Cancer Center at Colorado State. From there, she went on to University of Minnesota, where she's been a professor. We've been our first and only oncologist doing research. So with that, I will let you take over.
Okay, does everyone hear me okay? Okay, great. Well, thanks for that great introduction. Yes, I felt the same way about you, Heidi, about being wickedly smart. And we both had DVM PhDs at CSU, which, yeah, was just a great program to specialize in what we were really passionate about. So ultimately, I'm going to get my PowerPoint first. I know how to do that, actually. I will, does that mean my screen sharing is not working? I'll give kind of a brief introduction of, just thinking about topics in oncology that I thought you'd be interested in, and hopefully there's enough small animal practitioners to benefit from some of the advice I'll share. I think also, unfortunately, cancer is common in dogs and cats. So as a client, as an owner, so as pet owners yourselves, you may be, learning about some of these diagnostics that we're using to better diagnose and improve outcomes for pets with cancer. So potentially there's a way to learn that as well. Okay. Well, I can advance it too, but let's do that. Okay. I don't think this part's working, but okay. So I just had some learning objectives, just kind of get an outline of what I was going to cover today. So just looking at three, big types of cancer: lymphoma, mast cell tumors, TCC, or transitional cell carcinoma of the bladder. Some of the more common diagnostic tests, and these are specifically molecular tests that you may or may not have used or are questioned about using before. So try to make it hopefully helpful for you to feel comfortable, using these tests and when they're indicated. You're also always welcome to reach out to me or another oncologist to know if it makes sense. Again, often expectation is that I would talk to clients about these if you refer to me, but also there are definitely, ways that you can incorporate this into your practice to get owners more information about the cancer. So the first one, we're going to talk about PAR and flow cytometry. So really common tests we're using in small animal lymphoma. And then the mast cell tumor option is there's a molecular prognostic panel that is offered, not used a lot, but just talking about when we could consider that. And then third is probably the most used by a lot of veterinarians is the BRAF test for TCC. Lastly, I was going to introduce the IDEX Cancer DX test. I know very little about it, but we're certainly being kind of barraged with information about it. Probably will be targeted more towards private practitioners about how to detect lymphoma early in dogs. But I'll share with you what I've learned, how we think this can be helpful. So the first topic, just kind of talk about these three cancer types, lymphoma, so start getting you thinking about cancer and cells. The big picture, mostly gonna talk about dog lymphoma, but I'll mention a little bit about cats at the end of each section. We know, unfortunately, a really common tumor in dogs, and there's different types of lymphoma. This is something that we always talk about, but I think it's worth delving a little bit more into it, because certainly an owner getting the diagnosis of lymphoma is really devastating, and there are different types. More low grade or high grade, depending on the diagnostics, that we can help better predict prognosis. So just been big picture, most dogs get high grade lymphoma or the aggressive form of lymphoma. This is based on cytology, histopathology, looking really at the size of the cancer cell. So usually I always just call it large cell lymphoma as well. Usually it's more B cell, and again, we'll talk about cell type as well. Lesser number of dogs get low-grade lymphoma. That's again based on cell size primarily, small cell size. And generally that's more of a T cell lymphoma. Again, I'm really generalizing here, but specifically there's a subtype of lymphoma called T-zone lymphoma that's actually fairly well classified now that we know about it. And it's not as terrible as we thought all T cells were. So again, immunophenotype is the B cell or T cell distinction. Again, we're really simplifying this compared to what we know in people with lymphoma. Ultimately, most dogs have that large B cell lymphoma. We do have other types. Sometimes when we do these molecular tests, we do not know what the immunophenotype is. So like if you do flow cytometry, there could be a mixed big B cell, T cell, or sometimes these cells are considered non-B, non-T. Those, of course, we really don't know what to do with, but we are definitely collecting the cases. So why is this important to learn more about the type of lymphoma? So really big difference in how I would treat these cases. Always hoping if a dog has lymphoma, it's going to fall on the side of the low grade or indolent lymphoma. So again, a good example of this is T-zone lymphoma. This is definitely, again, something we didn't always know about, but we now see lots of cases of T-zone lymphoma. So a dog may present with big lymph nodes, but commonly feel well. So this is kind of the incidental diagnosis. We need to do diagnostics to figure out if it has that kind of low-grade lymphoma. We may or may not treat that dog. We may just monitor it. If we do treat them, usually it's going to be a lower grade kind of lower treatment like chlorambucil and prednisone. Survival time can be really good, usually several years. On the flip side, the most common lymphoma we see, which is probably the one you're prepping your clients for, is high-grade lymphoma. Again, based on cell size, typically. I think I've got a little animation there. This is where immunophenotype or figuring out the type of large cell lymphoma can help, because we know with the most aggressive protocol called CHOP chemotherapy, the survival time is pretty drastically different. So just to, again, probably we don't really learn a lot of this in vet school, but there are at least 34 recognized subtypes of lymphoma in dogs. We just don't really go as far as doing biopsies to figure this out. Part of the problem is, of course, biopsying every lymph node is time intensive. It's more invasive. Also, we don't really know how to treat, T cell rich large B cell lymphoma versus Burkitt lymphoma. So we just don't know, enough about these subtypes in dogs. In people, again, this is definitely gold standard. You figure out what subtype of lymphoma you have and even go farther with genetic profiling and figure out what might be the best treatment. For us, again, we have a different approach to this in veterinary medicine. The other thing is if you do a lymph node biopsy, not all pathologists will report a subtype. You can definitely ask them to, and there are some places, again, I trained at CSU, they have some pathologists specialized in or interested in lymphoma. So they will often kind of as a group collectively try to, tell you what type of subtype this is. Sometimes though, you do have to ask for it if you do actually do a lymph node biopsy. Again, why this is important is there's a really big difference. So this is something that Dr. Avery at CSU, who's head of the flow cytometry lab there, put together. This is now a few years old, but just the big picture again, This is the most common type of lymphoma in dogs, diffuse large B-cell lymphoma, just like in people, similar to non-Hodgkin's lymphoma. We know with treatment, the prognosis can be about a year. There are some types like T-cell lymphoma that, again, I mentioned don't do as well, but then there's T-zone lymphoma that can do very well. So again, the other colors in here, we just don't know a lot about, but these are all, subtypes that people get as well. Often we're comparing to, what they did in people as well. So we're working on this model. And then they did overlay this with, what are the diagnostics we have. So today I'm going to talk about lymph node biopsy, flow cytometry, and PAR. And these are, again, just some examples of sometimes we really do just need to do the lymph node biopsy to figure out what this is. But there are some types of cancer lymphoma, like T-zone lymphoma, that we can actually diagnose with flow cytometry. So when to use these tests is the question. So I was going to go through kind of the 4 big diagnostics for lymphoma, what it does, what it's helpful for, what we can't do with it. The obvious one everyone knows about is probably cytology. So still remains what we recommend for aspirating a dog's or cat's enlarged lymph node. It's relatively straightforward to diagnose large cell lymphoma, expansion of too many large lymphoblasts in comparison to a small lymphocyte. We can also get a suspicion of a different kind of subtype of lymphoma. So this is an example of T-zone lymphoma. T-zone lymphoma is usually described as an expansion of intermediate size lymphocytes, and they have this characteristic tail on them, cytoplasmic tail. So whenever I do cytology and I see this, I'm really excited that it might be T-zone lymphoma. Again, that's the one that we do better than other T cells. So this is not, diagnostic pathognomonic, but we do recommend flow cytometry on this sample to confirm T-zone lymphoma. So that's like a win of the day when we can diagnose T-zone instead of T-cell. Very inexpensive, relatively invasive. We do a lot of digital cytology. It's just fast, it's a couple hour turnaround through IDEX. But it does have the limitations. Obviously, if you wanted something like ICC done, this is, again, stains to apply to the cells to determine B or T cell, we have to send those slides out. So it's going to take longer for that. What it can't do, obviously can't give you a subtype, and that's kind of the big picture. And then the flip side of that is biopsy for histopathology. So again, kind of reviewed this already, but it is gold standard to diagnose and confirm lymphoma, tells us subtype. And certainly we can figure out the immunophenotype with IHC. That's usually a good idea to add on. And again, definitely just the best. It's just sometimes the problems with it are obviously it's more invasive, more expensive, takes time to get the results back. And if it's a lymph node that's like, let's say mildly large, there's not like an obvious population of cancer cells that's really big, we can miss the diagnosis. And again, really depend on the ability of the pathologist to tell us a subtype. In people, I mentioned they take this and do molecular profiling, and we just at this point don't have that. All right, so flow cytometry and PAR are the 2 I'm going to focus on for this lymphoma section, and just a review of what this is. So don't expect you to care a lot about this, but it helps, I think, understand why we use it when we do. So flow cytometry, probably the biggest thing to remember is you need a viable cell sample. So you have to get a fresh lymph node aspirate, has to be put in either buffer, or sometimes they have recommendations for certain blood. Ultimately, that gets sent to a lab, has to be processed within 24 hours. So why that's important is because we always think of these cancer cells, they need to be, just, perfectly 3-dimensional round, preserved. And what we do is we sort these cells in that buffer solution into like with like, and we sort them based on the proteins on their surface and also cell size. So it does give us a lot of really interesting information. We can also quantify things. For instance, class 2 MHC is a protein on these cells. We know that high class 2 MHC is a good prognostic factor for dogs with B-cell lymphoma. So flow cytometry is now kind of taken it a step further, helping us with giving prognostic information. Again, that's all stuff that the flow cytometry service will likely provide you. And again, they're really good about providing as much information as they can. It's not something you need to ask about usually. All right, so that's a good picture of that. Again, just an idea of how it's sorted. Pretty much they take out the red blood cells, sort it through a flow cytometry machine. The ability to basically do flow cytometry is based on we have to have these antibodies that are validated for cats and for dogs. So it is something that we're continuing to work on, but we do have the ability to do this test in both cats and dogs right now. Okay, so what it can do advantages is B cell or T cell immunophenotype. That's what we use a lot for. I did mention it can sometimes subtype a lymphoma like T-zone lymphoma. The other big use for flow cytometry is you think your dog or cat has leukemia, specifically acute leukemia, the kind of the worst case scenario for these cancers. It specifically expresses CD34. So that's just a really easy thing that flow cytometry can find out. Again, the prognosis for that one is extremely guarded, so it's very helpful to provide owners with information. I mentioned prognostic information. It is just a needle aspirate, but you may have to get the pet back in to get a fresh sample. So that's maybe a downside. The downsides of it would be it can't really be, I wouldn't like necessarily just do it without having suspicion of lymphoma. Let's say that. I do usually recommend like having some suspicion on cytology before we're doing it. You can test peripheral blood and other body fluids, but sometimes this is going to be dependent on the cell number. So if it's too low of an abnormal cell population, it won't be helpful. And then finally, probably the biggest one, you need viable cells. It can't be frozen. So when we send it to, we usually send it to CSU, they just want a cool pack in there and then we get it sent out. And the nice part about, I'll put a plug in for CSU's lab, they can do PAR on the flow sample. So if the flow cytometry comes back for some reason, the cells are dead or there's not enough cells to detect the cancer, the next step could be the PAR test and they can do it on that same sample. So you don't have to send it in. Of course, it's another charge, but it's helpful to have that same lab to keep the sample and do it. All right, so that's flow cytometry. And then lastly, I have PAR. And then after this, I'll talk a little bit about cats and then go through just a case example, a few case examples of how to use these tests. So PAR, as you probably remember, is a PCR test. So it's called PCR for antigen receptor rearrangements. What we're doing is taking the cancer cells, amplifying the DNA and evaluating the receptor gene length. So we're looking for the Ig receptor for B cells or the T cell receptor for T cells. So the big picture for this one is it's going to look for clonality. So the big important part is this is, again, what they're going to look at in the lab, but what they'll tell you is really just a readout of clonal or non-clonal or polyclonal. So this monoclonal looks like this, just one big peak versus polyclonal. This is more of like a reactive lymph node. So for them, there's cutoffs that they'll use in the lab, but they should give you a readout of what this is. Again, if you have suspicion of lymphoma and it's polyclonal, it is a very sensitive test. So to me, when I think flow cytometry can be a little bit more subjective and not as sensitive, but again, sometimes there is a need to do both tests as well. There's different types of cases that I recommend PAR over flow, and that's what I'll get at with my examples. But sometimes too, the sample depends on this. So big advantages of PAR is you can do it on like already collected samples. They don't have to be live. So blood can be submitted for PAR, body cavity fluid, CSF fluid, slides that you already did for cytology, stained or unstained. So that's really helpful. And you just don't need that many cells to do this test. So very helpful. And then finally, you can do this on biopsies. So again, sometimes biopsies are not going to confirm lymphoma. There may be like a population of lymphocyte-rich cells that are concerning for cancer, but not necessarily diagnostic. So PAR is like, to me, an add-on test to be more sensitive to detect that. This is the sensitivity, so specificity data that CSU is currently reporting for both cats and dogs. Okay. And then the final slide for here is what it does, what it doesn't do. And I think I hit on a lot of these so far. If there's anything else. The one place that we've looked at this as oncologists is if we have a dog that has obviously a full workup, gets treated, is in what we call remission, meaning lymph nodes are normal in our measurements. We can use this as a really sensitive way to figure out if they're truly in what we call molecular remission. It's like a whole lot of debate about doing that. They're probably not in molecular remission when we finish the chemo protocol, but how long do you keep going, right, with chemo? But this is definitely, this post-treatment follow-up is something we can do, specifically if I have a cytology that's possible lymphoma or emerging lymphoma or relapse lymphoma, then I will next recommend usually PAR. What it can't do, I mentioned, can't provide subtype. The big limitation I'd say of PAR for everyone is if you want to determine a new diagnosis of lymphoma to determine T cell or B cell, PAR will tell you just T cell. It won't tell you T zone or the bad T cell. So again, I do get, cases that are coming in really down about having a T cell lymphoma dog, but sometimes it just doesn't fit the picture. Like they're completely normal, incidentally diagnosed. I may recommend flow at that point to diagnose T-zone, which would be, again, the one that I would monitor, not treat. So that's really, I think, been changing our practice quite a bit. Again, giving people good news is always a nice thing in oncology. So, and then the other thing to keep in mind when you do B-cell lymphoma PAR is that plasma cells are also B cells. So if you get a B-cell clonal result, it could be plasma cell. Again, you really have to look at the cells under the microscope to figure out if they look like lymphocytes or plasma cells. And then there is false positive options. I think I've yet to have this, even though in North Carolina we had a lot of Ehrlichia. You can technically get a false positive in these dogs. So certainly the location fits to test them for infectious disease. That would make sense. And then there's also the possibility of a false negative. Again, I feel like the flow cytometry lab is good about telling you what they think the problem was, because if you were very suspicious and it's not clonal, that could be any of these reasons. These are, again, just the latest reasons I've heard. Sometimes there aren't enough cells. Sometimes they're natural killer cells. That would be like another weird type of lymphoid cancer. Sometimes it's just a mutated receptor and we don't have the right primer. So this is something they're continuing to work on their primers for PCR. And then I haven't yet had, I think, this background noise problem, but it definitely can be something that they will comment on. My take home point then about PAR, and I guess I will say this from experience, that submitting the PAR without a cytologic suspicion of lymphoma can be a little bit dangerous because it could be technically not lymphoma. So also, again, I feel like if I had to choose for a dog, I usually do flow cytometry, and that's because now we can determine prognosis better. So that's sort of the route I go. But again, there's definitely just different circumstances where you may recommend PAR or also just a lymph node biopsy. And then I just wanted to provide some resources for this. Again, that's the issue I think works really hard on this. They have a ton of samples from all over the place and they do a lot of good research about it, always changing. If you go to this website, you can click on each test they do. And again, I feel like it's kind of answers the questions that you have. A lot of the information I provided is from this website. I also like this because sometimes I have to think through, what would be the next best test if I'm suspicious of lymphoma, but I didn't confirm it. So some of the things I'd highlight, and I don't know how much you guys are doing this, but we get a fair number of mediastinal masses. It could be lymphoma, it could be thymoma. It's a hard place to sample, obviously, but we do cytology on that. Cytology is not always super helpful, so flow cytometry is actually a definitive diagnosis of thymoma versus lymphoma. I'll show you an example of that one. Another one I would say, again, I mentioned already, if the flow results that you send in are not diagnostic or equivocal, they will tell you we can just add the PAR on. So that's nice. You don't have to do more sampling. I mentioned histopathology can be submitted for PAR. Lymphocytosis in the blood, especially in cats, can be submitted for flow. This is helpful to diagnose leukemia in cats. And then the other one is plasma cells and plasma cell cancer. We don't typically we do PAR, but we don't have any flow cytometry antibodies. So yeah, really helpful. I think they're always updating it, learning more. So that's my takeaways about dogs. And again, any questions about this ever, you can always consult with me, or if we're referring, I'll talk about with the owners at that point. But I do offer a fair number of those tests depending on the case. You may ask, what about cats? So we unfortunately don't have a lot of information. They are their own separate animals there. So it's common though that we just don't have good antibodies for flow cytometry. PAR in general is used more commonly. There are a few instances that I already highlighted that I would prefer one or the other, but like cat blood with a lymphocytosis, a lot of times it's reactive, but the recommended test is flow cytometry. And that's because it can tell you whether it's like a chronic lymphocytic leukemia or again, an acute one. That's often based on the proteins on the cell surface as well as the cell size. And then in organs, this is again pretty common for us, lots of GI lymphoma, spleen, liver. Again, I think PAR is usually just recommended on that cytology slide. Part of it is just, yeah, flow is sort of limited for us. And then in at least our current practice, Dr. Coleman does a lot of scoping on cats with GI lymphoma. Sometimes the histopathology of those little tiny endoscopic biopsies are not diagnostic or definitive, but they're suspicious. So we often are doing PAR on those or requesting PAR on those. So that's often how we get the diagnosis as well. All right, so case examples. I think I already hit on how important T-zone lymphoma is for everyone to recognize, but this would be an example of a dog coming in with enlarged lymph nodes. We can have a suspicion it might be T-zone based on the cell appearance. And I don't always hang my hat on that, but this is a good example of these mirror handle or tail-like projections. We submitted a sample from the lymph node for flow cytometry. There's a specific pattern on the flow cytometry. Usually they lose this CD45 protein. So that would be diagnostic for T-zone lymphoma. So for them, it's pretty easy to do this test and say it's T-zone lymphoma. So a much different prognosis. And then another example of thymoma. So for aspirating this, sometimes cytology is difficult to figure out if it's lymphoma or thymoma, probably because most of the cells are lymphocytes. But if this is not confirmatory on cytology, then this is the way to diagnose it on flow cytometry. So if you submit that same or a sample for flow cytometry, this is an example of the flow cytometry results for different mediastinal masses and how they look different. So again, the characteristic cells they're CD4, CD8 positive. So this is something in the report would tell you this is diagnostic for thymoma. Okay, and then lastly, to put it all together, this is a little bit deep diving into like what I do in my life, but so if we have a case of a dog presenting with generalized peripheral lymphadenopathy, as such on this picture, I'm always going to start with cytology. That's just how most of us do it. It's very, diagnostic for large cell lymphoma. So that's what this dog was diagnosed with. They will often, the pathologist will tell you it's, bottom line, hopefully consistent with lymphoma. And then I'm always looking to see what is the cell. This obviously it's usually going to be intermediate to large cell, but making sure it's the aggressive type or the high grade type. So most commonly we see diffuse large B-cell lymphoma, but I can't determine that without more testing. Often owners will elect to do flow cytometry first, as I mentioned, for B-cell or for just detecting B-cell or T-cell. This case was when they look at the plot of the cells, all these cancer cells in red are positive for these B-cell markers. So that test confirmed B-cell lymphoma. And then it did tell me a little bit about the size of the cell. So one note about flow cytometry is the cells are looked at as like a 3D model. So when you talk about cell size on flow cytometry, it's a little bit different than cytology where they're flat, right? You're looking at flat cells. So this said small cell doesn't quite fit with intermediate to large cell on cytology. So I'm wondering from this case, maybe this dog doesn't have the aggressive lymphoma, maybe it has a low grade small cell variety. The only way to really know for sure is in this case where that's kind of conflicting results is to do a lymph node biopsy. And in this case, this dog was diagnosed with a low grade lymphoma. They still couldn't quite tell you. This is where it's a little bit tricky to say. But what we did find out is that based on all of the histopathology data, and I'm not going to go into any, the architecture of the lymph node, they felt comfortable ruling out the most common type, diffuse large B cell. So again, this is an example of if this is the dog, it's hopefully feeling well too. I might offer a different chemo protocol for small cell or low-grade lymphoma. The other helpful part about histopathology, of course, is that it provides mitotic count. So this pathologist noted mitotic count was extremely high. And again, I always think about too, the dog, how's the dog feeling? If it's small cell, but behaving aggressively, I'll probably treat it like aggressively. So for this dog, we did offer the CHOP protocol and not the chlorambucil protocol based on this kind of information. But it just goes to show you, yeah, kind of the confusion with all of these different tests, but they do actually complement each other in some ways. All right, so that's my mast cell lymphoma, sorry. The other sections are fairly fast, so I will just start now to have you shift gears to mast cell tumors. Again, really common type of cancer that we see in cats and dogs, and mostly going to focus on dogs in this. So I wanted to just introduce the mast cell tumor prognostic panel. Has anyone ever used it or been recommended to use it? Usually it's when you remove a mast cell tumor, submit it for histopathology, they may offer it. Okay, so I haven't actually ever submitted one myself, and that will go to my take home as we don't use it very much, but I do have vets ask me about it because it's been maybe recommended. So what it includes is the cell proliferation parameters. You've probably heard of some of these, Chi-67 and AGNORs. They are, very helpful to determine aggressive behavior of tumors. And then the whole panel does also look at the c-KIT mutation. That's a PCR test. And then KIT immunohistochemistry. I'm not going to spend too much time on the bottom two, but I will briefly cover why they could be helpful. So when is this recommended? Based on, at least went to the Michigan State website where a lot of these panels are run. They recommend doing the panel for all low-grade mast cell tumors. Again, it's not technically what I do. When it's in italicized print, it means this is the recommendation, but it's not necessarily what I do. So why would we do that? This is the logic behind that. So ultimately, there's not just one single way to figure out how aggressive this mast cell tumor will be. Although tumor grade, mitotic count are really important, they feel like the combination of these tests can be helpful to look at proliferation of the cancer cells. So we don't specifically know, but there are some reasons why we would do this test, and I'll give you the ones that I'd recommend it for. But specifically thinking about like a low-grade mast cell tumor, a tough location, it's incompletely excised. I often recommend monitoring it if it's truly low grade, but maybe this could be another test to just make sure it's not aggressive. So they give lots of algorithms on here. I think maybe it's easier to figure out, but so again, in one way, obviously if it's a mast cell tumor removed with a clean margin, you're going to monitor. If it's dirty, we have to consider what's the grade. If it's high grade, of course, we're gonna try to do a scar revision or recut it. If it's low grade, this is where, again, some of these are hard to predict. So this test could potentially help you feel better about either doing monitoring or going back for more surgery. The other way to think about it is, again, how aggressive is it? Will it spread? So they have, again, an algorithm on here that I'll just mention. And same kind of thing. It's a lot of these, what I usually consider is like the grade 2 mast cell tumors. Some behave well, some don't. And they always feel like I get burned once in a while on grade 2s. So in my experience, I feel like where most oncologists are recommending this. And again, if you get requested to send this in or add this test on to your histopathology, I just would think about, is it really needed? I don't actually know the cost of it, but basically more information is always better, but I don't think it's always needed. So when I use it is if it's a grade 2 mast cell tumor, specifically if the mitotic count is that borderline. For us, over 5 to 7 is concerning. So if it's like a grade 2 low grade, but it's mitotic count 5, I'd say, well, it's starting to make me more worried. The other place to use it is subcutaneous mast cell tumors. So remember, these are not really graded. They will tell you pathology, usually characteristics of low grade or high grade, but for some of those, it is hard to predict what they're going to do. And then the other way would be if you have a low grade tumor on the histopathology, but it didn't behave like that, like it was a rapid growing ulcerated tumor, it just makes you worried it's going to come back. maybe this would be another test to decide if you want to do more surgery or not. And again, this is my goal is just to make sure we're not missing an aggressive tumor that should have had more treatment. So take homes for me, again, this is definitely what I was taught and I still stand by it. Tumor grade, so what you get on the histopath report, the mitotic count, and the biologic behavior are definitely, to me, the most important factors in deciding how aggressive a mast cell tumor will be. So just a reminder of ulceration, again, bad prognostic factor. I treat it like a high-grade tumor. This test is certainly, I think, provides more information, specifically Chi-67, but again, I don't know that there's enough proof that it definitely improves outcome or, overall. Probably hasn't been studied enough in that way either. So that is mast cell tumors. And this is just what's sort of put on the page when you order it. The other side of this panel, the other two factors are going to be kit analysis. Again, less important for you guys, but for me, honestly, I don't do this a lot either, but if you recall, there is c-KIT mutation in 20 to 30% of mast cell tumors in dogs. This is where it's important, is if we find out that it has a c-KIT mutation, they may respond better to Palladia. So honestly, it's just not panned out that we should test for this either, but we can. It can help direct therapy, but again, I think it's still not necessarily proven. So ultimately, all of these things have been studied. I would just say it's hard to make a strong case for doing the panel on all low-grade mast cell tumors. And again, one last algorithm, if you do detect a mast cell tumor with this c-KIT mutation, it's positive. Sometimes we skip and just do Palladia versus vinblastine, vinblastine is the most common mast cell tumor chemotherapy. There's also this KIT pattern. They look under the microscope at KIT patterns. One has been more aggressive than another. So if it's this KIT pattern, they recommend, Palladia again. All right. And then one case example for using this is actually the one time I've looked at the prognostic panel. And it was a primary vet who had done it. So I had to interpret it all. It was very helpful though to go through this case. So this was a 6-year-old female spay lab with a subcutaneous mast cell tumor, kind of on a tough location by her pre-scap area. And it was subcutaneous. So already expecting not to really get a grade, but we definitely have this description. In-house cytology confirmed a mast cell tumor. It was removed with the primary veterinarian, submitted to IDEXX for histopathology. So there's some pictures. It was confirmed to be subcutaneous origin. The good news is it was completely excised. So we felt pretty good about these margins. Wasn't reported to be aggressive growth or anything. It was just noted and kind of unchanged. As you recall, just maybe a review, if you do remove a subcutaneous mast cell tumor, what we're looking for, because they're not going to give you grade 1, 2, 3, they're going to give you some other information. And usually a pathologist will talk about what these mean. This was a case that these were all the good things. We're all looking for the good parameters here. For subcutaneous mast cell tumors, less than 4 is good. Circumscribed is better than infiltrative for the growth pattern, and multinucleation absent is better than present. And then they did provide vascular invasion. So these were all good things, would suggest that this is a low-grade subcutaneous mast cell tumor. Usually I would just say, we're going to monitor this. No further treatments needed. And for me, monitoring is every 3 months, doing a physical exam. Of course, I did offer lymph node aspirates and staging for this dog, but pretty low chance of that with a low-grade tumor. They did, again, already order this before I saw the dog, so I interpreted this with the owner and the primary vet. I don't have all the numbers. This is not something I've ever memorized, but this was done through IDEXX, so they added it on. It provides all those things I just mentioned, KIT pattern, Chi-67, AGNORs, and then this AGNOR Chi-67 product. So they tell you what the cutoffs are. Obviously, if it's over a certain value, it could be more aggressive. So again, fortunately, this dog had all the low good numbers, and it seemed, again, less concerning for aggressive behavior. So in this case, maybe not needed, but if it's more reassurance, we have more things to look at, more data. And then they did do KIT evaluation. So again, if in the future this tumor came back to burn us and we couldn't remove it or it spread, if this was positive for c-KIT, I may recommend Palladia first over vinblastine, but not the case for this one. Okay, and the last section I have is on bladder tumors. Yeah, so I don't have any pictures of TCC unfortunately, but as a reminder, there's a BRAF test or BRAF test that Antec supplies. Again, it's pretty widely used, and I'm sure you've been asked to use it or used it before. But BRAF, just as a reminder, is one of these proteins that is key for the MAP kinase signaling pathway. So basically, we're looking for the BRAF or BRAF mutation. And in people, this was all started there. There's a mutation that has been determined to be a driver, so an important mutation in a lot of these different cancer cells. That tells us we can target it and hopefully have a good response. We looked in people, I should say me, some very smart people looked in dogs and specifically found this similar BRAF mutation in the majority of transitional cell carcinomas and prostatic carcinomas. So the good news is, yeah, we have this target now, and also what they've done is exploited that, and we now have a test for detecting this mutation in bladder tumors. The really nice part is it's just a urine sample. So basically collect a urine sample because we presume there's cancer cells floating around in the urine, as the annoying part is about this cancer in bladders, and it's very sensitive. So we only need a few cells, like not very many cells to detect this. Very, very easy to do. I do think the price seems higher to me than normal lately. I think it's $300 or $400, but it certainly is so much easier than scoping a dog to get a biopsy if we can. Some dogs and cats, of course, we can't do a cystoscopy. Traumatic catheterization sounds bad. That's also a way to get cells. And then we just generally don't recommend doing fine-needle aspirate due to the risk of tumor seeding, although sometimes that does have to be considered. So very well-established test. Still questions about when we use it. So the good part is that the Cadet BRAF test from Antec and this second test called the Cadet BRAF Plus can identify 95% of TCCs in dogs. So it's very sensitive. Again, this is right from the website, so just tells you what they're quoting. You may have done this test and found out that the first test, the main one, is negative or the mutation's not detected. They then determine in the sample they have if they should add the plus test. I've not seen that be an added cost, and they will automatically determine if that's a good next test to do. And so then of the percent of TCCs that didn't get detected with the first test, it says they can detect 2/3 more. So it's sort of like looking for just more mutations or more genetic signature of this cancer, but we're not really privy to what those are. When to use the BRAF test. Again, I put in italics because this is what they recommend. I will give you again my kind of personal opinion. Obviously, if you've got a pet with urinary abnormalities that are suspicious for a thickening or mass in the urinary bladder, and evidence of that, this is the key, I think. This could certainly be signs from a UTI as well. So we certainly would want, before submitting this, some kind of abnormality of the bladder wall. That's the obvious one that we use it for. Sometimes we get like a traumatic catheterization, or we will do a urine collection, spin it down, look at the cytology. That's always I think always a good starting point. Before BRAF, that's how I was trained, is we started with urine cytology, but sometimes it's not definitive. So this would be a nice way to confirm it with a sensitive genetic test. Another use for this test is early detection in high risk breed dogs, like Scotties are the big ones. Again, I haven't used this yet, but I don't think it's wrong to do that. It's certainly easier than doing an ultrasound every however many months. Again, Scotties are like the poster child for TCCs, but I think the cost is actually similar to an ultrasound. So that's the one I think disadvantage. Maybe that's why it's not been done as well. So the other things to do, if you've got like a UTI that is very resistant, you're suspecting there is some kind of early TCC going on without a mass. Again, I've not really used it for that, but it could be considered. And then again, they recommend that you can use it for treatment of bladder tumors, kind of like I mentioned with the PAR. We're looking for kind of minimal residual disease. And I just think that the problem with this is we don't really ever get a bladder tumor to completely go away with chemo. So to me, we're just gonna, again, look at the ultrasound to see what's happening. I do have a case example of when you may run into this. So 11-year-old, I think she was a female spayed miniature poodle mix. This was the ultrasound taken, I think the primary vet, I found this, and then Dr. Carver did an ultrasound for us. Very convincing bladder mass on ultrasound. She had urinary abnormalities. We submitted a BRAF test and it read out as no BRAF mutation was detected. Then they definitely give their comments based on their current data that this is, usually we find this in 85% of cases. So there is a chance that this is a non-BRAF TCC in 15% of the time. So that's a little frustrating because we still don't really have a definitive diagnosis, but there are some things to think about. So like for this owner, I usually describe these different scenarios. So, you know, we're always really hoping that it is positive just so we are done with the diagnostic, but there are some possibilities for that negative result. One is there just wasn't enough cells. Usually the lab will tell you that if we should collect more urine. It is usually a pretty big volume of urine, but I think it's unlikely that this is the case. The number two is that it is that kind of unusual non-BRAF associated TCC. Unfortunately, the only way we're really going to know that is to do sampling of the mass to see if it's actually the cancer cells look like that. And then the third would be that it's not a transitional cell carcinoma and it's something else. So other tumor types are of course less common in bladders of dogs, but that would be carcinomas of some other type, rhabdomyolymphoma, hemangiofibroma, or maybe it's an inflammatory polyp or granulomatous lesion. Again, for this case, kind of the things I offered are sampling more. So like traumatic cath. She was a really small dog, so cystoscopy for biopsies was not going to be easy, or close monitoring and trying again. That's another option too. She ultimately was treated Proxicam for like, I think it was at least 6 months and followed up with the primary vet and actually couldn't find the tumor anymore. And it's the first one I've ever seen actually go away. So I don't know if it was, my suspicion it was a benign mass. It didn't look like a hematoma or anything, but I don't know, that was a very unusual case. So in that case, I trusted the BRAF test, I guess. We didn't start chemo or anything like that, but they elected to monitor. And yeah, urinary signs normalized as well. So that was an example of that. My take home then is also don't completely trust the BRAF test. So that on the opposite side of things, you can get a false positive. There's lots of discussion with oncologists about this. For me, I do still prefer cytology or histopathology for definitive diagnosis, but yeah, not a lot of people are going to do that if the BRAF's positive. I do at least want to make sure I've ruled out a UTI, inflammation, and there should be some kind of, again, mass or thickening in the bladder before I feel comfortable treating with chemo or whatnot. So that's sort of how I use it, but some people are more picky about getting a cytology or histopathology diagnosis. And then again, we always wish there was a BRAF test for cats. So because veterinary and human cancers have similar mutations as we saw with BRAF, it makes sense that cats would also have something we could detect or target. So they did look at BRAF in cat, like a variety of cat feline tumors, and it just was not frequently mutated. So it doesn't look like we can use this test for cats at this point. But hopefully we find like a different mutation in cats that we can detect it. But bladder tumors in cats are less common, but they're still frustrating. All right, so I think if I have a few more minutes, and I'll answer some questions. I just wanted to get you at least starting to think about this test. I think it will be really marketed widely to everybody. And the last Veterinary Cancer Society meeting I went to, there was an IDEX rep there that did a nice talk to us, and we're kind of getting information as it comes out. But my understanding is it's going to be available if it's not ready available very soon. And so this is going to be a blood test that you basically perform on potentially your patients to detect lymphoma early. There's not a lot of science given to us yet about what they're testing for, but this is again what's been said. It's a multi-omic discovery approach with biomarkers. There's tons of research in this, different companies are trying to find these tests. Obviously, detecting cancer early is really, really important. What to do with that information maybe prove a little challenging for us, but this is definitely going to be something you hear about, I think. Only dogs, only lymphoma right now, but the numbers they're giving are that it is very sensitive and specific. What's really maybe advantageous is thinking about just like all the patients that come through Red River. If there's a sick dog, maybe he doesn't have enlarged lymph nodes yet, but you can run blood work and add this test on, and it's relatively cheap. And if it's positive, we're now going to be worried the dog has lymphoma without even, having enlarged lymph nodes. So again, a little bit dangerous. We want to really trust this test, but ultimately we're going to have to go forward and find the cancer versus, completely trust the blood test. So really interesting, but also we're gonna have to figure out how to manage it. Again, the very basic information I have is it's sensitive, it's specific. You can actually get the results in 2 to 3 days. It's just blood. And again, this is what they were quoting from IDEX as well. It's like $15 to add it, just really, really inexpensive. And then the other kind of cool part is it can tell you B or T cell. So if you get this positive cancer signal in the blood, if in some cases they can, I guess, tell you B or T cell right away. Again, for me, I'm always going to wonder, is there T zone? Is there T cell? And not make too much of that. But yeah, so very interesting for us. And then how else they might market it, again, particular to you guys, is for like screening at-risk dogs. So similar to like the BRAF test for Scotties, these dogs are at risk for lymphoma. So any of these over 4, could you add it on to annual blood review or annual wellness blood tests? Again, I feel like it might freak people out if we get a positive, but then the next step is probably going to be looking, like doing imaging, doing lymph node aspirates, looking for the cancer. The other thing we've asked is, can we use it for monitoring remission status? So again, if let's say we get this dog in, he has lymphoma, we're treating him. Can we use this test after they're in remission, periodically to see when they're coming out of remission? They haven't yet done that, but that would be, obviously really helpful for us too. It's just a blood test. Any questions first, but thank you guys for listening. And I think I have just enough time for a few, always too, if you have any questions, even that you're referring or not referring to us for just, I'm always at least available by email, or I'm there Tuesday through Thursday for phone consults. So you can always ask me questions as well. Okay. Backwards. Okay, well, thank you. Again, if you have anything comes up, let me know. Yeah. Yes.
Well, I'm gonna get Dr. Sets,
Take it off. To stop share to do this, but anyway, I'll leave it up.
we'll let Ken work it out.
I mentioned to the audience. in the chat function, on the screen, there were no questions, but yeah, but that they could hear. Yes.
Okay. While Ken's pulling up Dr. Brissett's talk, I'll go ahead and introduce her. Dr. Catherine Brissett, or Cat Brissett. She's come all the way from Grand Forks. But actually, she has been all over the country. She started her BS was from Louisiana State. Then she got her master's in University of Vermont in bacteriology, right? Microbiology with Dr. Paula Fives Taylor. And then she got her PhD in pathobiology at University of Washington with Dr. Sheila Lukart. And that's how I met Dr. Brissett, is I was the program manager for the lab where she did her PhD. After that, she did her postdoc work at University of Kentucky, focused on the outer surface adhesions and regulation of virulence factors in the Lyme disease spirochete Borrelia burgdorferi. Then she came to University of North Dakota as a professor, and she's been there ever since. Her lab focuses on bacterial host interactions and is interested in those bacterial and host factors that impact colonization and immune responses in the central nervous system. We're very excited to have Dr. Brissett here. She is an expert in her field, so I hope you guys enjoy her talk. Oh, and then if you have questions, the Zoomers, if you have questions, please put them in the chat and we'll be sure to ask Dr. Brissett.
I think I'll hold the microphone. Can you hear me okay? Awesome. Well, thank you so much for having me. I will preface this by saying I am not a clinician. I am a basic scientist, but I'm hoping to give you some valuable information about Lyme disease, particularly in North Dakota. So I'll give you a brief overview about Lyme disease and the bacteria that causes Lyme disease. And then I'll kind of walk through what Borrelia species are common, what's here in the state, where the endemic areas are, the most common clinical manifestations of the disease. I'll mostly talk about dogs, but I'll touch on horses as well. What diagnostic tests are available, what treatments for clinically ill, what testing we should be doing for healthy animals. I'll talk about prevention. And then I also surveyed a few of my veterinary colleagues and friends in Grand Forks and asked them, what would you want to know if you were coming to this talk? So I have some of their questions that I'll answer, and then I'll take questions from you. So Lyme disease is the most common arthropod-borne disease in the United States, at least in humans. But this is a disease that's actually endemic not only to the US, but also Europe and parts of Asia. And so in the 1970s, there was a cluster of juvenile rheumatoid arthritis cases around Lyme, Connecticut. And some clever detective work figured out that some of these kids had this weird rash before they developed arthritis. And they also found an association with tick bites. And what's really interesting here is that on these two sides of the Connecticut River, west of the river, they didn't see any cases. All the cases were east of the river, and there was a really good correlation between reported tick bites in patients and pets with ticks. And so it was really suspicious that this was a tick-borne illness. So Willie Bigdorfer at Rocky Mountain Labs out in Montana isolated bacteria called a spirochete from these ticks, and then it was subsequently isolated from skin, blood, and CSF of human patients. So the oldest known B. Bigdorferi infection, though, so this was, in the late 70s, is actually this guy. Does anybody know who this is? This is Otzi, the Iceman. He was the mummified guy found in the Alps. And when they sequenced his DNA, he actually was infected with Borrelia burgdorferi. So as I said before, this is an infection basically that's across the Northern Hemisphere. So we have different foci in North America, but then throughout Europe and Asia as well. So what is a spirochete? So these are bacteria that are really different than a lot of the other bacteria. It's a really ancient lineage of bacteria. And so they have this outer membrane and then this inner membrane. So this is sort of the main part of the cell here in yellow. And they have flagella for swimming, but instead of being on the outside of the bacteria, like many other bacteria, they're actually inside the bacteria, and they sort of wrap around that cell body, and that's what gives them that particular shape. So spiral, Spirochete is Greek for hair, so they look like curly hairs. So these are important human and veterinary pathogens. So I'm sure you're all familiar with Lyme disease, but also leptospirosis. Spirochetes cause syphilis, a variety of relapsing fevers, as well as some intestinal issues. I also want to point out that these bacteria with the Borrelia, they don't have LPS in their outer membrane. That's the endotoxin that causes a strong inflammatory response. What they do have is a lot of outer surface proteins that are anchored in this outside membrane, and that's kind of unusual for bacteria. They have a lot of these, and these are what prompt the immune complex formation that you see in Lyme nephritis. Is reaction to these outer surface proteins. So in nature, adult ticks will meet and mate on large vertebrates like deer, and then they'll lay their eggs in the fall. Now, deer do not get infected with Borrelia. Their serum complement actually kills the bacteria. But deer are important in the cycle because this is where the adults meet and mate. The female will lay the eggs, and then in early summer, the larva will hatch. And they go out and seek a blood meal. And they typically feed on small mammals or birds. And if that mammal or bird happens to be infected with Borrelia, the tick will acquire it at that point. Then they overwinter and molt into their next life stage, still infected. And then these nymphs will emerge in the spring, and they'll seek a second blood meal. If those nymphs happen to feed on an uninfected small animal or bird, they will pass the infection on. So this is how this is maintained in nature. And then the nymphs go on to molt into the adults, and the cycle repeats. So the bacteria really don't want to be in us. These bacteria don't have a lot of the traditional virulence factors. They don't make toxins or anything like that. So the disease is really about the immune system's response to the infection. And where we and our pets are most at risk is here in the with the nymphs, when the nymphs come out. And that is because these ticks are they'll feed on anything. And, late spring, early summer, we're all outside, our pets are outside. This is where your chance of exposure is greatest. So the bacteria don't want to be in us or our dogs or our horses. We're all dead-end hosts. But the small animals and birds that these ticks normally feed on and pass the bacteria to, they've evolved a long time together, and so those small reservoir animals, they don't get sick, but we do. I also just want to point out that, when you see a fed tick on a dog, they're really big and fat and gross, right? But when these ticks first bite you, they're tiny. So size of a poppy seed. So there's 5 ticks here, 1, 2, 3, 4, 5. Tiny, tiny. So it's really difficult for you to see that on you, much less on your pet, which is why tick prevention is so important. So I'll briefly run through some of the human clinical manifestations because some of these overlap with pets. So people can have no symptoms. There are probably some people who get infected and never have any symptoms, and that's also going to be true with dogs. People will get flu-like symptoms, and then they can get this erythema migrans rash, which is just a big, they call it a bullseye, but on most people it doesn't actually look like a bullseye, but it's a very, very large rash. And this is how these clinical signs are really how Lyme disease is diagnosed most of the time in people. So if you don't have that rash, and a proportion of people never see that rash, the diagnosis gets missed. But obviously you're not going to see this kind of rash on a dog. People can also get carditis, where you get inflammation of the heart and you get blockage of the atrioventricular node. People also get neuroborreliosis, so they get inflammation of the meninges, so meningitis, and you can get cranial nerve involvement, peripheral nerve involvement. So this woman here has Bell's palsy, where you get a partial paralysis of the face that resolves on its own. And the big one here is arthritis. So in the United States, this is the most common later manifestation, and it's a really massive infiltration, usually large joints like knee, but it can be other joints as well. And this can be a recurrent arthritis. So you have the arthritis and then it resolves and then it comes back. And this again is going to be the most common later manifestation that you'd see in dogs. And then in people, even after treatment, there are some people who continue to have long-term symptoms. So fatigue, muscle and joint aches, as well as neurocognitive issues. Whether or not that occurs in dogs, we don't know. But so Borrelia can be divided into, the Borrelia gene can be divided roughly into two large groups. One is Lyme disease and the other are relapsing fever spirochetes. And these are really, they're spread by very different ticks that have very different lifestyles. So the Lyme Borrelia are spread by these hard ticks that tend to live in temperate forested areas, whereas the soft ticks tend to live in things like dens or burrows or caves. The hard ticks have a 2 to 3 year lifespan, whereas the soft ticks can live for decades, just sort of scary. And they have very different feeding styles. So soft ticks, since they tend to be in a burrow or a cave or a den, they can feed whenever they want. So they attach very quickly, feed for minutes, and pop off. Whereas the hard ticks attach for days. So this is why if you're in an area where there's lots of ticks, doing a tick check every day is really important, because it takes a while for that tick to feed. And if you can catch them early and pull them off, there's less chance that you're going to be infected, because the spirochetes are in the midgut of the tick and they have to travel up to the salivary glands to get injected in you, and that takes some time. Another important point is that hard ticks are generalist feeders, where soft ticks are not. Soft ticks tend to, live in a den or burrow or cave, so there's usually a particular host that they like to feed on. Whereas the hard ticks, they'll feed on anything. So that's why we're sort of at risk. They're not just going to go after those deer mice and robins. They're going to feed on whatever's available. Dogs, cats, lizards, anything, any vertebrate. So there's a lot of there's this big umbrella of Lyme Borrelia species called Borrelia burgdorferi centu-latu. But in the United States, Lyme disease in dogs has only been associated with Borrelia burgdorferi, and there's a bunch of different strains and subtypes based on outer surface protein genotyping. The tick vector in our area is going to be Ixodes scapularis. So this is in northeastern mid-Atlantic, upper Midwest, as well as adjacent areas of Canada. On the West Coast, it's going to be Ixodes pacificus, but the disease, everything is pretty much the same. So Ixodes scapularis can also transmit a lot of other pathogens like anaplasma, babesia, Powassan virus. And in the upper Midwest, they can also transmit Borrelia mayonii. So this is a fairly new Lyme-causing species that was identified. But in people, it has some different characteristics. So people have more spirochetes in their blood. They have some more rashes. There may be an association with more neurological effects, but the numbers are really low. So we don't know if that's something that infects dogs, but it likely does because it's very similar. Ixodes can also transmit Borrelia miyamotoi. So this is actually a relapsing fever bacteria that's vectored in these hard ticks, which is really weird. It causes in immunocompetent people, it just causes sort of a self-limiting relapsing fever where you get a fever and it goes away and you get another one, kind of like malaria. And we don't know if that affects dogs, but it is in our area. So our endemic areas, so in the United States, the Northeast, Mid-Atlantic, Upper Midwest for people. And then for dogs, you see that the map is really pretty much the same: New England, Mid-Atlantic, and Upper Midwest. And then if we look at North Dakota and the surrounding areas, you see in Minnesota, a really high risk through most of the state. Some of these areas here, the gray is supposed to be low prevalence. I don't believe that. I spent a lot of time in northwestern Minnesota, and there's just no data. And that shows you some of the limitations of some of this surveillance, is that there's a lot of places where we just don't have data. And then in North Dakota, Red River Valley, these ticks are established here. So this makes sense. I don't know what's going on here, why we see cases there, but. And then this is Manitoba, so right above us. And again, along that, the Red River, a lot of cases there. And then there are some established populations that have been seen in the last couple years in South Dakota. And so there's a few hot spots in South Dakota as well. So the takeaway is that it's spreading westward. And in fact, this paper just came out a couple months ago, and they found an Ixodes tick in eastern Montana. So finding one tick on a dog, that doesn't necessarily say that they're established there, but I think it's something to be aware of, that we could be seeing westward spread. So in places in North Dakota where maybe you wouldn't be worried about Lyme disease, like in the western part of the state, maybe it's something to keep an eye on. So most common clinical manifestations in dogs. So most seropositive dogs have no clinical signs. When they do have clinical signs, they can be very nonspecific. So like people, like the flu-like symptoms, myalgias, lethargy, they've got fevers. The main manifestation is the arthritis. We have involvement typically of the tarsus and carpus with histological evidence of mild to moderate synovial changes. Neuroborreliosis, which we see in humans and horses, is not as well documented in dogs, so there are some case reports. I've also seen some case reports of carditis in beagle pups, but very limited. So I think mostly what you would tend to see would be either no clinical signs or arthritis. And then, of course, we have Lyme nephritis, which is a very serious and deadly manifestation of Lyme disease in dogs. People generally don't get Lyme nephritis. I think I found 1 or 2 case reports. So there's something really different about dogs that they develop that. So with Lyme arthritis, and here's the only histology that I can reliably interpret, because I do a lot of work on mice and I look at a lot of inflamed joints. You get these perivascular accumulations of plasma cells and lymphocytes in that subintimal space. It's very rare to see neutrophils. I think there's one right there. So you tend not to see neutrophils. And sometimes you'll see some fibrosis as well. Now this one I can't interpret because I don't know kidneys at all, but a really serious complication with dogs is this membranoproliferative glomerulonephritis. And these dogs will have severe, a lot of protein in their urine, low levels of albumin, and signs of kidney failure. And on histology, you'll see a lot of subendothelial immune deposits, so complement, IgG, IgM, and you'll see a lot of necrosis and regeneration. So renal disease is reported to occur in less than 2% of dogs seropositive for Lyme disease. And those antigen antibody complexes against those outer surface proteins are thought to be causative. What about in horses? In horses, neuroborreliosis, uveitis, and cutaneous pseudolymphoma, which that actually happens in people as well. Uveitis is fairly rare in people. Of course, another veterinary cause of uveitis in horses would be leptospira, so that's important to keep in mind. There are cases where horses have lameness or stiffness, but this isn't well documented. And I have horses, and I would imagine the differential for lameness in horses is pretty large. So diagnosis in the horse requires cytology or histopath of the infected fluid. And what about other pets and livestock? So cats may be seropositive for Borrelia, but it's unknown if there is actually any disease in cats. There have been reports of cattle having Lyme disease. You look back at some of the older literature, but I suspect those cattle were not actually infected with Borrelia burgdorferi. They might have been infected with another Borrelia. So we have this Borrelia thuralii. It's a relapsing fever spirochete, so they get to very high numbers in the blood. So if you did a blood smear, you could actually see these organisms. And this Borrelia infects a lot of different ruminants, mainly in the southern, initially mostly in Africa, Australia, and South America. But it has moved into Central America and Mexico, and now we're seeing some cases along the Texas border, so this may be something that's moving north. It's transmitted by a different tick species and is associated with mild clinical symptoms, and the literature I've read suggests that this is not a huge economic loss for ranchers, but if you see something like this in a cow or a goat or a sheep, I would be suspicious that, it's probably not Lyme Borrelia. And the reason I say that is I told you that deer don't get infected and their serum complement kills Borrelia. So this was a study that was done in Europe, and they looked at Borrelia burgdorferi, and they looked at the sensitivity of these bacteria to a complement from a number of different animals. And you see that they're extremely sensitive to complement from cattle. When you come down here to dogs and cats, so that's why cats are kind of a question mark, whether or not they get infected. And humans are very susceptible. Our complement doesn't do a great job of killing Borrelia. So diagnostic tests. Unfortunately, we're kind of stuck with serology, and this is the issue with people as well. The holy grail with Lyme testing is to find some non-invasive test. If you could just take a urine sample, or if you had to do a blood draw, do a PCR or something that's quick point of care. But unfortunately, these bacteria, they spread all throughout the body, but they're present in really low numbers in any particular tissue. So for instance, if I infect a mouse in the lab, at 7 days post-infection, I might be able to find it in the blood. It's kind of hit or miss. So the sensitivity of a lot of these other kind of tests just don't work for detecting this bacterium, which is why in people, a lot of the diagnosis is simply clinical. If you come in with the rash, you're going to get doxy. So all the serology has been based, so all those tests that you send out, the SNAP tests, they're all kind of based on this principle where you have an antigen, in this case, the Borrelia, and you add antibodies from your blood sample, and there's a chromogenic substrate that gives you a signal, and you get a pretty color, and this is a quantitative test. Early on with people, they'd also do Western blots where you take the Borrelia antigens, run them out on a gel, and then transfer that to a membrane and treat with the antibodies from the patient. And then you'd get all these bands. And these OSPs here, these are the outer surface proteins. And you can see those are really highly immunogenic. And so the band sort of gives you an idea of there's particular Borrelia antigens that people tend to, and dogs tend to develop antibodies to. And so, but obviously that's a very clunky and not something most people are going to do in their practice, or whether human or veterinary. So, so you're all probably familiar with the SNAP test from IDEXX. There are some other ones. Most of them are not quantitative. A couple of them you can do point of care. A couple of them you can also detect some other pathogens, which is useful. Detecting acute versus chronic infection, companies say maybe, but I would say no. And that's pretty true with humans as well. So one of the things that's been demonstrated in humans is that you have Lyme arthritis, you have all these bands on the Western blot. 30 years later, a person could still have all those bands on that Western blot. The infections, they were treated, the infection's gone, but people are still making antibodies. So monitoring antibody levels is probably not helpful in following disease progression. Some of these tests might be able to differentiate vaccine versus natural exposure. So if you've had a dog that's been vaccinated, this was from this consensus statement in 2018. Since then, this VetScan test, this just came out a couple months ago. They claim that it's 100% sensitive and specific for differentiating vaccinated dogs from naturally infected dogs. Of course, this is all from work done by the company, so take that with a grain of salt. So if you have clinically ill dogs, doxycyclines, tetracyclines are recommended. You can use amoxicillin. Some of these can be given IV. Obviously, that's not something you would want to do unless you have a really, really sick animal. Frankly, I think 30 days is probably overkill. If a person comes in with early Lyme disease, you generally don't treat for 30 days. That's going to really mess up their guts. Or owners, there's going to be diarrhea. And then, azithromycin, erythromycin, these are not drugs that are used in people, and their efficacy against the Borrelia is not as good as the tetracyclines, so those are things I would avoid. The third generation cephalosporins are really good. Those in people are reserved for treating the carditis or the neuroborreliosis, or some of the later really serious manifestations. And then in horses, tetracyclines are recommended, but there have been treatment failures with advanced neuroborreliosis, and that may be due to the failure of the antibiotic to get to that minimum inhibitory concentration in those affected tissues. The other issue is that if the horse presents with uveitis and then some time goes on and they develop neuroborreliosis, the disease may just be too advanced to treat. But there's some recent research that suggests this antibiotic, which I don't know, but I'm guessing based on the prefix, so that's a third generation cephalosporin, might be more effective than tetracyclines with horses. So the consensus statement suggests screening all healthy dogs in Lyme endemic areas for Borrelia antibodies. I don't know that many clients are going to want to pay for that expense if their dog isn't sick. But certainly if you do have a dog that has a positive serology, you definitely want to screen for the protein in the urine because of the possibility of Lyme nephritis, which is very serious. And if you can catch that early, you have a much better chance of treating. So a big question is, if you have non-clinical, non-proteinuric, seropositive dogs, what do you do with them? So there's pros and cons to treating these dogs. The consensus statement was don't treat, just monitor. Some of the pros might be maybe they have a co-infection. So if they also had anaplasma, it would be worth it to treat. But, you can run that, SNAP test and see if they have a co-infection. So, and then it's unclear if treating these dogs would prevent future arthritis or nephritis because most seropositive dogs have no clinical signs and don't develop any clinical signs. So overuse of antibiotics and the adverse effects of treatment, unnecessary owner cost are things to consider. So tick control, obviously this is of utmost importance because if we can control the ticks, we can control Lyme disease and a lot of other infections as well. So I am currently stuck with my dogs using Frontline because my vet would not prescribe the isozazolines. I'm going to show you some data that we've done with field work with these drugs, and I'm really excited about these drugs because of the frequency that you can give them. I'm going to show you some data though that at least in wild mice, the tick killing efficacy lasts longer than that. So one of the questions I got from a veterinarian is, what kind of damage is happening to joints, kidneys, and other organs, even with subclinical infection? I would say probably none. Because this disease is immune mediated, if you're not seeing symptoms, there's probably not a damage going on. So what happens in reservoir hosts, and even in laboratory mice, which are a completely different genus from the wild mice. So they're radically different and they've been bred forever. What we see is that in early infection, if you don't treat, you get high numbers of bacteria in certain tissues, and then they kind of plummet, and then they stay at this low level. And if you don't treat, your immune system is never going to clear that infection. But what the bacteria want to do is just be at this kind of low level, and that's what they do in the reservoir hosts. So they're not replicating to large numbers, they're just kind of hanging out, and that's what they want to do, is just sort of hang out. So I think in a lot of the subclinical animals, their immune system is keeping them right at the right level, but not overreacting to the infection, and so you're just not going to see clinical damage. And then they asked, I believe in dogs, it takes 2 to 5 months to get clinical disease. Is that still the case? Yes, particularly with the arthritis. So, the time frame that you're going to see that is going to be some months after that initial tick bite. Another question was, are there any more accurate diagnostics to evaluate whether there's clinical disease if you get an initial negative on the 4DX testing? Unfortunately, not really. So antibody production timeline varies. This is a big problem with people as well. Somebody has this rash, they come in, they do the serology, they don't have any antibodies, so they get a negative test. And you're going to see the same thing potentially see the same thing with dogs. So part of the problem with Borrelia infections is that this early IgM response, normally you would think within 2 weeks you would have a good response, but it's kind of delayed in a Borrelia infection. And then the IgG is much slower to ramp up. And so there's quite a long window where you're just not going to see antibodies. So another question was, have there been changes in vaccines to stimulate longer immunity? So I have a few different points here. One is that there are a lot of problems with long-term immunity with Lyme disease. So you can get infected again and again and again. And if you aren't treated, you're not going to clear it. Your immune system will knock the bacteria down to a certain level, but won't get rid of them. So these are bacteria that are extracellular, and so those B cell responses, antibodies, are really important in keeping those numbers low. But in Lyme disease, what happens is that that class switching from IgM to IgG isn't really efficient, and the IgG doesn't, you don't get good maturation and longevity, good class switching. And you also get a rapid collapse of the germinal centers. And what this means is that you make lots of plasma cells that pump out antibody, which may not be the most effective antibody. And you don't get any memory cells. So that's why you can get infected again and again. You can also, so IgM should go up, and then you class switch to IgG, and IgM should go down and go away. But what happens in Lyme disease often is you get these waves of IgM, and you can get strong and ongoing IgM levels, but IgM doesn't penetrate tissues well. So if you gave an animal prophylactically anti-Borrelia IgM, you could prevent infection, sort of a passive vaccination. But in a natural infection, it just doesn't penetrate tissues well, and it won't prevent the dissemination of the bacteria. So I have a colleague at University of Tennessee, and she published this earlier last year, and this was an intranasal vaccine, and they were able to show protection beyond 1 year. So right now, you got to vaccinate every year. If we could stretch that out, that would be awesome. I was sort of surprised by this because intranasal, you think that's the sort of thing you would stimulate immunity towards some kind of respiratory agent. So I was sort of surprised that it was as effective as it was. So, and there are other vaccines in the works using different epitopes and different methodologies, but nothing that's really close to the market for veterinary use. The human vaccine is in phase 3 trials right now. And another problem is with older dogs is immune senescence. So as we age, our immune systems fail. But I found this interesting paper that suggested they gave a combination of these short chain sugars, basically. So a prebiotic plus a new yeast postbiotic, and then vaccinated dogs and looked at their immune cell profiles. And they showed this combination actually led to increased, a better CD4, CD8 T cell ratio. And that's really important because you need that T cell help to make good antibodies. So if you stimulate an appropriate T cell response in your vaccinated animals, you're going to get a better B cell response. So something to think about. So Grand Forks Vet asked what kind of prevalence is there around North Dakota. Right now, I know it's in the Goose River system in Mayville, Turtle River State Park, Walhalla, Pembina Gorge. I haven't seen too many positive infections west of Michigan. And that tracks with data that we have. So in North Dakota, we have 2 tick species that attack humans and pets. So we have Dermacenter. This is the dog tick. It's endemic to our region. It's well established here. It is a vector of rickettsial diseases, but when we surveyed ticks in North Dakota, we got a very low prevalence of non-pathogenic rickettsia. So Dermacenter, at least right now, don't seem to be a huge problem in terms of being vectors for infections for dogs. But Lyme disease is not spread by Dermacenter. It's spread by Ixodes species. Breeding populations were first described in 2010. And this is a vector not only of Lyme disease, but anaplasma, babesiosis, powassan, Borrelia miyamotoi, and many, many other things. And I just want to talk a little bit about the expansion of Lyme disease, because I think this is something to keep in mind. So how did these ticks get here in the first place? And you might assume that they just were on deer that swam across the river from Minnesota. But the deer are introducing adult ticks. And when those female ticks drop off and lay eggs, those eggs will hatch into spirochete-free larvae. So you're not going to introduce the spirochetes into that area. Whereas birds introduce immature ticks like nymphs. And of course, we're on a major flyway, migratory flyway here. So birds may be really important sort of sentinels for introducing Ixodes into different areas. So my colleague, Jeff Vaughn, first started, this was about a year after I got to North Dakota. And, you know, there'd been some human cases in Manitoba. And so we wanted to look more closely at this. This is health department data, and you can see the numbers of human Lyme disease cases were quite low. But he wanted to do some small mammal trapping. And so he looked at a couple of different sites in Grand Forks County with Nate and Michael. I was on both of their PhD master's committees. And basically what they found is that we have all these forest islands amidst all our agriculture. And so, you know, these areas are not good areas for these ticks, but these forest islands are. And what they found is that even a small forest island like this one in Oslo, that's 7 hectares, they all had sufficient numbers of small mammals to support tick populations. And if you look at the number of Dermacenter in those sites, that tracks. But the only places they found Ixodes scapularis were in these larger sort of forest islands. So there may be, in terms of westward spread, the size of those forest islands may be important. We cannot get funded to do this work, but we've been trying. So those isoxazoline drugs, because these islands are isolated, a lot of the things that have been done in eastern United States to try to stop the spread, where they've put out like anti-tick things at deer bait stations or tried to target the small mammals, haven't really worked, but the disease was very well established there. And you know, a lot of those methods we really can't use. You don't want to have deer bait stations because we have chronic wasting disease. You get deer coming together, you're going to spread that. And so we wanted to try to use these isoxazoline drugs and see if we can target in these islands and reduce the tick population among the small mammals. And so Jeff actually caught a bunch of Peromyscus at his house and then had bred a colony at UND. And we tried all these different isoxazoline drugs. And you can see with lotilaner, is that Credelio? That days after tick infestation after the drug, that almost out to 2 months, we were getting really good prevention of engorgement. So these drugs don't keep the ticks from biting, but they do prevent their feeding. Another interesting thing is that we get, there is some transfer in mother's milk. So with pups, with 3 doses, if the dam had 3 doses of lotilaner, you got protection in the pups up to 2 weeks post-infection, or tick infestation. And then, anytime you try to do some kind of environmental strategy like this, you have to worry about effects on other things. But we took fecal pellets from these lotilaner treated mice, and they were toxic to mosquito larvae. I don't think anybody is going to be upset about that. And they were not toxic to aquatic snails or fathead minnows, so good news for people who like to fish. We also put out the carcasses of the lotilaner treated mice and looked at how long it took them to decompose, because there's a natural progression of bacteria and fungi and nematodes, and they did decompose more slowly, so there may be some effects there. But we would really like to do this study and see if we can stop the westward spread. And another question was, what percentage of wild mice are infected with Lyme disease? And so nobody is really doing this except us, and so all the data we have is just from Grand Forks County. But you can see in 2012, 6% of the ticks were positive for Borrelia, and in 2018, that had gone up to 45%. So now we look more like New England and the mid-Atlantic states in terms of the percentage of Borrelia-infected ticks here. So the risk has definitely increased. So there is some North Dakota tick surveillance. So this is 2025. People sent in 348 ticks, and they were mostly dermacenter. And you can see where they're from. You're not getting here in the Red River Valley where we know exodes are established. And again, this is just dependent on people sending in ticks. So certainly benefit to doing community science, but we obviously have huge gaps in our knowledge in terms of data. And these are human cases. And so this is 2023. That's as far out as the state has data. I don't know why we had a big spike in cases in 2017. I wouldn't trust these numbers here because that was COVID. But you can see that human cases have remained kind of low, but there's a lot more cases in dogs that have been reported in North Dakota. So dogs are really important sentinels for human disease. And then when ticks are positive for Borrelia, just showing you this because our percentage, these are blue bars, are positive for Borrelia. And you can see that the proportion of positive increases as you go throughout the summer, and then decreases as the summer ends. And that really tracks with human cases. So the bulk are here in late June and early July. And so, here, if people are being infected here You would expect to see development of arthritis a few months out, and that's probably the same with dogs. And so they're here. This is Turtle River State Park. It was about 8 miles from my house, and there are signs there telling you to do tick checks. So it's here, it's established, and it's probably going to spread. But the best thing, I think, weapons we have in our arsenal right now, obviously the vaccine, which has to be given every year, but at least there is a vaccine for dogs, and tick prevention is really critical. And with that, I thank you for your attention and happy to take questions.
I have one in terms of the tick surveillance. Where do we send ticks? Or we can figure that out. Then we can.
Yeah, I'll look into that pipeline.
Yeah, we can figure that out. That could be something that.
State health department.
Yeah, it's.
We used to take part. We have the last couple of years. But I'm from Rugby, and I was say our county kind of showed up.
Yeah.
On that list, but what it doesn't show though is that I would say probably 90% of our disease cases are from bottom of the
Yeah, absolutely. So, yeah. And so that's another problem with the surveillance data. And it's a problem with the human data as well. So like the CDC map, each of those little dots is where someone was diagnosed. It doesn't mean that's where they got it. And so if someone is doing recreation in, Walhalla or, Red River Valley, or, they're camping in Minnesota, we don't know that that's where those dogs were. Those dogs likely weren't infected in your county. But, what I'm particularly wonder about is, there's been an idea that the ticks can only go so far west because they're very sensitive to dehydration. So as it gets drier, it's not good habitat. But, obviously people change the landscape. And so if we have areas with, grass and trees and the right mix that you have mice and deer, then you're kind of creating conditions. And so the ticks get established. And then I think along waterways is, in North Dakota, that's where most of our trees are if they're not in tree lines. And so I'm concerned about spread like along the Missouri or the Cheyenne. So those are areas, if you're near a river system, that I would be on the alert for. So ticks do feed on the deer. The deer just don't get infected. So deer are really important because that's where the ticks mate. And the female has to take a really large blood meal in order to have the energy to lay the eggs. And so deer are really, really critical for that stage in the tick life cycle. Deer just don't get infected. But deer are obviously very important. There's been a lot of things have been tried in New England to like cull deer populations to reduce risk because they're just so important in maintaining the tick life cycle. Yeah, and that was from a 2018 consensus statement, and I couldn't find anything more recent. So I don't know why that would not be. The C6 test was sort of the gold standard for people for a long time. I mean, it's off the market now, but yeah, I don't know.
Thank you so much. Super helpful, especially as we saw in the graphs how we're now entering the season where they can acquire Lyme. So
we are going to take a break. It's just a refreshment break. I guess there's a couple of little snacks there, but there's coffee and ice water. And then we will start again 10:30. So I guess that's a good 20 minutes. Thanks, Michelle. Let's see. Before we get started, I do need to make a plug for the lab. And that we have a new residency position opened up. It's even being advertised right now. So any of you youngins or olders who are interested in coming into the lab to do a residency, you'd be training for under Michelle before she decides to sail off into the sunset. Yeah, eventually. You'll train under Michelle, and there are other toxicologists that would be part of that training too. So if you are at all interested in nutrition will be a huge part of that. You no longer want to do 2 a.m. calls. Come into the lab. We have a position open. So check it out on our website or at NDSU. Okay. We'll just get started here. Just an outline for today. I'm going to talk a little bit about influenza viruses in general. Hopefully you won't be too bored. I find this stuff fascinating, but it can get a little bit into the weeds. I know that. But there's some important things to know about influenza viruses and why they can infect certain species and not others. And so we'll talk about some determinants of host range as well as some the species specificity of influenza viruses. Then we'll move over into poultry. What does high path in poultry mean? What does it look like? How does it shift from low path to high path? We'll talk about what those pathologic lesions look like in birds. And then we'll shift again over into mammals because that's what we're seeing high path in mammals in North America, which hasn't been typically the case when we had a previous outbreak about 10 years back. We're going to talk about how it affects the brain and how it's really spilt over into dairy cattle and cats. And then also, what does it mean for us as veterinarians? What's the risk to us? And I'm fine if you guys want to stop me along the way and ask questions or something isn't clear. Last year when we did CE, you're going to notice some of these slides, but not all of them, don't worry. I did show this one last year just to give you an introduction to influenza viruses in general. There are 4 genera. They say A to D, that's pretty easy. All of them have an overarching concept of antigenic drift and shift. We'll talk about that. And then for them, there are various viral and host adaptations that are required for a sustained transmission amongst a species. So there is a reason why I don't get canine influenza per se. Also interesting about this, or I'll try this. What? Oh, now it works. Aha. So up here in A, you'll notice that the epicenter of all influenza viruses come from wild birds, aquatic birds specifically, except over here we have a bat. There are a couple of strains that are bat specific, and we're not going to talk about that today because I honestly think this probably also came from a wild bird at one time. So we'll talk about bats a little bit, but only in that we'll say blah, 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 and bats. So aquatic birds, that's where all influenza A viruses come from. We'll talk about, this is actually, it says H1 through 16. They're always finding new H's, so that's actually not accurate anymore. But all come from aquatic birds. They go to wild birds and then to other mammals. Can go into poultry, which we know. And then through poultry, various species have been infected and get their own influenza virus. So dogs typically have actually H3N2 or H3N8. Horses get H7N7. That's actually not really so much anymore, but also H3N8. So each species gets its own subtypes. Typically, there can be spillover of other types. I'm not going to talk much about influenza B and C, but look how humans are the epicenter of those ones. And then there's D, and you guys might have heard of that before, and that's in cattle. And before high path avian influenza was detected in dairy cattle, That's the only influenza we talk about in cattle. Okay. So influenza A virus, it's enveloped. What does that mean? Basically, an envelope virus, what it means to me is that as a laboratorian, this thing's actually easy to kill. So you can use your 10% bleach. You have to make it every day and keep it out of the sunlight. But you can kill influenza viruses pretty easily with bleach, other disinfectants, UV light, even wind. The wind can also disperse influenza virus. So that one's a little bit, iffy. But an envelope virus is a lot easier to kill. It's also a negative sense single-stranded RNA virus. Typically, those come into a cell and then they can replicate in the cytoplasm. Influenza a little bit different because it actually enters, parts of it enter into the nucleus because there's this, the genome needs to be spliced. We don't need to get into that. It's a little bit different though. What's more important is that it's error-prone in its replication. So in every 10,000 replicates, there's one that's going to be mutated. Just because something mutates doesn't mean that it's going to actually be a better virus. There are mutations, which means it's a worse virus. But those better viruses, and what I mean by better are those that are able to infect either that species better or another species. It can jump into a new species. That can happen in 1 in every 10,000 replications. Also, what's interesting about influenza is it has a segmented genome. So there's 8 segments of the genome. And they code for at least 11 proteins. Some of those are on the surface, some of them are internalized. And because they also have 8 segments, they can reassort 8 to the 8th. So there are 6 million genomic combinations of influenza. What we see, though, is that there are 19 HAs at this point, 19 HAs that have been described, that's hemagglutinins, and 11 NAs, that's neuraminidase. And they have produced over 130 subtypes, and that's what we see in the wild. So the concept of antigenic drift and shift, you've all heard of this, right? We all heard about this in vet school. But just to give you a quick overview, because this is what's really important, this is why we have to get an influenza shot every year. And also why influenza can jump into new species. So we have our 8 segments of the genome, and they code for various proteins. Some of them are surface proteins, like I said, the hemagglutinins and the neuraminidase. In antigenic drift, say for instance, there is a mutation in that hemagglutinins. So that codes for a new protein on the surface. And the hemagglutinins is really important for how the virus can attach to receptors in mammalian and avian tissues. So if you have a mutated hemagglutinins, well, it could be that it has less affinity for a receptor in an animal, so it's a dud. Or maybe it has better affinity, so it's easily able to infect the host. So that's antigenic drift. There's a lot of other pressures other than just having a mutation. There's the host pressures, environmental pressures, but we won't get into that. But this is why we get a flu shot every year, is because it's always mutating. Now, when we talked about antigenic shift, it's a bit different. So this virus A and virus B, that's not influenza A and influenza B. That's an influenza A, virus A, influenza A, virus B. The 8 segments of the genome can reassort in a host cell. So you need a host cell that can what? That is able to be infected by both those viruses. We'll get into that. That's most of what this beginning of the talk's about. But this host cell is able to be infected by virus A and virus B, and then those gene segments can reassort. And then you get this new virus C, and who knows what nefarious things this new virus is going to do. But you might have a new hemagglutinins from B and a new neuraminidase from A, and that could be the perfect storm for jumping into a new species. Get a little bit into the weeds starting now, if it isn't already there. But the virus, you all have heard this before. Influenza enters the cell by binding to sialic acid receptors on the surface of host cells. So this is the host cell. Here's our virus. It is attached here to the receptor. And then from there, it undergoes clathrin-mediated endocytosis. And basically what that means is that there's these clathrin pits and vesicles that allow it to fuse with this endosome. I mean, there's a membrane fusion between the envelope and the plasma wall that was here on the plasma membrane that was on this virus, on this cell. And then it's able to release its contents, go into the nucleus, then the proteins are coded and made, and then it can make a new virus. So this is very important, and how the virus actually gets into a cell. So that's important, but also what's important is at this fusion point, it requires a low pH as well as the cleavage of the hemagglutinin precursor protein by endogenous proteases. And typically that's trypsin, or a trypsin-like protease. Some of the main host factors, of course, we have sialic acid receptors, but also the immune system of the host. We have also virus factors, like how the receptor affinity for that host cell. And then, of course, we just touched on hemagglutinin cleavage. We'll expand on these. This is just an illustration of here, wild birds. They have all the influenza viruses that are ever possible, basically, and how it can go into domestic birds. But then there's usually mutations that are required for it to jump into a new species and then be maintained amongst individuals in that new species. And so I think I like to add this one because we usually only think about the hemagglutinin, but there are other genes that are involved that code for new proteins too. So this is polymerase basic 2. We also have an M, is that M? I don't have, oh, PA. So that's polymerase acid. So it's not just HA. Any of these genome segments can actually be mutated to enhance the ability of the virus to jump into new species. And then what does it mean by to be a sialic acid receptor? And what's that mean with specificity? Basically, a sialic acid receptor, let's see. I'm going to flip to this one real quick, and then we'll flip back. Is this this chain of carbons and sugars and carbons along here, and how here it makes this ring here, and it has various positions: 1, 2, 3, 4, 5, 6, 7, 8, 9. So that's your sialic acid. And when we talk about sialic acid alpha 2,3 and alpha 2,6 specificity, that's actually referring to where that carbon is and where that would link on this carbon chain. So sialic acid receptors that have an alpha 2,3 configuration, they usually are linked to here on that carbon chain versus the sialic acid alpha 2,6s, which would link to here. And the big point here is that avian influenza viruses typically have affinity for sialic acids that have that alpha 2,3 configuration. And then the human viruses typically have greater affinity for alpha 2,6s. So it's not just the linkage alone that matters. It also matters in the biochemical structure of the sialic acid receptor itself. So you could have an N-acetylneurominic or an N-glyconeurominic acid that is part of that biochemical structure. And that actually is way beyond me. And so I'm not even gonna go there, but that's important. The other thing is, where are these receptors located in the body? So maybe there's 2 3s in my nose, but not deeper in my lungs, or vice versa. And that's how it is for every, different species. The receptor could be located in different places. And we'll skip that. We went over it. Just touch a little bit on this. Kuchipudi went through a lot of studies to make these tables. These are great tables because they talk about the sialic acid alpha 2,3s and the sialic alpha 2,6 distribution in various tissues in various species. So again, 2,3s, we think about avian viruses. 2/6 we think about human viruses. So in humans, there are alpha-2/3 receptors in our ciliated and non-ciliated cells in the respiratory tract. Also in our ileal epithelium. And for 2/6s, we have 2/6 distribution or 2/6 receptors in our bronchioles and our alveoli, as well as our colon, endothelial cells, the blood vessels, and in inflammatory cells. So what that means is that, an avian virus, it is possible that if all those stars align, basically all the molecular elements are there, that an avian virus can definitely adhere to one of our sialic acid receptors in our ciliated respiratory tract. Where's that at? From our nose all the way to our bronchioles. And the bronchioles is where it changes to the non-ciliated respiratory epithelial cells. So that's quite interesting, I find, because we think about alpha-2/6s, right? So this says ciliated cells in the bronchioles and alveoli. So that's pretty far down there. For non-human primates, this is what's interesting too, to me, as a primate pathologist previously, is that the sialic acid 2/3s are in these goblet cells of some mucosal glands in respiratory cells, as well as ciliated cells in the upper respiratory tract. So that's for avian viruses. Here's for humans. They same as before, but also there's alpha-2s deep down in the type 2 pneumocytes. Where are those ones? Those are the ones that line the alveoli, right? Okay, so just going through this real quick. Pigs have alpha-2/3s in their ciliated epithelium goblet cells in the trachea and bronchus, so upper respiratory, as well as lower alveolar epithelium. And alpha-2/3s are in the alveolar epithelium. We won't go through all of these, but this is the kind of thing that's really important when you're thinking about how a host cell can get two kinds of viruses. And then this table, some chickens and turkeys and quail, but also I'm just going to point this out. This says trachea of ducks, but then down here it has inseriforms. So I don't know, but I just don't. I think they needed a pathologist or a veterinarian on this paper. Actually, he's a veterinarian. I don't know. I think. But you can see here. So here's some birds. In these chickens, the nasal cavity to the lung, they have alpha-2/3s, but also the tracheal epithelium chickens and quails. And then the alpha-2/6s all the way from the nasal cavity to the intestines. While I'm reading this, guys, I might at lunch, I might look this up because this just seems kind of weird to me that this to me should be 2/6s and this should be 2/3s. So I'm going to look this up. There might have been some error on my part when I wrote that down, because I know for a fact that 2/3s are in the intestines of chickens. So we're going to look that up. The point, though, is that where those receptors are can tell you a lot about what kind of virus is there. So if you have a chicken and it just seems a little bit sick, and it just seems a little bit not respiratory, more like intestinal, it might be a low path, just something, not that you have to ignore, but not like the high path that is going to infect the entire body and kill the chicken. Then we're talking about mixing vessels. We talked about those host cells. So down here, this is like the low probability of these species being mixing vessels, all the way up to high probability. So foxes, bats, whales, their distribution of sialic acid receptors, as well as other host factors, makes them unlikely to be mixing vessels where a host cell can get two kinds of viruses and then it can reassort into something new. But up here, these are species that have high probability, and we usually think about pigs. But over the years, we've learned lots more about how influenzas that humans get, and humans can also be a mixing vessel, as well as ferrets and mink. Cats are one that are being more and more talked about as well. And these ones are more intermediate. Questions about that? It's a lot of in the weeds stuff. So how does a low path virus transform into a high path virus? And what does that mean? We'll start out by talking about low path and this duck. So it's typically intestinal tract where you see the viral replication, and they shed primarily in the cloaca. The virus doesn't typically spread beyond those epithelial cells, epithelial line tissues, I should say. There's a minimal induction of type 1 interferon and pro-inflammatory cytokines. And then there's also low interferon stimulating genes expressed in those infected tissues. When we have a high path avian influenza virus, it moves, instead of the intestinal tract being the typical location, it moves into the respiratory tract. And that's where you see most of your viral replication. And the shedding is typically from the trachea. And that's why we often will swab straight from the choana. Oops. The virus can spread beyond the epithelial tissues into the organs, like the pancreas, other skeletal muscle, intestinal tract, and even the CNS, so into the brain. There could be a rapid induction of the type 1 interferons and interferon stimulating genes, as well as pro-inflammatory cytokines. And again, there's a high expression of interferon stimulating genes in those infected tissues. So how would it go from low to path? We already talked about sialic acids. Well, there's often an enhanced binding affinity or a change in the binding affinity, some kind of change where that virus can now either, it was an alpha-2/3 specialist and now it likes alpha-2/6s, or vice versa. The other big one is there can be an alteration in the type of proteases that can cleave that hemagglutinin from hemagglutinin. And remember, that's what's needed for in the endosome for the envelope and the plasma membrane of the host cell to fuse and then the contents to be released. So typically it's trypsin-like proteases, but when there's a shift from this cleavage site from a monobasic arginine or lysine to a polybasic cleavage site, more ubiquitous systemic furin-like proteinases can now also cleave that site. And we see this so far exclusively in H5s and H7s. So those are subtypes. I like this picture because I think it just really drives home the role poultry actually play in this low path to high path transformation. And so again, we start out with all avian influenzas are in wildlife. They get transmitted via foraging. They also can live, these low path, but also high path, but low path viruses can live in the environment over the winter. So they'll come, there's flyaway migratory paths, right? So they go one way in the fall, come back another way in the spring, and even over the winter, a virus can still be there. And so they'll pick it up, and maybe maybe there's a little sickness here, but it's when they give it over, it spills over into the poultry that we might start seeing some sick animals. But these would be low path, and maybe they're in pigs. And then they can even go from livestock into humans. But also, if it doesn't stay low path, if there's some adaptation and maintenance within poultry, and then it gets to, has these features of high path, that can go back over into wildlife, into wild birds, and kill them. But then we're also seeing how it can spill over into other mammals and humans. So in this, at least this is from the Journal of Wildlife Management, they believe that the authors here make a case where most of the viruses are low path, and that's true, but that poultry plays a huge role in amplifying in the mutation to high path and then the amplification of that. So I'm a pathologist. I like histology. There's a lot of histoimages. I hope that's okay. This is a study where they looked at high path in chickens and in ducks. These are air sacs, and just so you know, the respiratory epithelium is on the outside usually. And then there'll be some submucosal glands too. So in this chicken, these darker areas, those are more gland areas. And so, yeah, we should say this more pink look. But over here, do you see where it seems a little bit like it's kind of scattered and falling apart? This is fibrin. If you ever get a report from me that talks about neutrophils, you should call me and tell me that you're mad at me. Because chickens don't have neutrophils, right? What do they have? Heterophils, right? So neutrophils don't make, neutrophils like to make pus, but we don't see a lot of pus or purulent discharge in poultry. Usually it's more that inspissated stuff. You guys know what I'm talking about? Heterophils, though, we see that a lot of the times associated with fibrin. So in this sample here, we have fibrin, we have necrosis, and a lot of these dead dots, some of that's stromal tissue, but there's too much of it. So there are some inflammatory cells in here too. And in this duck, you see mostly just inflammatory cells. So you see all the blue nuclei here? When they put an IHC on here, and I think this is for the nucleoprotein, and that is one of the internal proteins for the virion, we actually get in the chicken a lot of immunoreactivity. So that means positivity. And we see them a lot in the submucosal glands, but also a little bit on the surface. But in this duck, we see it mostly on the surface. And in the chicken lung, it was kind of the opposite in this paper, where the chicken had maybe some areas, maybe in some of the submucosal glands that look a little bit lighter. Maybe there's some necrosis here, maybe here. But the duck had a lot more, their little, basically alveoli are wiped out here, and there's more inflammatory cells. And then when they put an IHC on here, you do see some scattered, but you see a lot more in the duck. And then the pancreas is really interesting because in high path, that's one thing you want to look for is look at the pancreas and see if you see any hemorrhage, necrosis. But in this chicken, it has, look at all these clear spaces. That's basically where that tissue has died, if you will. And there's some space here with edema. There's some inflammatory cells. The duck, you can see it as well, but it's a bit more scattered. And when they put an IHC on it, it's really concentrated over here in the chicken, but more scattered in the duck. What's interesting is that they say the duck was more profound in the duck. So I'm thinking what they mean is just more scattered versus just on this outside of the pancreas for this chicken. So that's chickens and ducks, but high path in birds, we talked about the pancreas affecting poultry. Well, it can passerines and other birds as well. So this is a long-beaked crow out of Japan. And these red areas, so this is if you were opening, well, if you think it's high path, you're supposed to send it to us, right? But what if you didn't have that on your radar and you just opened up a chicken? If you see this, you should be thinking two things, high path or Newcastle, and you should close them back up and send them to us. Or actually call the state vets. That's probably the best thing. And then they'll tell you to send them to us. But here's what that pancreas looks like microscopically. This is what a normal pancreas, more normal pancreas would look like. And here we have a lot of vacuolation, so degeneration. And then this is just necrotic debris in here and a lot of inflammatory cells. And when they put the IHC on there, you can see where it's positive for the virus, or these viral antigens. So we're going to talk more about neurotropism. And my PhD was mostly in canine and equine influenza infections. And the brain is not something we typically see in mammals being infected. And I didn't see very many birds in my during my PhD because that wasn't my area at all. But it is important to know that high path avian influenza, not low path, but high path, can affect the brain of birds, both poultry, ducks, and passerines like crows and many others. So this is the cerebellum. You might remember this from vet school histology, that these are Purkinje cells. When we're looking at a slide and we're looking for neurons that might be dead, often we want to see them extra pink, if you will, hypereosinophilic. And sometimes they are kind of shriveled up and coiled. And so I would say that this is probably one on its way out. But then there's some of these that look like they have some vacuolation along them. So there's some degeneration and necrosis in these Purkinje cells. And then when they put an IHC on here, we see it here and also in the molecular neuron layers. And these are straight just IHCs. In this crow, a lot of immunoreactivity in the respiratory mucosa, but also in the myofibers of the heart, and then even in the tubular epithelium in the crow, in the kidney. I guess this just illustrates that high path can go anywhere. It goes all over. It's not just within the respiratory epithelium or the intestinal epithelium. And it's a major feature of high path avian influenza. I'm going really fast. What questions do you guys have? Anything? So for low path or for both? Oh yeah, the question is, what are the symptoms in poultry? And if a clinician wants to chime in here, you can, but this is what, if you were to send me, this is what I would think. For low path, they haven't been right. Looks like maybe they have some diarrhea. I hardly ever get anything like that, unless it's coccidiosis. What we get mostly is the high path. And basically what we're told is that they have respiratory signs and they're obviously straining to breathe, and then they die. That's what we're told. What have you guys seen in the field? Yep. Yeah. Yeah. So, yeah.
I'm not sure I would notice if my chicken said that.
Yeah, I know. But we never really get those cases. We get, I mean, it's if they die. That's when we get a case. I don't know for sure, for the most part, in terms of low path, the mortality is low. So, but I don't know, has anyone dealt with low path avian influenza in a poultry facility? You could speak to that. Anything else? Okay. When I practiced this talk, it was a lot longer. So please stop me. Let's ask questions if you have any. This is, you can get this map off of the USDA website. And this is the mammals that have been infected with high path avian influenza that they've detected at least. And so I think I got this off, the last update was in May, and I got this off early June. I find this really interesting, how many mammals across the US have died of HPAI. And the sign mostly here has been, the clinical signs have been neurologic or found dead. And then the pathologist saw something in the brain that made them wonder about high path. But there have been bears, both black bear and I believe some grizzlies, though I don't see. I thought there was a report. You see a grizzly? Oh, well, yeah. Yeah. Oh, over here. Yeah. That's probably the grizzly I read about. captive wild cats as well as domestic cats and wild cats. Lagomorphs, I looked that up. So my favorite lagomorph is a pica. And yes, there was an account of them being infected. That sucks. But hares and cottontails too. The marine mammals, seals and sea lions. Mustelids, so that would be both mink and ferrets. Raccoons, rodents, that's usually rats and mice, permiscus. Skunks, possums, and wild canids too. So there have been over 20 species, I think maybe we're up to 25 by now, of wild mammals that have been infected. When we look at the history of humans and mammals getting this high path avian influenza over time, it's pretty dramatic. So this is looking at basically the goose strain that the current high path avian influenza has mutated from. Way back in 96, when we first saw that, maybe there was a couple human cases, and they were usually in poultry workers, and the mortality rate was like 60%. We'll talk about that a little bit. And what was described wasn't neurologic signs, it was respiratory signs in those people. And then when high path stretched out across Asia and Europe, we did see more and more human cases, but then started seeing some mammalian cases. And then with the outbreak that actually hit us 10 years ago, more human cases, but not very many mammal. I know humans are mammals, but you know what I mean, non-human mammals. And then in this last outbreak, look at all the non-human mammals that have been infected. I really like this paper. It goes through basically the three spillovers with this latest outbreak. And so, and I want to say spillovers and being able to maintain the virus within that species, because all these really are spillovers. So we'll start with aquatic birds and seabirds, poultry, right? All these ones here, even polar bears. Did that map show Alaska? I think yeah. I think there was a polar bear too I read about. These are dead end hosts. These guys have neurologic, die, or just found dead. And they're not spreading it amongst other individuals of that species. So it's usually like one-offs. Maybe there's a couple of them. I know that there were some goats over in Minnesota. But for the most part, these are thought to have been because of feeding off of wild birds, basically, or being, scavenging wild birds. But then there have been three main spillovers that have been maintained among the new species. So this one here is in marine mammals in South America. So evidence that they have a strain that's related to seabirds, and then they're passing amongst individuals of their species. Now in Europe, there's something similar in mink. And then of course, now we know we have that here in dairy cattle. And I'll show you a graphic that talks about some possible mutations and why that would be. But yeah, I mean, we've had a llama. Wasn't the llama out in Idaho? Mice, people, lots of different animals are infected right now. They just like a reminder of that there's various molecular components and why it might shift from one species to another. It's so we have the HA and the NA that we talked about, but also that we talked about the PB2, PA, PB1 being important. Those help make up this ribonuclear polymerase. So here in this graphic on this side is just talking about avian influenza viruses that do get spread to wildlife and how They all share the same receptor, sialic acid receptor, alpha 2,3s, so up to mammals and to shorebirds. Humans have both 2,6s and 2,3s, pigs, chickens, all these. So just another iteration of what we've been talking about. Here are those bat ones. I don't know what to make of them. When I was doing my PhD, that came out, and even then, everyone was excited, but they haven't found them beyond bats. And I wouldn't be surprised if they were at one time an avian influenza that just isn't circulating anymore. Okay. So why is there this propensity for this virus to go into the brain of mammals? And often you won't see any respiratory signs. It'll just be neurologic signs or death, right? They'll just be dead. Well, the latest high paths seem to be more neuropathogenic than other influenza A viruses in mammals. They're finding that cranial nerves, especially olfactory nerve, is probably involved in their neuroinvasion. And that once it does reach the CNS, it has broad neurotropic potential. So it can infect and replicate in a number of different CNS cell types. And in this table, it talks about the sialic acid type, so 2,3s versus 2,6, in mice, humans, pigs, cats, and dogs. Well, in mice, in the olfactory bulb, they have 2,3s, and also the hippocampus, the thalamus, and the cerebellum, I should say. Well, also the cerebrum. Here it says no, but this is getting picky. And then other places in the brain. They also have 2,6s in the olfactory bulb, hippocampus, thalamus, cerebellum, and other places in the brain. The humans, in our cerebral cortex, we have 2,3s and 2,6s, our hippocampus, both, brain stems, both, and cerebellum. The cat also has them in the cerebellum. So this is a good graphic to show how a virus could potentially enter the olfactory bulb into the brain. And so here is the olfactory bulb. Down here is the IHC that correlates to that. So this is looking at the H5N1 virus antigen. So we have the cribriform plate all the way out to where the epithelium would be, and our cilia down here. Here's the mucus here. So if a virus enters this epithelial cell, it has pathways to get straight up into that bulb. And some of this actually, the olfactory bulb, some of these neurons actually reach right into the brain. And this is the respiratory pathway. Yes, ignore the trachea. Yes, that's obvious. But what they're talking about here is just in the upper respiratory tract, like the nose and the pharynx, that also has a pathway to the brain through the trigeminal nerve. And when they put IHC on, this is a ferret that was infected, they can see virus or virus antigens in various layers of that olfactory bulb, as well as in the trigeminal ganglion. So a couple of ways, if you can imagine an animal scavenging a bird, they just inhale some of that virus and go straight into the brain. At least that's what I've been imagining the last couple of years. And then I found this paper and my bias was confirmed. I'm sure there's other things. I'm open to other interpretations. This one just shows areas of the brain that can be hot spots, like the olfactory bulb, hippocampus, pons here down in the brain stem and into the spinal cord, and into the cortex and then the meninges. So we've talked about this, what can influence it jumping from one species to another, but what may also influence it from becoming neurotropic. Like I said, like we think mostly of mammalian influenzas affecting the respiratory tract, not the brain. But there's a number of factors here. The host species, like we talked about, if they have the right receptors, the exposure route, are they inhaling it? How much virus are they getting? And also the strain of the virus. And then this graphic just shows they could have, you know, depending on these factors, no symptoms all the way up to death. What questions do you have at this point about neurotropism and how influenza virus gets into the brain of mammals? Okay. You ready to talk about dairy cattle? And a little bit of beef, because that's really what we care about here, right? Well, I care about dairy cattle, especially if we're going to get 2 new dairies. Okay. Influenza A virus in cattle. There is some evidence, if you will, or talk of influenza being in cattle since the late 1880s. There's a number of times where they thought that cattle had it, but it wasn't isolated. The first isolate didn't occur until 1962, and it was around a time of human pandemics that they might also see some of those. They started really testing for it in the 70s and again in the 90s, and they saw a human-like influenza A virus circulating in cattle. I believe this is all by serology. And then when we went, and if you look in culture versus in real life, in culture they found, so if anyone doesn't know what MDBK cells, those are Matta and Darby, bovine kidney cells. So this is from a cattle, from bovids. But there's bovine serum components and secretory proteins that actually have anti-influenza properties. So there's thought that that cattle may not be natural hosts to influenza viruses because they have components in their blood that fight it off, kind of like the deer in Lyme. I don't know what they are. This is just what the paper said. But as we all know, a little over a year ago, HPAI was detected in dairy cattle. I got this one off of the USDA website in early June, and this is where we're at right now. 17 states have confirmed HPAI, over 1,000 cattle affected. We all know it started in Texas and moving into Michigan, and we're spared. What do you guys think about that? We have been testing for it though, just so you know, it's not like we're not looking for it. People have been looking for it. We just don't have very many dairies here, right? So what they found was that this is the same, that goose strain that's going around, which is 2.3.4.4b, but the genotype is B3.13. And the clinical observations were that over 80% of the farms that had this virus had abnormal lactations and decreased feed consumptions, and that there was thickened and clotted milk. And so a lot of that milk would be yellow. This is what you'd want to be looking for out in the field. Yellow, it's thick, it has flakes and clots. Yuck. But clinically, what might they see? Decreased milk production is the #1 thing. Abnormal milk. They go off feed for a while. They may have a fever. They might have some respiratory, but look, it's only up to 50% where you might see an increased respiratory rate. But the fever they see more often, in dehydration. They just feel off. But they tended to recover. And then when they were recovered, their milk production was typically still down. They never came back in to the high amount of milk production that they were before they got sick. So again, this is the goose virus that's been going around with this genotype B3.13. What's interesting is that when they did a serologic study of serum, looking for H5N1 from cattle from 2023 to 2024. They found some seropositivity, but it was to human and pig strains, none to that circulating cattle strain that we're seeing now. So that suggested that this has been a more recent jump. This hasn't been in those dairy cattle for a while. And so putting some of this together from what we previously talked about, here's that original goose strain. Looks like it reassorted with the European low path and changed its composition. And then another, well, from here, it was introduced into North America. And so that's what we have here. But it added another low path avian influenza that we have here, reassorted with that. Add another, well, and from there, because there's all these, this is pretty interesting. From there, that's what went down into the South American marine mammals. But then they add in another American low path. You get this B3.6. Add in a couple more American low paths, and then we get what we see right now in dairy cattle. But if we go back over here, here they had, so this is the one that was in Europe, a gull adapted a couple of subtypes that made this genotype. And this is what they're seeing in the mink. So the three different species that are now able to pass it on amongst individuals in that species. So again, the cattle influenza has been mostly related to cattle movements, not necessarily wild birds bringing it. Over 20% of the affected farms received cattle within the 30 days of them detecting it. And despite detecting it, 60% continued to move them off farm. Yeah. 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 Right. Yeah. Right. From what I've heard, they don't come back. That's what I've heard. Has anyone heard differently? They don't come back. I don't know anyone who has looked. I haven't heard anything about fertility. Like, are they able to breed again? I don't know. But I'm going to show you some slides and talk about some papers where it is, I think it could have been possible that they could get pregnant again or breed again. So those studies haven't been done, and I haven't heard any clinicians telling me otherwise. I think often too, because they don't come back into production, that they get cold. If they can get cold. Can they get cold? I think they're entering, yeah, they go straight to slaughter. Yeah. Because if you cook your meat, then you shouldn't get high path avian influenza. That's a great question. Any other questions? Though I like a raw, I like my steak rare too, but Okay, so they're thinking that it's probably, well, they say out loud, they think it's likely multifactorial with direct and indirect transmission. Though when I read papers and stuff, many people think it's from contaminated milk equipment, which and we'll talk about that when I show you the next slides here. But maybe it's because there's multiple species on the farm, there's shared transportation vehicles, employees, veterinarians, contractors, suppliers. And of course, the big push is for biosecurity on these farms, which is appropriate. So, there's this genotype B313 spillover into cattle. There is some adaptations. There's like 5 mutations that now they find consistently when they sequence the genome of the HPIIs coming out of cattle. So they adapted to cattle, and now it's being transmitted among cattle. But of course, we're also seeing transmission to cats and humans, and spill over into other mammals. And people apparently from poultry to human. So into other animals, including chicken, and then back to people. There's the one, I think it was Colorado, where a poultry worker had this dairy subtype. So here are some of those adaptations. This is general. This isn't the one specifically for the, well, actually, maybe it is from the cattle. But it says, doesn't give us these are some of the mutations in cattle. There are of 5 genes that have been mutated, and I think it's 7 proteins that help that virus adapt to its new host. So there's better replication of both human and avian influenzas. So enhances the polymerase activity, so its ability to replicate, helps its binding, receptor affinity, contributes to how stable that virus can be. And it can change its virulence, its ability to replicate. Maybe it's also its ability to be fought off with zanamivir, so their antivirals aren't working. And also resistance to oseltamivir. And enhancing the viral polymerase function. So again, its ability to replicate. So these types of mutations are what allows a virus to jump from one species, well, to be maintained in a new species, basically. Okay. I think we're going to talk about cats here in a second, because I want to make a point about those cats. Here's a study where this is all cell culture, but they did primary epithelial cells for the trachea in a beef and dairy hybrid, and then a dairy, I think it was a dairy cow. They're looking at pan-keratin, so they're looking at for the epithelial cells themselves. And then Muse1 is looking for goblet cells. So that just shows differentiation into goblet cells. So these are really good respiratory cells. The only thing that we're not seeing is the cilia. And they're showing in culture that they can recreate those cells. And they did it with mammary epithelial cells as well. Here's some from beef. Here's some from dairy. And they're looking at pan-keratin. And then looking at beta-casein, which is the ability, I guess, to produce milk. And then they wanted to look at the alpha-2,3s and alpha-2,6 distribution. So in these tracheal epithelial cells, that's on this side. Here's the mammary epithelial cells on this side. The dairy cattle, so where it lights up green up here is alpha-2,3s. Where it lights up red down here is alpha-2,6s. These are lectin binding studies. The dairy had evident alpha-2,3s in the trachea and a lot in the mammary tissue. So did the beef dairy cross. When we're looking at the alpha-2,6s in the trachea, there's a little bit here, a little bit here, a lot more in the mammary for the hybrid and also in the dairy. They just call them beef dairy. Well, this is all cell culture, so I don't know where they came from. This is where they're just showing. So they took the lining of these cells. So they took the organ, so basically the trachea from these cattle. Then they harvested the cells, they grew up the cells, and then they infected the cells. So where the animals come from, I don't know. These animals are not naturally infected. So this is all cell culture, guys, I'm sorry. We are going to get to some in vivo studies, though. So in cell culture, though, you can see that there is a lot of 2,3s and a lot of 2,6s in the mammary, right? And a bit of 2,3s in the trachea for the dairy. And again, this is all cell culture. Here's some actual studies done in vivo. So I think that there were 2 cows and 4 heifers in this study. I'm pretty sure this is the one. Then there's another study I'm going to show you, and similar numbers. Not a lot of numbers, but interesting information. Down here is control tissue. So this is a mammary gland. And this is just the H&E stain. And this is a trichrome. So we're looking for collagen and fibrosis, basically. Up here, and these are the 2 cows that were infected, and it was just intramammary infection. So they just injected the mammary with virus. And if you compare this to this, we see a lot more of these blue areas. That's inflammation and cellular necrosis of these alveolar, or the alveoli of the mammary glands. And we're also seeing a lot more of this pink. This is fibrosis compared to down here. I mean, you're going to have some collagen in any tissue, right? But there's a lot more in this one. So necrosis, inflammation, fibrosis, same in here. Now, if you put the trichrome on here, that's looking for fibrosis, you see a lot of fibrosis here and here. And this gets back to, the study wasn't long enough to look at months and months out, but this fibrosis from someone else was talking, another presentation lasts. So this is why they don't come back into production very well, because all these alveoli, that is, that's where the milk is secreted, right? It's destroyed. And then it's filled in with fibrosis as part of the reparative process. And I don't know, I mean, we're a year out, so I don't know. I'm sure someone's looking at this and we'll find out more information. I don't know if they ever really truly recover. So these were same. These are the alveoli. And when they put an IHC on here, you can see that the virus is here in the lining of the alveoli, but also in the more myoepithelial tissue, if you will, the cells around it. So that's what they did with the adult cows. And this is what they did with the heifers. They did an intranasal inoculation with H5N1. And so this is let's see, this is alveoli and probably a bronchiole. Here's a bronchiole. And down here, some alveoli here, and then this is bronchiolitis obliterans. That's actually a reparative process, and another path can tell me if I'm wrong, but we usually see this with chronicity. This is not an acute thing. And I can't remember how many days out this is, but you can see that a lot of the alveoli are filled in with necrosis, inflammation. There's inflammation around this bronchiole, necrosis here around this bronchiole. This respiratory epithelium looks damaged. When they put the IHC on there looking for the virus, you can see it a little bit. So they were able to produce a pneumonia, but it was a fairly mild pneumonia. And these animals actually recovered, if you will, within, I think it was 2 weeks, but because it was H5N1 study, they were sacrificed and then they harvested the tissues. So this was an experimental infection. This is another study looking at the airway of some other heifers. This is the trachea here. This is alveoli. This is in the lung. And then this is a bronchiole here, and this is actually, looks to me like galt around a bronchiole. So when they put we can see that looks like there's some inflammation here. I think this is possibly normal lymphoid tissue, but there is probably some neutrophils and necrosis here being like exudate into the lumen here of the trachea. Here, I think they're trying to show us some fibrin and some inflammatory cells. And I think they're trying to show us some inflammation here. Like this, like I said, I think this is BALT. Did I say GALT? I meant BALT. Bronch-associated lymphoid tissue, BALT. And when they put the virus, the IHC for the virus, you can just see barely any. So even though it had some inflammation, there's hardly any virus in these samples. I think the paper says none. That could be some. And these were cows. And this is mammary again. And again, this was another intramammary inoculation. So in this case, a lot of necrosis and inflammation by day 3. This is the IHC showing that there's virus there. Same in here, in here, and here. So that's more of an acute infection within a couple days. And then similar here, by day 9, they still have inflammation, some fibrin in here, and a lot of virus in the slough cells that are in those alveolar spaces. So again, inflammation and some virus, all the way out to day 21. Oh, and this study was interesting too. I have all the references, you guys can look these things up, but they did US cattle versus, it's US strains of high path versus European strains of high path. But they had similar findings. Okay, so what questions do you have about cattle? I have a question, if you guys don't have questions. Yeah. Some places have. We are working with some researchers and we have sent some serology for that. We haven't got the results. Now, in terms of PCR, if you want to test for high path, you need to go through the state vets, right? So there was one case where it was possible that we wanted to do more testing. It was a respiratory case in a calf, but the producer said, no, thank you. So we are coming up against that because it's a regulatory test, which means if it was positive, that facility went in quarantine and they just didn't want it. They don't want it. So we are coming up against some of that. But yes, there are studies being done in beef cattle. I'm not privy to any of those results yet. And serologic studies. So maybe we're going to get some information here in the next couple months. But that's a great question because that was close to my question. What do you guys think about high path in dairy cattle? I have a theory. What this doesn't, I mean, any thoughts? Yeah. 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 Absolutely. I love that answer, but I also have another one. The sheer numbers of epithelial cells in a dairy cattle mammary gland versus a beef cattle mammary gland. So remember how influenza replicates in epithelial cells? There are so many epithelial cells in a beef cattle udder. Not beef, dairy cattle udder, right? Because that's what their job is. Beef cattle, when they're lactating, they have increased mammary glands too. But just comparing them to what a dairy cow looks like is, what, maybe 10 times as many? I mean, I haven't done the studies. So I think it is, I can't imagine that a beef cow out in the summer has not come upon a dead goose and put its nose into it and not been curious, right? Because they're out in pasture, no one's looking at them and there's a dead bird and they're interested in it. But we're not hearing any cases of them getting neurotropic. So they may not have, just from the studies alone, they may not have the right receptors, sialic acid receptors in their nasal cavities to get those cells infected, replicated all the way into the brain like a lot of the other mammals do. But then, especially if it's true that it was the milking equipment that started this whole thing, well, we don't really have that in beef cattle either. So those are my thoughts. Any thoughts off of my thoughts? Oh, okay.
Is there cattle?
Yes, in dairy cattle.
I'm just thinking.
Yeah.
Beef cattle.
Yeah. Yeah, absolutely. Yeah. But then then it's like, how are they getting it from a mammary to mammary? So I don't know. We're almost done. No worries. We're We're almost out of here. For lunch, I mean. Okay. Cats. Since 2000 and whatever, 4, there's been over 600 avian influenza infections in cats with over 300 deaths. Many of them have been here this last year, and many of those are actually associated with dairy farms. In terms of location, Southeast Asia, there's a lot of tigers that have been infected. This is just, you'll get this in your notes, but this is where we're at in terms of the cats here in North America, and they have a really high case fatality rate. They do not recover from this. They think that, at least early on, it was scavenging dead birds, but now that with the dairy cattle, it's very likely being around raw milk. But then we also know about the cats with the raw diets, raw meat diets that are also getting it. Maybe there's some fomites. Clinical signs, you just might have fever and appetence and lethargy. There may be respiratory signs, but there may not be. And in fact, a lot of these are just neurologic and then they die. Super fast. This is the study Brett and I did. Here's the lung of a cat that had HPII. Dr. Mitchell autopsied these ones. And you can see here that the alveoli are filled with stuff. And when they put the virus IHC on there, they got it. Same with the cerebrum, cerebellum. You can see the inflammation, a lot of virus, hippocampus. There's some necrosis in here and some virus. And finally, humans, there have been, this has not been updated since last year, but 70 cases. And we've seen conjunctivitis, respiratory disease, but what's interesting is that we're not seeing 60% mortality rate like you see in other countries. So one thought is that in those, especially early on in those other countries, those are just reported, people who go to the hospital. And they're often poultry workers. This is, 20 years ago. But also think about the quality of care maybe in some of these other countries that they may not have access, and they may not have access to healthcare. We've seen it in dairy workers here, and a Mexican resident died. So I believe this is the last one. What do? If you think you are dealing with a high path, is you're going to call the SAHO. So you're going to call Dr. Andrus if you're on this side, or whoever is on the Minnesota side. Remember to wear your proper PPE. If you go to these farms, you'll want to make a line of separation. Try to keep dirty and clean on the right sides. And remember to properly disinfect according to the contact time. I gave you guys a lot of resources. You can look up any of these. And then we ask questions along the way, but we have 1 minute for a question. And I'm here all day unless Dr. Mitchell needs me to go back to the lab. So, okay, great. Thank you, guys. So we have lunch. Please eat. And then get your food, come back to the personal breaks, whatever you need to do. Dr. Mitchell is going to go over those while you're eating. If you want to eat here, she's going to go over those canine respiratory disease cases we had 2 years ago that there was never an answer. So she's going to go over those. Okay. Okay, I guess we'll get started while we're eating. Dr. Mitchell's going to just talk about those cases. She just has a couple of slides to go over. In case you were ever wondering what happened with those canine respiratory outbreak that was talked about all across the country. Dr. Heather Mitchell comes to us after 17 years as a clinician. She worked all over in many different species, large and small. We were very excited when she joined the lab in 2023 as our diagnostician. Her undergraduate was at NDSU, and vet school is at Iowa. And I will let her take it from there. Thanks.
Okay, this is going to be very informal, so it's just about 15 minutes. I'm going to tell you a little bit about what we experienced what we saw during that atypical canine respiratory disease outbreak in 2023. So we're going to go back in time just a little bit. Okay. So in about like the late summer of 2023, we had an increase of canine respiratory illness submissions. So this kind of coincided with what the rest of the United States was seeing around that time as well. So the disease was being called atypical canine respiratory disease complex because they were having, everybody was seeing similar symptoms of the canine infectious respiratory disease complex, but it was, for the most part, pretty unresponsive to any type of treatments, or at least the conventional type of treatments. So from January 1st of 2023 to December 31st of 24, we saw about 42 cases of suspected respiratory or canine respiratory illness. Of those cases, 10 of them were necropsies, 6 were tissue cases, so actual lung lobes. And then we had transtracheal washes, BALs, and swabs as well. And then the swabs were from the caudal pharynx area or ocular mucous membranes. So we received about 64% of our cases in this time period, so August, September, October of 2023. And then we got to the 2023 cases here and then the 2024 cases here. So there was a pretty distinct drop off after 2024 hit. 26 of our submissions were from North Dakota, 14 were from Minnesota, and then we had 1 from South Dakota, and then 1 from Canada as well. So here's just a graph kind of breaking it up by age and weight. So this is a representation of our respiratory cases that we saw. On the x-axis, we got age, and then on the y-axis, we have the number of respiratory cases. And I have it broken down by weight as well. So the green bar is just the total number of cases, respiratory cases per that age. And then the yellow are dogs that weighed greater than 22 kilograms. And then the gray bars are those that weighed less than 22 kilograms. So regarding the weight of the dogs, there was only 32 submissions that had the actual weight wrote down. Okay, so there's going to be a little bit of a disparity between these numbers compared to the total number of respiratory cases. And then for the total number of respiratory cases, I was only missing 1 submission that had an age associated with it. So we can kind of maybe, make an assumption that the greater than 22 kilograms were medium to large breed dogs, and then the less than 22 kilograms were small breed and puppies for this case. So most of our submissions were in that 1 to 4 years old and 5 to 9 year old case range. And then they were the bigger dogs too, so greater than 22 kilograms. And then, as with kennel cough complex, boarding history is kind of an important information as well. So in about 36% of our cases, we had information about, yes, they did go to a boarding facility. About 10% did not go to a boarding facility, recently before they had these clinical symptoms. And then unfortunately, the majority of our cases didn't have any information regarding the boarding history. Okay, so we'll talk a little bit about what we actually saw at the diagnostic lab regarding our necropsies. So there was 10 necropsies and 6 tissue cases that we processed during that time. I'm not going to talk about one of the necropsies because that actually had an actual diagnosis of brachycephalic syndrome. So it was included because, yes, it had respiratory symptoms, but the diagnosis was unrelated to this atypical respiratory disease complex. So of the 9 necropsies that we saw, a lot of them shared the same characteristics of bronchopneumonia, necrosuppurative bronchitis, pulmonary thrombi, and even some hemorrhagic bronchopneumonias as well. The bar graph here also shows the bacteria that we isolated most frequently from our tissue samples as well. So this is tissue samples from necropsies, and then the 6 that we received from lung lobes as well. So we got E. coli was predominantly isolated, and then we got some strep canis and some Peptostreptococcus canis, mycoplasma, and then there was multiple, I think just maybe 2 samples that had no growth, and those were from lung tissue cases that had previous antibiotic treatment as well. Okay, so a lot of our tissue bacterial growth had a combination of things too. So not just E. coli, but there was often multiple bacteria that were isolated as well. Okay. So hopefully everybody is not gonna, like, we're gonna talk about, show some necropsy pictures next. So if you're queasy, I apologize, but this is your fair warning, okay? Okay. So this is a photo from a gross necropsy. So we got the head over this way, the caudal aspect of the animal is over there. But this is from a 8-year-old, 14-kilogram corgi from the West Fargo area. Okay. Clinical signs were dyspnea, mild fever, cough, respiratory distress. Did some preliminary diagnostics as well. So the radiographs had an alveolar pattern in the right middle lung lobe. And the animal was actually hospitalized and deteriorated fairly rapidly within within 24 hours, and then died. Before death, though, they witnessed the development of bilateral pleural effusion. They did some cytology on it, saw some septic suppurative exudate and intracellular rots. So this animal also had treatments with ampicillin, sublactam, enrofloxacin, and ceftazidime as well. So the whole gamut of IV antibiotics were given to this creature. Okay, but on necropsy, there was about 20 mils of red opaque fluid in the thoracic cavity. And then the right cranial lung lobes were red, heavy, and firm as well. And it's important to note that when these were put into formalin, they didn't float, they sank. So there was no air in those pieces of tissue sampled. So that was pretty significant. So the diagnosis for this particular case was the necrotizing hemorrhagic pneumonia, and E. coli was isolated from the lung of this case as well. And then Dr. Heidi did this necropsy and also put down that endotoxemia and septicemia were present as well, and saw some hemorrhage within the adrenal cortex too. So numerous of our necropsies kind of had these same characteristics that we saw as well. And like the histories associated with our necropsy cases kind of varied too. Sometimes it was incredibly acute. There was no prior symptoms, and then sometimes it was maybe a few days of acute respiratory issues and then death. We had some necropsies that had more chronic histories too of a week or so of coughing, and then ended up passing away as well. So the clinical symptoms were quite variable. But we did a lot of testing. So we did testing for canine distemper, influenza A virus, Bordetella, trying to find some sort of cause for this. So, but we didn't find a whole lot. We didn't find any viral diagnostics results, just we had some bacterial growth. Okay. We did get the opportunity to send some samples off though to Cornell in New York. So through the USDA unexplained mortality event classification, we were able to send 8 samples to Cornell for additional testing to find out what this is. Because as you all were probably experiencing, you had kind of being bombarded with all these canine respiratory cases, but there was no answers for anything. That kept showing up negative for all the common things. So we had the opportunity to send some to Cornell for additional testing. They did additional PCR tests, virus isolation, and viral sequencing as well. So a lot of capabilities that we didn't have at NDSU. So they tested for beta coronaviruses, Bordetella, parainfluenza, canine influenza, Mycoplasma cynos, pneumovirus, and Strep zooepidemicus, in addition to virus isolation and viral sequencing as well. Everything was negative. We had 1 sample that was moderately positive for Mycoplasma cynos, but it was likely in that gray area where there wasn't, a complete and definitive positive or a definitive negative. So it was in that gray area. So that was, considered an unlikely primary pathogen for that particular case. So what do we know from, the testing at the VDL? We isolated E. coli and Strep canis most commonly from tissues. We didn't identify any viruses. We did not isolate any Bordetella, and Mycoplasma was an unlikely cause. A lot of our submissions were young to middle-aged dogs weighing over 22 kilograms. And a lot of the clinical histories with it were prolonged coughing, especially for our our swab samples and our BALs and transtracheal washes. A lot of those cases had, prolonged coughing. So rather than just a week or two, these was could range from 2 to 4 weeks. But our necropsy cases were just a smidge different and a little bit more variable. So they had those same symptoms of chronic coughing, or it was more acute, or no prior symptoms prior to death as well. So this was going on in the rest of the United States as well. So what do we know from the rest of the United States? So New Hampshire in the summer of 2022 reported that they had started seeing these atypical canine respiratory disease cases too. And then Oregon saw a great spike in their canine respiratory disease cases too around August of 2023. And then that kind of continued as well in California, Colorado, Florida, and Canada as well. So same symptoms, clinical symptoms were chronic and prolonged cough in weeks duration and unresponsive to conventional antibiotic treatment. The New Hampshire Veterinary Diagnostic Lab and the Hubbard Center for Genome Studies at the University of New Hampshire claim to have found a novel bacterium during this time as well. So I think that happens maybe around December. So they found in 31 of 226 of their screened animals, they found this non-culturable small bacterium that was similar to Mycoplasma in 31 of 226 screen dogs. So that's 14%. But they didn't know what the significance was either. Was it a part of this disease complex making it this atypical and unresponsive, or is it just some sort of incidental finding? There was nobody knew the significance of that particular finding. USDA did some testing in December of 23 as well, and they just found the common respiratory, infectious respiratory disease causes in its investigation. So we really don't know what brought about this atypical canine respiratory disease complex, but we certainly saw an increase of cases submitted. And I know that a lot of the practitioners that I talked to in the area were seeing an increased incidence of canine respiratory disease too. But I'll leave you with this quote from Dr. Weiss. He's from the University of Guelph, Ontario Veterinary College. And we don't know what it is. Maybe it's probably more along the lines of a long-standing, disease that we just haven't diagnosed yet. And the disease pattern that was seen in 2023 doesn't necessarily support the idea of the new, a novel cause for respiratory infectious disease. So basically, I have no new information for you. But I thought it would be interesting to at least talk about what y'all saw out, at your practices as well. Because, we kind of have our submission area from North Dakota, Minnesota, Western Minnesota. But I talked to some veterinarians in South Dakota and, contacted some classmates that were scattered around the US as well. And they, they all kind of told me the same things, that really prolonged coughing, not responsive to anything. And eventually they get better, but it takes like 2 or 3 times longer than it usually should. So did anybody have any stories to share that you guys have experienced in your practices? Kind of support this or see something different? I think my dog had it as well. We were camping in July, but it was July of 2023. And I'm usually very anal about my dog's going to have nose-to-nose contact with other animals. But it just happened that he was tied to a tree and puppies were getting walked by and he went to go sniff the puppies. And then a week later he was coughing and then my other dog got it and Ozzy recovered like normally. He was probably better within like 10 days, but Loki had a cough for a good month or so, but just very mild. It didn't progress to anything serious, but yeah, so we don't know what happened. Was it because the media kind of blew it up and had everybody aware of it that we had a lot more submissions? But I don't know if I totally believe that. I think there was actually really a lot more of this going around, because there's always something that the media has to hear for them to be interested in it. So I think there was a lot more canine respiratory disease going on that kind of brought that to their attention. So
Say that they had something, or they had discovered something, or not discovered, but found something, and they were waiting for to do news release or something to that effect, and then I never heard anything
right.
about that.
Yeah.
Were they working with something in New Hampshire? I thought it was from Kurt Williams, Oregon, but I never followed up with Oregon. I didn't know if anybody else.
Yeah, and I wasn't able to find any additional information about other than what New Hampshire had come up with. So yeah, it was just very interesting and odd. So I don't know that we isolate that very often. Heidi, yeah.
Dr. Maddox will be here soon, and we can ask her, but no, at least from an necropsy perspective, no.
So Dr. Roth asked if we have isolated mycoplasma more often from canine respiratory issues, and we have not. So this is probably the time period in which we had that one, I can't remember if it was 1 or 2 isolated, but not at not anything that we would contribute to be for the mycoplasma being the primary culprit. Okay, yep, and Dr. Quinn also said that Not seeing a lot of histopathologic lesions for mycoplasma, but more hemorrhage as well. Yeah, so I just thought that was a little interesting lunch seminar. Thank you for your patience or thank you for your attention as well.
I'm going to introduce the next speaker, Dr. Holly Hummerding. She is with Pet Poison Helpline. She's been with the helpline since 2014. She received her bachelor's and her DVM from the University of Minnesota. And since working with the Pet Poison Helpline, she's become a diplomat of the American Board of Toxicology and the American Board of Veterinary Toxicology. And she will be presenting on tasty toxin tomes, the toxicological consequences of the palatable pharmacy. And I believe you presented this to ABVT, part of it. And
Part of it, yep.
They're creating more flavorful and more palatable medications for dogs. And when they get into them, it's a problem. So Dr. Hummerding is going to address this.
All right, everyone. Thank you so very much for having me here today to talk about one of my very favorite topics in the Poison Control Center. Before I maximize the presentation, can everyone see my PowerPoint okay? Can someone give me a wave or a chat? I can't hear. I apologize. I'm going to presume you can. And if someone comes to the podium, I'm going to presume you can and we'll fix it. All right, bear with me. I'm going to flip the settings here too for you guys. All right. So because we are remote today, or I am remote for you guys, and thank you for your flexibility with that. I really appreciate that. It's going to be really hard for me to see specifically when somebody has a question. So if somebody wants to pop to the microphone, if there's a specific question, or my hope is that there's going to be a good 10 to 15 minutes at the end of this presentation, since we're going to be together for the next 1.5 hours, 90 minutes until about 2 o'clock today. My hope is that there'll be a good 10 to 15 minutes at the end of the presentation to chat through questions too, but please keep this casual. Feel free to interrupt if you have specific burning questions, and we'll try to address those at the time of as well. And again, if you can't see my slides, okay, do let me know, but I think they're sharing well. So welcome to, again, one of my favorite topics, tasty toxin tomes. As a pet owner, I can wholeheartedly say that I'm incredibly grateful for the fact that we have chewable, palatable medications. I have 2 dogs who are averse to taking medications easily for me, and I swear to you, they can find pills in the tastiest of bits, including pill pockets and bananas. Though I found blueberries to be helpful, but regardless, one of my favorite topics because I find these medications to be very helpful. And this conversation today is not to deter you from using these medications in practice. My hope today is that we take away that client education is key here, and we need to make sure to keep some of these medications in spaces and places where our critters just won't have access to them for safety's sake. But let's dive into the topic at hand. There are quite a few different medications that I want to chat through today. We're going to work through the list from top to bottom and start with our typical nonsteroidal anti-inflammatory pain medications, nonsteroidal anti-inflammatory drugs or NSAIDs. Many of us are familiar with these in practice regularly in many of our patients, and we'll talk about the toxicological consequences of the acute overdose. I do want to touch on antibiotics, though. I think we sometimes forget that antibiotics can cause more than just gastroenteritis in larger overdose situations. So I want to talk about the more multisystemic consequences that we might see with some of these more common antibiotics that are landing in our pet owners' homes. And then Proin, phenylpropanolamine. If any of you have ever had a good old Proin overdose case, you know what a wild ride some of those can be. It's a pretty common medication used for urethral incontinence or urinary incontinence and urethral hypotonus in female dogs these days, and a myriad of other extra label purposes as well. So I want to make sure that we touch on that given its commonality in homes. And joint supplements, again, one of those topics where sometimes I think we fall back on thinking that they're really quite safe. And for the vast majority of them, they are relatively safe. But of course, as Paracelsus paraphrased, or as I will paraphrase in Paracelsus in saying, the dose makes the poison. Anything is poisonous in high enough dose. And we're going to talk about some of the consequences that we can see with those joint supplements. And then the bit that Dr. Malmstrom was saying we chatted about during the ABVT office hour sessions was the bit about the JAK inhibitors, Janus kinase inhibitors. And I think this is what we're all most excited to chat about here today. This is a relatively new corner of the poison control world and the toxicology world in vet medicine, as it's a relatively new family of drugs or class of drugs that we're using in our companion animal patients. Most of us are quite familiar with Apoquel, which is oclocidin maleate. I do not intend to single it out today by presenting the data that I have on it. It's just truly that I have the most data on that medication because it is the most ubiquitous JAK inhibitor that we use in vet medicine. We'll talk about one other JAK inhibitor in vet medicine and then the potential for human JAK inhibitor exposures in our vet patients as well. All right, so let's dive in. There are a lot of different chewable veterinary NSAIDs available on the market, both brand name and generic of those brand names as well. Most of us are quite familiar with Rimadyl and Carprofen generics, similar to Rimadyl, and goodness knows there are chewable tablets abound amongst those different brands. Don't forget about Daramax, though. There are indeed generics of Daracoxib, Daramax, that are available in chewable formulation as well. And don't forget about our over-the-counter culprits. So aspirin is not necessarily your traditional cyclooxygenase 2 or COX-2 inhibitor, but is instead a COX-1, cyclooxygenase 1 inhibitor. But my goodness, is that not readily available to our animal owners? You can get that online. You could get that at most pet stores just by driving down the road and going to PetSmart or Petco. And large box stores carry it as well. And they come in very large bottles and very large tablet sizes, usually about 300 milligrams. And last but not least, meloxicam, Metacam. Now, Metacam for us is oftentimes in liquid formulation. In the human pharmaceutical world, it's often in tablet formulation in much higher doses at a good 7.5 or 15 milligram tab size. But both Canada and Europe make a palatable, chewable tablet of meloxicam as well. And I suspect with time we might see an FDA-approved product too. But at this point in time, we do not have an FDA-approved chewable meloxicam, or at least as of May 16th, when I put this presentation together for you guys. Now, if you remember back from our vet school days, COX enzymes, cyclooxygenase enzymes, and specifically COX-2 enzymes play an essential role in inflammation and pain, which is why they're so beneficial to our post-surgical patient or to our arthritic patients with age. They reduce that pain and inflammation by blocking the production of associated prostaglandins. Your aspirin, your COX-1 inhibitor will do the same. It plays a really similar role, but it's far less specific. And in doing so, can lead to a more vast array of clinical signs. We're really going to focus on our cyclooxygenase 2 inhibitors today because the treatment between the two of them would be quite similar. You'll see these little polls pop up through the presentation today, and I wish I was there in person so I could stare at you awkwardly and ask you to raise your hands in answering these questions. But alas, you guys get to escape my gaze today. I'll just have you answer these personally in this situation, just to kind of stimulate thought as we're working through these varying poisons or toxins. But of these, the following sign is not commonly associated with cyclooxygenase 2 inhibitor overdoses in companion pets. Would you say that that would be neurological signs, gastrointestinal ulcers, KCS, keratoconjunctivitis sicca or dry eye, or acute kidney injury? And I think the vast majority of us are very comfortable with saying that gastrointestinal ulcers and the potential for acute kidney injury are quite common and are our primary concerns with the acute overdose of a cyclooxygenase inhibitor like carprofen, meloxicam, Daramax, piroxicam. All of those would pose risk in a dose-dependent fashion for gastrointestinal changes, ulcers, and kidney injury. But I think we often forget that high enough doses of nonsteroidal anti-inflammatory pain medications can lead to neurological signs. When we look at the human NSAID world, 400 mg per kg ibuprofen would lead to neurosigns. When we look at the veterinary NSAID world, 200 mg per kg of carprofen or Rimadyl could lead to neurological signs. And those are the two most common NSAIDs to lead to neurosigns in very large overdoses, but it can happen with any NSAID. The neurotoxic dose is not well established for all of your NSAIDs though, so please do keep that in mind. So the answer here is KCS, keratoconjunctivitis sicca. There are a lot of drugs that, no, I shouldn't say a lot, there are a fair number of drugs that could lead to KCS in our pets. And the suspicion is that it's an idiosyncratic reaction to that overdose. Of those that we're not going to talk about today because we don't have a veterinary labeled product for it, of those in the NSAID world that could cause that, though, acetaminophen is your culprit. It's more common in breeds that are prone to dry eye, but doses over 30 mg per kg of acetaminophen could lead to KCS in our creatures. We are going to talk about one other medication today in our discussion that can lead to KCS, though, and that'll be your Apoquel, your oclacitinib overdoses as well. So what indeed are the clinical consequences of our NSAID overdoses? Well, it kind of foreshadowed to that. In dose-dependent fashion, at early low doses, we'll see gastrointestinal distress, erosions, and ulcers. And when we look at veterinary NSAIDs, roughly 5 times the high end of the therapeutic dose would be suspected to lead to GI ulcers. So for instance, for carprofen, if your high-end therapeutic dose is 4 mg per kg per day, in the young adult healthy dog, I would anticipate that I'd be more worried for gastrointestinal ulcers at 20 mg per kg in the acute overdose situation. Well, once you hit about 10 times the high end of therapeutic, you're going to start to worry about the risk for acute kidney injury in those kids. So again, if carprofen is used at 4 mg per kg per day, I'm going to worry about acute kidney injury at about 40 mg per kg. Versus meloxicam, my single daily dose after that initial loading dose, my single daily dose is 0.1 mg per kg per day. So 0.5 mg per kg for ulcers and 1 mg per kg for acute kidney injury. Please keep in mind that all patients are different, though. So the very young are pediatric kids. The very old are elder patients that may have some degree of hepatopathy or renal dysfunction, or perhaps are just so young that they do not have developed renal function or hepatic function of yet, maybe at increased sensitivity. So we may have to cut those doses of concern, or what I affectionately like to call quote unquote trigger doses, in half in some of those cases too. And know that those patients who are on NSAIDs chronically might be at an increased risk for troubles too. So we'll always adjust our treatment plan as needed per the individual patient. And then in dose-dependent fashion, we can see those neurological signs. And again, with carprofen, 200 mg per kg, that dose isn't well established for Daramax, for daracoxib, or for meloxicam. On the human side, naproxen 50 mg per kg, that's your Aleve tablets, and ibuprofen, about 400 mg per kg would be your neurotoxic dose. Let us not forget about the liver, though, guys. Of course, with any of our NSAIDs, you could see idiosyncratic hepatotoxicity or hepatic enzyme elevations, even at therapeutic doses. I'm sure you all have had cases in practice where you've used carprofen, and with routine lab checks and lab monitoring, you'll find elevations in alanine transaminase ALT. What do we do to fix these kids? I'm sure you guys have dealt with some of these patients in practice, so this may not be a new treatment protocol or regimen for you, but I don't want to leave without chatting about our therapeutic course in our NSAID patient. So decontamination, of course, we're going to try to decontaminate these patients as quickly as possible. The trouble that we face with chewable medications, though, is they are indeed chewable. So they are masticated and chewed as they go down. They're harder to get back up and out. They also dissolve very quickly, even as compared to a non-chewable tablet. So ideally, with your chewable NSAIDs, you're decontaminating with emesis within 1 hour of ingestion. Now, if you have a dog who gets into an entire bottle, a huge clump of pills, perhaps my heart is hopeful that they'll clump together in the stomach and I have a better chance of getting them back. And I might be a little bit lenient and give you grace and say, let's induce emesis within 2 hours of ingestion. But beyond that, probably not medically helpful in that case. And then I'll reach for activated charcoal, ideally within 1 to 2 hours of ingestion. I'll give a single dose of activated charcoal, often with sorbitol, but if you prefer without or don't carry, we'll use regular. And I dose charcoal at the low end of the published recommended dosing range of 1 gram per kilo. If you guys use Toxaban as your brand, for instance, it's a very popular brand in vet medicine, that would be equivalent to 10 mils per kilo. They're 100 mg per mil concentration. I recognize they don't put that concentration on their bottle. So easy for me to say 1 gram per kilo, hard to dose when you don't have some calculations to roll through in the clinic. Historically, we used to repeat that charcoal. I used to repeat activated charcoal in NSAIDs that underwent enterohepatic recirculation, like carprofen and meloxicam, ibuprofen, and naproxen, every 8 hours for a total of 3 doses. Follow-up doses without sorbitol. Always, always check electrolytes prior to each dose. Make sure they're passing stool at some point, and they've got to be on IV fluids if we're doing multi-dose charcoal. We don't want to face osmotic fluid shifts. The activated charcoal molecule is very large, so is sorbitol. Both of them can lead to osmotic fluid shifts, which can lead to systemic hypernatremia. It's not that they're salty, it's all related to shift of free water within the body, but we really don't want to battle hypernatremia and salt issues in our patient in addition to an NSAID overdose. Nowadays, we've moved on to using a bile acid sequestrant medication called cholestyramine or cholestyramine, tomato, however you prefer to pronounce it. But cholestyramine in humans is used to manage high triglyceride levels. And in vet medicine, it's going to bind up those bile acids in the stool, helping to reduce the enterohepatic recirculation of the vast majority of our NSAID medications in overdose situations. Many of these NSAIDs are metabolized in the liver, deposited in the bile, and eliminated in the feces. A portion of those will be resorbed back into the body, and a portion of that medication is then defecated away. My goal with this therapy is to increase the amount of the drug that's bound up in the stool with bile acid sequestrants and help them to defecate that away. It's readily available at human pharmacies and very affordable. I'm always going to ask that you get the one without xylitol because we don't want to compound our toxins or poison concerns and add on xylitol to that case. But there are many without xylitol available on the market. Dose ranges are pretty wide, 0.3 to 1 gram per kilo. Go on the low end. Your patients won't love this flavor. Mix it in with food if they're willing to eat it for you. It makes it a lot easier to give. And we give that every 8 hours for a total of 3 days for most NSAIDs. Now, daracoxib undergoes extensive first pass hepatic metabolism, and you won't need cholestyramine or multidose charcoal with that one. I also encourage you to reach out in these cases. We'd love to chat through treatment recommendations, and we can decide for that particular patient, the dose ingested, and for that particular drug, if reaching for something like multidose charcoal or cholestyramine would be appropriate. Now, if you get into an ulcerative dose, but a dose that is not yet nephrotoxic to your patient, we might just start with some subcutaneous fluids. If we get into a dose that's going to pose risk for acute kidney injury, then certainly we'll recommend intravenous fluids. There's been a lot of conversation in vet medicine lately as to whether or not we are overusing IV fluids, and I think it's a good conversation to have. But I hesitate to generalize that to all of our toxins. Keep in mind that cyclooxygenase inhibitors will alter how prostaglandins are produced in the body. And our goal is to target the prostaglandins responsible for inflammation and pain. But our concern in overdose is that you lose specificity and sensitivity with drugs. And in overdose situations, you're also then affecting the prostaglandins that encourage good gut lining health and that encourage good renal blood flow. They alter how the renal arterioles are either constricted or dilated. So my goal with fluids is to keep our renal vascular bed open, dilated, and flowing to encourage healthy kidney function and reduce injury if I can. Recognizing that most of our NSAIDs are very highly protein bound and fluids aren't necessarily going to help with enhancing or expediting their elimination, I'm still trying to keep those kidneys quite healthy. So 1.5 to 2 times maintenance, but your fluid rate should always be adjusted per your patient's needs, hydration needs, perfusion needs, and to match ins and outs as possible. GI protectants. I usually reach for a proton pump inhibitor nowadays. Pantoprazole, omeprazole would be appropriate. I like to use a mg per kg twice a day instead of once a day. Seems to be more effective in our canine patients. Alternatively, especially in your smaller patients, you can use H2 blockers like famotidine at the same dose. Pick one or the other. Compliance in owner's hands is such that I'd like to choose one or the other. And then add on sucralfate, carafate in your patient. I do still like to use misoprostol in the appropriate patient. I won't use it in recently bred animals or potentially pregnant animals, and I ask that pregnant individuals not handle that medication out of an abundance of caution. But misoprostol is a prostaglandin analog. So I'm trying to bolster that mucinous barrier and the prostaglandin levels to the stomach by dosing 1 to 5 micrograms per kilo orally every 8 hours for 3 days. And then diagnostics, minimum baseline, PCV total protein, and an NSAID profile or a Chem8, Chem10, something to look at BUN creatinine, ALT, CFOS, and electrolytes when we're giving charcoal to make sure your sodium is normal, is not elevated before dosing that charcoal. and a urine-specific gravity before you start giving fluids to see what that pre-fluid USG is. In an ideal world, we're doing CBC chem lights and UA. We don't live in an ideal world, and understandably, our animal owners are facing significant financial distress. It makes it tough to afford veterinary care in a lot of situations. So if I need to par back and just do what I need to do to get the values that I need to get, I will do that, and do that in any way that's most effective for you and for your pet owners. We'll usually recheck labs daily while in hospital for nephrotoxic doses, and then 1 or 2 days post-discharge as well. What about more advanced therapies? Interlipids, very affordable. It's the IV form of fat. You can give it through a peripheral catheter as well. Plus or minus a filter, there's always a rare risk for a lipid emboli, but the vast majority of us don't end up giving it through a filter. Keep it in the refrigerator between doses. Once you open the bottle or the bag, discard it after 24 hours because it's the appropriate and perfect nutrient bath for bacterial overgrowth if we keep it too long. The purpose of interlipid therapy is to provide twofold, to provide a lipid sink to draw lipophilic fat-loving drugs into the bloodstream, into those intralipids for elimination via the chylomicrons in the body. Distributes it to tissues that don't really care about it, and then those drugs then follow the chylomicrons on out for elimination, is the suspected mechanism. It also provides a direct amino acid nutrition source to myocardial cells to help improve cardiac function and circulation. That's more important for cardiotoxic drugs, but to know there are a few proposed mechanisms. Do we reach for interlipid therapy at the outset of NSAID overdoses? No, we do not. It's tempting because they're very affordable and easy to give, but keep in mind that most of your NSAIDs are very highly protein bound, and lipids do not love to scavenge drugs off of proteins. They'd prefer to just be lazy about it and take drugs that are floating around the serum and plasma without being bound up to protein sources. That being said, when we get into a neurotoxic overdose of an NSAID, we only have so many proteins to which those NSAIDs can bind. And at that neurotoxic dose, you're likely to face a very notable amount of NSAID floating around unbound in the bloodstream, and we have the opportunity to scavenge that away. So I will use interlipids in the asymptomatic neurotoxic dose within the time that it takes to reach peak plasma levels. So within the Tmax for that particular NSAID. I would never ask that you guys keep those particular Tmaxes in mind. Get in touch with us. We'll help you to decide if interlipids are appropriate for that patient. And certainly if they're showing neurological signs, I'll continue interlipid dosing. I do a 1.5 mil per kilo bolus of the 20% solution. After the first bolus, I do a 0.25 mil per kilo per minute CRI for 30 to 60 minutes. And then I'll repeat the bolus every 4 to 6 hours for up to 5 doses in the symptomatic patient, as long as they're not lipemic. I always check a PCV tube to look at the serum prior to redosing, and if we're lipemic, postpone for a couple of hours, repeat once the serum is clear. We don't want hyperlipidemia syndrome here either. So I reserve interlipids for very, very high overdoses of NSAIDs. Extracorporeal therapy, out-of-body therapy. The one we often think about is hemodialysis. Hemodialysis is a sole effort in drug removal for NSAID overdoses is a poor choice. It's too highly protein bound, but if you can do hemodialysis in line with charcoal hemoperfusion, that could be helpful. Essentially adding a charcoal filter into the mix to try to bind the drug as it's moving through that filter. Alternatively, a lot of us have moved to discussing therapeutic plasma exchange in the right situation. So again, neurotoxic doses are very high overdoses. This allows us to remove the plasma from this patient that has the protein-bound drug still in it. We'll discard that plasma and that drug, give them fresh frozen plasma back with their regular blood components that have been spun away thereafter. So those are good options. Hemodialysis I may reserve for the acute renal failure patient, especially those who have progressed to oliguria or anuria. Have to be honest with you, we don't get to do extracorporeal therapy often in our patients just because we may have limited resources to do so and finances might be limited too. All right, before we move on to antibiotics, any questions at all about the NSAID world? And I should let you guys know too, the doses that I'm discussing are all in your standard formularies. NACA, PLUMS, and VIN-Drug formulary will have these doses too. We try to standardize our doses to published formulary doses as much as possible for ease sake, and also because it's good practice, good medicine as well. All right, let's dive into antibiotics real quick. I'm going to take a swig of my water. All right, I want to talk about three main families of antibiotics because not only are these the three most common classes of antibiotics that we may use in practice, they are readily available in chewable form and tend to be quite palatable as well. And they also have some multisystemic consequences that might be more problematic. So we're going to talk about the amoxicillins, the cephalosporins, and the enrofloxacins, the fluoroquinolones of the world as well. Again, lots of varieties out there. This is not an exhaustive list in photographic form of the chewable antibiotics that are available to us in the vet profession, but these will be some of the more common products that we carry on our shelves. So what indeed are the consequences of antibiotic overdoses? Well, it depends on the antibiotic, honestly, but cephalosporins and amoxicillins are going to be quite similar. Certainly, overdoses of antibiotics can lead to gastroenteritis with nausea, drooling, vomiting, diarrhea, and inappetence. But doses in excess of 200 mg per kg in the amoxicillin or the Cephalex and cephalosporin world could potentially lead to drug crystal formation and subsequent renal tubular injury. This happens when the drug concentrations in the urine are saturated and they precipitate out as these very linear, sharp, double-ended needle-like structures. And oftentimes in our patients, we'll see them as singular agents, or they'll clump together in these little brush formations that you see in the bottom right-hand corner of that slide. These images are from human studies that have been completed, but I guarantee if you have a patient that has drug-induced crystalluria from either of these families and you spin down a sediment and see crystals in that urine, it's going to look like this. So I oftentimes direct you guys to Google Images if you're seeing crystalluria to compare and contrast and see if they're similar to the amoxicillin or cephalosporin drug crystals that they're seeing in human UAs too, because they should be. They are truly a drug crystal. You usually see these crystals form within 24 hours or less, and oftentimes they resolve within 24 to 48 hours as well. Now, know that cats are more sensitive, and those patients with pre-existing renal disease, no matter the species, are more sensitive. So for those kids, I will use 44 milligram per kilogram as my dose of concern. For the young adult healthy canine patient, 200 milligram per kilogram. Enrofloxacin is a little bit different. Enrofloxacin, fluoroquinolones in general, will all carry the potential adverse effect or overdose effect of neurological signs in the acute overdose situation. Truth told, it's usually enrofloxacin that's going to cause that. The vast majority of fluoroquinolones will lead to gastroenteritis when consumed in overdose, but enrofloxacin seems to have a higher incidence of neurological changes. And in fact, they studied this in rats. In rats, they looked at enrofloxacin compared to ciprofloxacin and norfloxacin, two other fluoroquinolones commonly used in human medicine, and there was a much higher incidence rate of neurological signs or a seizure risk with enrofloxacin when compared to the other two. Most formularies will indicate that any fluoroquinolone could cause neurosigns, and theoretically they can, but again, know that it's usually enrofloxacin. Doses over 125 mg per kg in the dog or just 20 mg per kg in the more sensitive feline species can be problematic. And your cats are also prone to the potential for retinal damage and blindness, and that blindness might be permanent. It may not be permanent. That is a feline-specific trouble. The mechanism is not entirely well elucidated or clear in this situation, but it's thought that it's potentially related to gamma aminobutyric acid or GABA antagonism in the brain. GABA, gamma aminobutyric acid, is an inhibitory biotransmitter that prevents the body from having tremors and seizures. And if you antagonize that or inhibit the inhibitor, and you're going to have more significant neurological signs develop. This is also documented in human children too. So what do we do to fix these kids? Well, gastrointestinal support is the most common clinical sign that we see will be gastroenteritis. So antiemetics, digestive diets, probiotics, gastroprotectants, all on an if or as needed basis. If we get into a potentially nephrotoxic dose of amoxicillin or cephalosporin, I would encourage IV fluid therapy for a minimum of 24 hours. Let's check a baseline urine sediment at minimum. If finances allow you to get a BUN and creatinine at the same time, at least get baseline, ideally recheck that. And I'm going to recheck a urine sediment and ideally BUN and creatinine in 24 and 48 hours. I'm aiming to hospitalize for 24 hours, so that means that we're going to check 1 day post-discharge off of IV fluids as well, out of an abundance of caution. If we do develop crystalluria, I'm keeping those kids inpatient then until the drug crystals clear, checking those labs daily while in hospital, and then again 1 or 2 days post-discharge. The vast majority of your crystalluria kids need just 24 hours more of care, so a total of 48 hours of inpatient care. With your Batral cases, they will typically be symptomatic for 24 to 48 hours. I'm going to ask, neurologically speaking, that they be asymptomatic for 8 to 12 hours prior to discharge home for a neuro watch, and as based on the duration of action of most of our anticonvulsants. And you can use benzos, Valium, midazolam in this case. You're welcome to use Keppra, phenobarbital, propofol as needed too. Certainly, again, GI support, fluid support. They'll run fluids at about 1.5 times maintenance in these patients, especially if they're having advanced neurological signs. And then once the feline patient is neurologically stable and can be transported to an ophthalmologist, I'll ask that we get an ophthalmologist involved. In the interim, let's keep them in dim, dark light. Minimize the stimuli and rest those eyes, minimize the effort that they need in hopes that we can maintain or regain some of their vision. All right, any antibiotic questions before we move on to Proin? We're cruising today, guys. I'll presume everyone's doing okay, and we can also, again, take questions at the end, too. Chewable phenylpropanolamine, Proin. I simultaneously love and worry about this drug. I had a lab mix. Kelly, my heart dog, rest in peace. She passed away about 5 years ago. She was on Proin for almost 15 years, and she lived to the ripe old age of 16 and a half. And did she have some adverse effects from that medication with time? She did. This is not a drug to choose willy-nilly in our patients. It is great for the right patient. It's labeled for the use of treating urinary incontinence with regards to urethral hypotonus in the female dog at 2 mg per kg orally twice daily for the chewable tablet, 2 to 4 mg per kg once daily for the non-chewable extended release formulation. Right now, the only FDA-approved product available on the market and on our shelves is brand name Proin. But June of last year, the FDA did approve the first generic chewable phenylpropanolamine tablet. The application was submitted by Zyvet Animal Health out of New Jersey. It's not on the market yet, but I would presume it's going to be soon. And I do think there is a market for that as well, so I'm glad to see that that's available. But if you look at your prescribing information, the package insert, the little square of paper that comes stuck to the top of the medication, don't just throw it away. Those are so important. Take a look at the adverse event profile, adverse drug event profile, or ADE profile that we see on that package insert, and look at the various conditions that can occur with use of the medication at therapeutic doses. That'll help you to pick and choose what patients this may be most appropriate in. Overdose situations tend to be an exacerbation of those adverse events, which we'll talk about momentarily. Again, a little poll for you guys. I wish I could be there to see who would want to raise their hands for this one, but we'll think about this ourselves. Many signs associated with PPA overdoses are what in nature? Are they parasympathomimetic? Parasympathetic nervous system is your rest and digest nervous system. Everything is good. You can chill out. Your heart rate's going to lower. Your blood pressures are going to normalize and be lower. It's okay to use the bathroom at that point in time. Maybe take a good nap. So is it parasympathomimetic in origin? Or is it more sympathomimetic in origin, in which case we're stimulating our fight or flight system? Are we tachycardic and hypertensive in preparation to throw some fisticuffs or run away? Are we flushed? Are we warm? Are we agitated because we're just ready to roll? Is it neither of these that the clinical syndrome is very different? Or my favorite answer in this list is I'm not sure, let's talk about it. I think one of the biggest lessons that I've learned in being in poison control and in this particular career over 11 years is that I'm not always going to have the answer, but I'm happy to admit I don't know, and I'll help you figure it out. So I'll give you a moment to kind of think about that one as I grab a swig of water here. So in this particular case, phenylpropanolamine is a a sympathomimetic agent. I almost gave you guys the wrong answer. It's a sympathomimetic agent, very stimulatory in nature. And to be able to get a better idea of what we expect in these cases, I want to take a look at gremlin. Gremlin is truly a case that came through Pet Poison Helpline. I've changed the name and the breed. The weight is the same, but the breed in this case because I had a photo for a corgi and I think corgis are adorable. But this is truly a case that has very recently come through the Poison Control Center and is really a classic case of prone overdose. Gremlin's a 2-year-old female spayed corgi mix. She's 7.9 kgs. The owner gave us a call initially and said, "Hey, my dog just ate my other dog's medication. What do I do?" Gremlin ate one 75 milligram pro-chewable tablet. It was intended for the other dog in the home, and it happened 20 minutes prior to the call, and Gremlin was still nice and asymptomatic. Here's the kicker. Gremlin has a history of tracheal collapse and a very recent history of aspiration pneumonia. It makes things a little bit more challenging for us, but unfortunately, our dogs don't always present us with the most ideal situation for decontamination. So Gremlin made it into the primary care vet, the emergency vet rather, about 2 hours post-ingestion. And due to the pre-existing medical history, they elected not to induce vomiting. And my heart sank when I heard this. I couldn't agree more. Not only do we not want to induce emesis in a dog who has a notable history of aspiration pneumonia, and very recently so, also has a history of collapsing trachea as well, likely a patient who's prone to coughing and increased gag reflexes, or poor gag reflexes rather. But we also have a chewable tablet that was consumed just over 2 hours ago. The likelihood that we're going to get that back by inducing emesis now at this point is pretty darn low. And given the combination of our pre-existing medical history and that time from ingestion and the formulation of the medication and the time it takes for absorption, the medical benefit of inducing emesis does not outweigh the risk. So what do we do in this case? Well, we're kind of in a decontaminate and monitor phase. Activated charcoal could still be helpful in this situation, but given that pre-existing medical history, we should proceed with caution. We did recommend that perhaps we start with an antiemetic and check some baseline electrolytes. Let's make sure that that sodium is normal before we think about giving this patient activated charcoal. If it is indeed not elevated and is nice and normal, let's try to feed the activated charcoal in some canned dog food. Either have the owner try to hand feed it to the dog, or if the dog is more readily food motivated, have them eat it out of a bowl. In this case, if this pup was not voluntarily willing to consume the activated charcoal, we were not willing to force it into Gremlin. We did not want to deal with an aspiration event again, especially this far out, 2 hours out post-chewable ingestion. We're at that tail end where I might find benefit to charcoal anyway. We started with subcutaneous fluids in this case. The dose that this kiddo had ingested was relatively low. So 75 milligrams in a 7.9 kilo dog is, hang on, calculator, 75, 7.9 is going to be about 9.5 milligram per kilogram. Well, I can see clinical signs and doses as low as 3.3 milligram per kilogram. You'll remember we used the chewable tablet at 2 mg per kg PO/BID. We used the extended release coated tablet at 2 to 4 mg per kg PO/SID. Well, it falls within that therapeutic dosing range, doesn't it? We can see adverse events at therapeutic doses with this drug. It is an extra label fashion intended for use for some conditions, again, extra labely speaking, in much higher doses at 8 mg per kg for a very short period of time for 3 to 5 days in breeding male dogs to reduce the risk of retrograde ejaculation in those patients. You can absolutely see clinical signs at that 8 mg per kg dose. Your most severe clinical signs, though, usually occur at 20 mg per kg. So right now, we're in this kind of gray zone area where I want to see how bad this is going to get. So we started with sub-Q fluids, and then we asked them to monitor vitals and blood pressures every 1 to 4 hours, depending on how Gremlin looked clinically and those trends, for 8 hours post-ingestion. Goodness, if nothing happened by that 8-hour mark, you could send Gremlin home. But if we did see clinical signs, we might want to keep Gremlin for a bit of a longer period of time. What do we expect to see? Well, it's kind of a multisystemic consequence to this overdose. In a very sympathomimetic fashion, we expect to see agitation, agitation, hypertension, very profound hypertension, with a reflex bradycardia in most of your patients, very rarely tachycardia. You can see some dermal changes. So you can see flushing, they turn hot pink. Their fur will stand on end, so you'll see pretty impressive piloerection develop. They're not aggressive or scared, it's just a function of the drug. You might see liver injury, you might see kidney injury, you might see ocular changes like mydriasis, or if you have severe sustained hypertension, you can even see hyphema, anterior chamber bleeds, and retinal detachment. And in really severe cases, especially those who have been left untreated for several days, you might see some perfusion-related injury to the myocardium. Some of these dogs will have ECGs, especially those dogs that have been that have faced delayed onset to care and persistent protracted signs, will have ECGs that show nothing but VPCs, ventricular premature complexes. Those can be persistent for weeks to months to even years in some published cases, and do get a cardiologist involved in that situation too. So quite a myriad of clinical signs that we can see. And then on the neurological side, you can see tremors and seizures in really advanced cases or very large overdoses. The vast majority of our clinical signs occur within 2 to 4 hours, rarely out to 8 hours of ingestion in our cases here at Pet Poison Helpline, and they may last for 1 to 3 days. 90% of the drug is eliminated within 24 hours of a therapeutic dose, but we have to give that a little bit of grace when we get into a big overdose. Those kidneys can only work so quickly and so hard for elimination. So it can take a little bit longer for your overdose patient to recover and head home. Mechanistically speaking, Proin acts as a nonspecific adrenergic agonist that stimulates postsynaptic alpha-1 receptors in the canine urethra. Those receptors are also present in the eye, in the blood vessels, in the ophthalmic smooth muscle. It also increases the release of norepinephrine and reduces norepinephrine uptake, and that increases smooth muscle contracture at the bladder neck and in the urethra and at the urethral sphincter to try to reduce the risk for urinary incontinence. Norepinephrine also stimulates beta-1 receptors in the heart. So you can see where some of these adverse events are occurring even at therapeutic doses, and certainly you will see an exacerbation of those troubles in large overdose situations too. So what happened with Gremlin? Well, we heard back from the emergency vet clinic 4 hours post-ingestion, and Gremlin was classically symptomatic. They were noticing piloerection, erythema, not on this list, but Gremlin was also quite mydriatic. Mildly bradycardic with a heart rate of 70, but pretty impressively hypertensive with a systolic of 190. My goal in these kids is to maintain a heart rate between 50 and 180 and a systolic blood pressure between 90 and 180. And I recognize that 180 is a little bit high. Ideally, it's less than 160 when they're in the clinic, but that helps to compensate for nerves in clinic as well. And that's also the level where I'm going to worry about perfusion-related injury and where I can confidently say, hey, this probably isn't our patient being quite nervous or scared. This is quite likely the drug talking to us. So what do we do in this case? How do we manage Gremlin now that we're symptomatic? We've already gone through the decontamination process for Gremlin. We might want to think about some additional diagnostics. Initially, we ran electrolytes to confirm that the sodium was not elevated before giving activated charcoal. Now, because Proin could rarely in overdose situation lead to liver and kidney enzyme elevation, I'm going to want a chemistry, maybe a Chem 8, Chem 10, maybe an NSAID profile, but some additional diagnostics would be really helpful. Then we're going to monitor vitals and blood pressures pretty closely. Initially every 1 to 4 hours, but if we have upward trends of our blood pressure, we might bring that to every 30 minutes to 60 minutes while we get that under control, and then bump back to every 1 to 2, 1 to 3 hours thereafter. If you have sustained cardio signs that are difficult to control, it's a good idea to monitor an ECG in these patients as well. And if you have a dog head in that has had a delay in onset to therapy in managing that overdose case, I'd absolutely recommend an ECG to look at the rhythm of that heart. On the neuro side, if you have a patient who's agitated, aggressive, pacing, panting, let's reach for some sedatives. And I love ace-promazine in this case for twofold purpose. It's a nice sedative, and it's also a peripheral vasodilator that can help to manage that blood pressure, that hypertensive state of your patient. I start with a 0.05 mg per kg dose IV. I wait 30 to 60 minutes, and I'll repeat that dose if my signs persist. If we're severely agitated, I'll also add in butorphanol 0.2 mg per kg IV, which will have some anxiolytic properties as well. But what happens when we have our dogs nice and sedate on ACE and they're still hypertensive? Well, in that case, we're going to have to think about some antihypertensive agents. We might grab a vasodilator like hydralazine, which comes in an injectable form, but you can also get an oral formulation at the human pharmacy pretty affordably so as well, scripted out. Or we'll reach for an antihypertensive agent like amlodipine. Now, the cardiologist and internal med specialist will ask that in dogs, we pair amlodipine with an additional ACE inhibitor like enalapril or more typically benazepril. Chronically speaking, the use of calcium channel blockers as a sole agent in dogs may increase the risk for glomerular blood flow changes and glomerular sclerosis. Oh my goodness, say that 8 times fast, guys. Regardless, by giving an ACE inhibitor like benazepril or enalapril, you alter the blood flow such that that would not be an expected consequence. Dr. Asiera was out at the Hawaii Vet Medical Convention conference, and I went to one of his presentations on this topic and asked him specifically whether or not we need to consider concomitant use of those 2 drugs in cases like this with a proin overdose with sustained hypertension. And he, as a cardiologist, preferred that we do so. I'll be honest, in practice, that's not something that's done as frequently, as most of these dogs just need 1 single dose of amlodipine to get them under control while we wait for that drug to eliminate. But to know that that conversation will be out there as well. And then kind of standard GI support as needed in these cases would be appropriate too. So it really comes down to symptomatic and supportive care as based on the clinical course in your patient. There's no antidote for phenylpropanolamine. We need to support them as they eliminate that drug. Hope to enhance elimination with fluid support, but it's a nice tightrope that we have to walk with fluid support. I'd love to drive them at 2 times maintenance to enhance elimination. But if we're hypertensive, we don't want to volume expand our patient either and contribute to that hypertension or increase risk for renal injury. So we may have to temporarily discontinue IV fluids or cut them down to half maintenance while we get blood pressures under control. And then it's just symptomatic and supportive care for neurological signs and blood pressure and cardio changes in these kids. Precisely what we rolled out with for Gremlin. Gremlin did quite well, did require a couple of doses of acepromazine and 1 single dose of amlodipine to correct our hypertension. Gremlin went home just over 24 hours post-exposure. If I remember correctly, it was about 30 hours post-exposure to the time point of discharge. And again, it's one of those cases where I ask that these pets are asymptomatic on nothing but IV fluids for a nice 8-hour window as based on the duration of action of most of our therapies prior to discharge home. That rounds out Proin, phenylpropanolamine. How's everyone doing? Any questions about that one? From the sound of it or lack thereof, things are going well. I hope folks aren't asleep yet. I find this very interesting, but I know to some it may not be as interesting. So I hope I'm keeping your interest peaked here as we move on to joint supplements. And this is a busy slide, guys. I don't expect you to read the fine print. My goodness, I'm sitting right in front of the screen and I need a magnifying glass to be able to see this. This is here to illustrate the fact that joint supplements are not created equally. They aren't in the human world either, but over-the-counter and prescription joint supplements intended for use in dogs and cats can vary significantly in the ingredients that they carry, and there may be some different toxicological consequences that we then have to assess and address in that particular situation if they get into a large overdose. These are very flavorful. This is an expensive treat for our dogs. They'll eat the entire container if they can, and sometimes they'll eat the container with it too, especially our Labrador Retrievers. Here's looking at you lab friends. The most basic and most standard of joint care supplements is represented by the Purina Pro Plan joint care product on this slide. This is a pretty standard glucosamine chondroitin supplement. The ingredients list is rather simple in comparison to the others, and the active ingredients list is rather small. You've got glucosamine, you've got collagen, chondroitin sulfate, you've got omega-3 fatty acids, and hyaluronic acid. In your inactive ingredients, I'm going to point out the 3rd inactive ingredient here, which we'll talk about in just a little bit, of glycerin specifically. This is not unique to joint supplements. This is a soft chew ingredient, very commonly found in soft treats. Think pill pockets as well, and then your joint care supplements or soft chew medications in general. If we compare that to the Zesty Paws product, this is an 8-in-1 multivitamin bite. If I had just looked at the main label, the main highlighted name to this product is Zesty Paws 8-in-1 multivitamins. As a pet owner, I would never say this is a joint supplement. I would say, great, I'm giving my dog a multivitamin. Nothing more to worry about here. And of course, there are some vitamins and minerals and multivitamins that might be problematic. But if you dig into the active ingredients label for this product, you can actually see that at the core, at the heart of this particular supplement, this is a glucosamine chondroitin supplement with omega-3 fatty acids as well. So very similar to what we're seeing with the ProPlan product, but now we're going to add in some vitamins and minerals that we need to assess and address in our patients. The vitamins and minerals and multivitamins in general that I look for in being more problematic. Iron's a big one. This doesn't contain iron, but iron is a big one on the human side. Vitamin D3, also labeled as cholecalciferol, or vitamin D2, alternatively labeled as ergocalciferol. D3 is more dangerous than D2 by about tenfold. We would worry about manganese. And if we look at the third active ingredient down on the active ingredient list for this joint supplement, you'll see manganese highlighted there. And then we're going to look at selenium. There's no selenium in this product. We might look at magnesium in multivitamins. It's usually in low enough doses where it's not terribly problematic. It's usually magnesium as a sole supplemented aid where we start to worry for that. But the other vitamins in this particular product, your vitamin E, B, your vitamin C, are all going to carry a wide margin of safety and can contribute to GI distress, but wouldn't pose risk for multisystemic consequences. What's up with manganese, though? Manganese is a heavy metal, really commonly found in joint supplement chews and also other multivitamins, but not exclusive to multivitamins. Manganese in high enough doses might damage the liver. And roughly speaking, this isn't well established in the literature, but after doing an extensive literature search and comparing and contrasting it to our cases at Pet Poison Helpline, roughly speaking, about 16 mg per kg might be problematic in these kids. This is a pretty low dose at 0.5 mg per chew. And of course, dose dependent on how many chews you're giving to your dog. You may be dosing anywhere from 0.5 to 1.5 mg with each therapeutic dose. Then let's take a look at the Daysequin Advanced product, something that we might have more readily available on our shelves at the vet clinic, right? So still a good glucosamine chondroitin supplement. Then we've got our manganese on the bottom, which we briefly talked about with the Zesty Paws product as well. But let's take a peek at that proprietary blend. Not too worried about boswellia. That's actually frankincense. I'm not too worried about boswellia or curcuma. Green tea extract, they actually use a decaffeinated variety of green tea in Daysequin products, so don't worry about caffeine toxicity and overdoses. But alpha lipoic acid is a big problem in high enough doses in dogs and cats. Cats are more sensitive than dogs, and dogs will worry about doses exceeding 50 milligram per kilogram. This is a proprietary blend, so you can't parse out based on this list exactly how much alpha lipoic acid is in this product. I do know how much is in this product. It is very, very confidential and proprietary, so I can't share it with you, but if ever you have a case, I can calculate it and tell you what your risks are based on that. Many veterinary manufacturers are wonderful in working with us from that perspective, as long as we keep that information confidential and proprietary. Alpha lipoic acid mechanism unknown can lead to very profound sustained hypoglycemia, ataxia, tremor, seizures, significant gastrointestinal signs, severe liver failure, and even kidney injury in our patients. So it's not something to be taken lightly, and you'll find that in a lot of human multivitamins too. Medically speaking, it does have good antioxidant benefits in our DJD and arthritic patients. So in an appropriate dose, it is an appropriate therapeutic modality too. So what do we expect with a joint supplement overdose? Well, for small breed dogs and cats, anything over 15 to 20 soft chews. For medium breed dogs, anything over 25 soft chews. And for large breed dogs, anything over 50, maybe 75 in the giant breed, soft chews could be problematic regardless of their ingredients. Certainly, we worry about gastroenteritis with these big overdoses. They are very prone to vomiting, nausea, drooling, diarrhea. In rare cases, those soft chews might clump together and form a bezoar and a very rare foreign body obstruction. Your soft chews are made from large molecular weight ingredients that may cause a shift of free water or an osmotic fluid shift of water into the gut that can lead to systemic hypernatremia. Again, it's not that they're salty, but they look salty. Hypernatremia can lead to neurological signs. It's beyond the scope of this particular conversation, but I find the mechanism to hypernatremia really fascinating in that it causes the brain cells to physically shrink and it peels the brain away from the calvarium, and that's how you start to see your neuroscience develop. It's pretty rough. Glycerol and glycerin can do the same, can certainly cause osmotic fluid shifts, can also cause cerebral dehydration without hypernatremia as well. It's documented pretty well in lab species. We have some really rough glycerol, glycerin overdose cases with large soft chew ingestions, including pill pockets, which don't have an active ingredient to them when they get into large quantities of pill pockets, that develop severe protracted neurological signs due to hyperosmosis syndrome. Those are really tough cases to manage. We're seeing more of these now with migraine caps that contain a combination of glycerol or glycerin and sodium polyacrylate. Again, beyond the scope of this conversation, but just a brief mention that you'll find this in a lot of different products. But I am also very worried about severe, profound liver failure in rare cases. But if it happens, you'll never forget that case and you'll never forget that it's happened. It has led to death or humane euthanasia due to poor prognosis and progressive clinical signs in some of our patients. The liver failure can be profound enough that you'll see these patients become notably coagulopathic and hypoglycemic, just secondary to liver dysfunction as well. There are 3 published papers that implicate manganese as a potential culprit. And I do like that theory because manganese is a heavy metal and does like to damage the liver. We do have cases without labeled manganese, however, that have still progressed to develop liver injury or evidence of liver injury. So could it be that they have unlabeled manganese? Absolutely. Could it be glucosamine chondroitin that's causing the troubles? Maybe. The jury is still out, but I certainly take pause and my hackles go sky high when I start to see joint supplement ingestions in very large quantity that contain manganese. I'm going to take those cases a little bit more seriously. Of note, the first 2 papers measured elevated manganese levels in hepatic tissue post-mortem. In one of the cases, in the Jaffe case, 1 dog survived after 6 days of intensive care. The other dog in the household died at the 48-hour mark. In the first case, the Borchers case, that dog was euthanized 6 days in due to very poor prognosis and severely progressive liver failure and signs. In the Wolf case, that patient survived. The samples were taken, the manganese samples were measured from urine and stool and not from hepatic tissue specifically. So what do we do to fix your joint supplement, kids? This is a great opportunity to decontaminate. Your soft chews, when consumed in large quantities, might clump together in the stomach and be pretty darn slow to digest. If we catch this one within 4 to 6 hours of ingestion and they haven't already spontaneously started vomiting and returning product for you, let's induce emesis. If they vomited or retched just once or twice and had poor return, think about inducing emesis. If you have enough finances or money to go ahead and do a lateral abdominal x-ray to look at the quantity of ingesta in the stomach before you do so, please feel free to do so. But I wouldn't hesitate to induce vomiting if we've previously had poor return and you're within a good time frame. We're then going to follow up with an antiemetic. Make sure to confirm that your patient is euhydrated clinically and with a PCV total protein, a body weight if you have a past history of their body weight, and in looking at electrolytes. If they are euhydrated and their sodium is nice and normal, then we'll give a single dose of activated charcoal. Again, with sorbitol, if you have it. If you prefer against or don't carry it, use regular, and dose at the low end 1 gram per kilo. Give a good dose of subcutaneous fluids to the relatively asymptomatic patient, as long as we check baseline liver values. Look at that liver profile and specifically make sure the ALT, alanine transaminase, is normal. A lot of these dogs will be your elder patients who have a history of DJD. Alkaline phosphatase has many isoforms. One of them is a bone isoform. I'm sure many of you have had dogs in practice, elder dogs in practice, that have mild to moderate ELK phos elevations, or goodness, your cushingoid dogs will too. But ELK phos is not specific to the liver, so I really pay most attention to alanine transaminase in these guys. As long as your liver values are normal, we'll do sub-Q fluids and send home a 1 to 2 week course of your favorite combination of SAM and milk thistle, something like Denamarin. I'm not a brand specific person on that one. Let's recheck a liver profile in 2 and 4 days post-ingestion, 48 and 96 hours sooner if we see progressive clinical signs. Now, if we have evidence of hepatic injury, that patient has earned some IV fluids. I generally avoid LRS because lactate's metabolized through the liver. Probably most important if the ALT is really severely elevated, over 800 to 1,000, then I would choose something like Plasmolite or Normar in these cases. We'll continue your Denamarin or your favorite combination of SAM and milk thistle, but if we have really notable ALT elevations, usually anything above 3 to 5 times high normal, I'm going to start cases. And N-acetylcysteine is brand name Mucomyst. I'll affectionately call it NAC. NAC is the antidote to acetaminophen. But in this case, and in a lot of other hepatotoxin cases, we're using it as a free radical scavenger and a beautiful antioxidant for hepatosupportive purposes. I dose it just the same as I would for an acetaminophen case. So we'll give that IV. If you only have the oral/inhalational form, you can still give that IV as long as you give it through a little 0.22 micron filter for bacteriostatic purposes. Otherwise, you can give it orally. And something that tastes good. So slurry of canned dog food works really well. Low sodium chicken broth, no garlic, no onions works pretty well. I find Gatorade to be effective. Humans take it in cherry 7-Up or apple juice, and they make sure to put a cover over it and drink it through a straw because it smells and tastes terribly. But regardless, I'll add that on board. And if your ALT reaches above 800 to 1,000, I might start to get a little bit concerned about the potential for true liver failure. In that case, I'm going to monitor coag profiles for coagulopathies. If they're coagulopathic, we're going to talk fresh frozen plasma transfusions. And I might just start vitamin K1 to at least support factors 2, 7, 9, and 10, your vitamin K1 dependent clotting factors. I can't catch them all, but it's a very safe therapy and very affordable therapy to add on board to try to support that patient. Other hepatosupportive agents might include vitamin C, 20 to 30 mg per kg every 6 to 8 hours. Oral dosing in the dog is very poorly bioavailable, so you'll want to give that injectably if you've got it available. Vitamin E, 50 to 400 units per dog per day orally. That's usually used in chronic hepatopathy conditions in the dog, but if you're throwing everything but the kitchen sink at them, they may be helpful in these cases too. All right, the moment of truth, we're going to dive into JAK inhibitors, Janus kinase inhibitors. Before we do so, we've got about 30 minutes left, and I want to leave enough time for questions at the end. But any questions about joint supplements, antibiotics, phenylpropanolamine, or NSAIDs thus far? Everyone doing okay? I don't know if you can hear the golden retriever dreaming in the background, but she's chasing some bunny rabbits right now. All right. Janus kinase inhibitors are pretty new to the veterinary profession. They are not new to the human profession. There are lots of different reasons that they use immunomodulating agents in the human profession. And I was chatting with a good friend of mine. He is a human pharmacist who works in oncology at the University of Minnesota specifically. And we were talking about Janus kinase inhibitors in humans. And I was, inquiring as to whether or not they were seeing such significant troubles as what we're seeing in dogs. And his brief answer was, well, Holly, humans aren't eating a whole bottle of this at one time, so no. So they aren't seeing the evidence that we're seeing for multisystemic consequences with the overdose situation in humans because they don't have similar overdose situations to the degree that we have in veterinary medicine. It's just to say that the data on the human side for overdoses is incredibly limited, and the data until now on the published side in vet medicine was non-existent. We do have a bit more data that's been published, which we'll highlight here in a moment. There are 2 FDA-approved products for Janus kinase inhibitors in vet medicine. Zenrelia is a non-chewable tablet, available at 4.8, 6.4, and 8.5 tab sizes, with 15 mg tab sizes being the highest. And then Apoquel is the one that most of us are most familiar with. Zenrelia is pretty new. Apoquel has been out there a little bit longer. Chewable tablet formulation is newer. Chewable tablet was originally FDA approved in June of 2023, went to market in October of 2023, and we started seeing our first very odd overdose cases that really threw us for a loop shortly thereafter. I remember it was mid-October, and I reached out to Pet Poison Helpline vet management side and said, hey, I'm getting these cases while I'm on call, and this is really strange. What do you think is happening here? Because this has me very worried for what's going on. This shouldn't be happening. And it really snowballed from there and has been a really impressive path from there, and to try to determine mechanistically what's happening in these overdose cases and to decide on treatment recommendations as these cases tend to evolve and develop. As we take a look at this, again, I don't mean to single out oclocinin and maleate or Apoquel. It's just where I have the vast majority of my data. We have had similar clinical consequences with overdoses of human Janus kinase inhibitor creams. They looked identical. I don't have a significant number of Zenrelia overdose cases. I did a search in our database just last week, and I had less than 20 cases. The vast majority were very small overdoses. For instance, hey, I accidentally gave my dog a double dose of this medication. And thus far, we saw mild lethargy. So we're going to focus on oclacitinib simply because that's where I have the data for you guys. This, of course, can be extrapolated to other potential similar products. But here's your palatable poison poll. Hopefully you've read through it and have had a moment to think about it. But oclacitinib maleate is approved for use in the following species: A, horses; B, dogs; C, cats; or D, all of the above. Give you a moment to think about it. I think most of you could probably get this one, that B. It's actually approved for use in the dog. The labeled therapeutic dose is 0.4 to 0.6 mg per kg. You start with that every 12 hours for about 14 days, 2 weeks, and then you drop them down to once daily thereafter. Now, that said, there are extra label therapeutic doses suggested for the dog for other dermatological disorders. The highest dose that I was able to find in Plum and VIN drug formularies at this point in time was 1.125 mg per kg orally every 12 hours. It was used in one case report in managing a perianal fistula. They continued that high dose until they saw remission of that fistula, and then they decreased the dose thereafter. In cats, extra label published doses in Plum and VIN drug formulary range anywhere from 0.4 to 1.3 mg per kg for various dermatological conditions, pemphigus foliaceus, and asthma. And in the horse, there are suggested therapeutic doses of 0.25 mg per kg or 0.1 mg per pound to help to manage pruritus secondary to atopic dermatitis in the equine species. You will not find that published in a formulary just yet, but it is published in one paper out there, and there is a kinetic study in horses too. In fact, we're going to talk about the mechanism of Janus kinase inhibitors shortly, but they actually, through their studies, have determined interleukin-1 to be the primary cytokine responsible for inflammation and allergy in the horse. Look at 3 different cases side by side and compare and contrast our expectations to what happened in these particular cases and the clinical outcomes in these situations and therapeutic course in these situations. We have Nugget and Reggie. And by the way, these cases came in within the last 3 months to the Pet Poison Control Center, Pet Poison Helpline. These are very, very real cases. I don't have the outcome for some of them, unfortunately, but they've been lost to follow-up. But I worry about the outcome for one of them, which you will see why in just a moment. But Nugget and Reggie are actually in the same household, and the owner originally called about Nugget. One of the 2 cats in the house decided to push a bottle of 16 milligram Apoquel chewable tablets off of the counter, and they really suspected Nugget was the one that consumed the medication. It's Nugget's medication. Nugget loves this medication. It is very, very highly palatable. So Nugget loves this medication, and they don't think that he would hesitate to consume it. They suspect he consumed approximately 30 of those 16 milligram tablets 25 minutes prior to the call. That's a 480 milligram dose. He's a 12-year-old male-neuter terrier mix weighing in at 14 kilograms, and that would put him at a 34 mg per kg dose. The owner originally declined to add the cats to the case. Nugget arrived to the emergency clinic approximately 1 hour post-ingestion and was asymptomatic. The owner returned home after taking care of Nugget originally, and we'll talk through what we did for treatment and decontamination shortly, but returned home from the emergency clinic several hours thereafter to find that Reggie was significantly symptomatic. They don't know how many tablets Reggie would have ingested. If he did consume all of the 30 tablets, we would be at 100 milligram per kilogram. Reggie presented then to the emergency clinic with acute onset lethargy, vomiting, and diarrhea. The owner initially noticed profound lethargy when they got home from the emergency clinic, watched Reggie through the remaining part of the night and into the morning, and presented to the emergency clinic 18 hours post-ingestion. You'll see why that has me so worried. 7 is our 10-year-old male castrated quarter horse. He's about 500 kgs. He's got some allergies. He takes Apoquel therapeutically, but he decided to consume 40 of his 16 milligram Apoquel tablets. He is a big kid though, so that comes out to be 1.28 mg per kg, and he was asymptomatic. As compared to extra label therapeutic doses in the dog, that's a hair over therapeutic for other species. As compared to labeled intended therapeutic doses in the dog, that's about a double dose. So not terrible, right? So what do we expect to see and why? Well, for that, we have to look at the mechanism of action of Janus kinase inhibitors. Janus kinase enzyme pathways are going to play a very important role in many different bodily functions. Your oclocinate malleate and your Zenrelia are primarily going to have JAK1 inhibition with a little bit of Janus kinase 2 and 3 inhibition. But the JAK1 enzymatic pathway ultimately results in the production of interleukin 2, 4, 6, 13, and 31. These are the primary cytokines responsible for inflammation and allergy in the dog. Again, interleukin 31 being the primary identified in the horse. And as we use oclocidinib as a JAK inhibitor, we're preventing the formation and release of these particular cytokines to reduce allergy and inflammation in our pets and pruritus associated with those conditions. So all in all, our goal is to reduce inflammation and pruritus. Seems simple, right? Well, what do we see in these overdose situations? They can be pretty rough. Let's take a look at Nugget first. 4 hours post-ingestion, we got some labs, CBC Chem. Our white cells were mildly leukopenic at 4.47, normal's 5.06. We were mildly neutropenic at 2.68, our normal is 2.95. We had a mild ALT elevation of 145, high normal's 125. Could that sample have been hemolyzed? Sure, maybe. I don't know that answer for you. That wasn't documented in the case, unfortunately, but we do know that post-collection hemolysis can lead to a 25% elevation of ALT above the high end of normal in some patients. So take note, watch it, but I wouldn't be up in arms about a 20-point increase in ALT at this point. Elk Foss was mildly elevated at 275, high normal's 212. He is a senior pet, so he was about 12 years old, but he did have recent normal values on his senior wellness exam, according to the owner. I don't have the dates or the values for those. His BUN and creatinine were normal at 26 and 1.1. 30 hours post-ingestion, and this was after then we saw Reggie come into clinic as well, but 30 hours post-ingestion, everything had normalized except for that mild elevation in ALT. So your white cell count was up to 7.8 with neutrophils at 4.83. ALT was still 133, so we were just 8 points above normal, not too shabby. Elk Foss normalized at 190. BUN and creatinine were 20 and 0.6. This patient had been on IV fluids, which we'll talk about momentarily. So those are anticipated changes to BUN and creatinine while on IV fluids, and I'm fine with that. Most importantly, blood pressures and heart rate remained normal throughout this 30-hour window. Heart rate ranged between 105 and 120. Blood pressure was 99 to 171 systolic. More typically in the dog, I expect to see profound sustained tachycardia within 6 hours of ingestion. And then you'll start to see more significant multisystemic consequences from there. We're going to take a look at the whole set of clinical signs that I would expect in these cases in a moment. But as owner brought Reggie into the hospital about 17 to 18 hours post-suspected exposure, he had a normal heart rate and was exhibiting no signs of ocular changes at that point in time, seemed a little bit brighter and improved per the owner, but was notably anemic. We went from a normal hematocrit as a young adult healthy cat to 36 18 hours post-ingestion and 24 30 hours post-ingestion. Now that's on a good clip of IV fluids. We were neutropenic. White cell count was just 1.73 with neutrophils hanging out at 0.93 and very notably azotemic. BUN was 63 and creatinine was 5.3, just 18 hours post-ingestion. Potassium was touch low at 3.4. 30 hours post-ingestion and on IV fluids then for about a 12-hour window. We were more notably anemic, hematocrit of 24%. BUN was 79, creatinine was up to 8.21. Our potassium had normalized with supplementation to 3.7. Looking nothing like the canine or feline counterparts, 7, our quarter horse, clinically normal, seemingly fine. Nothing seemed to be bothering 7. I have no data in horses, so I asked them just to monitor labs out of an abundance of caution. 30 hours post-ingestion, we rolled out with a CPK, a CK of 4,000, high normal 360, with an LDH of 800, high normal 450, and an AST of 445, high normal of 420. So the vet was calling back to see if we had any documentation of musculoskeletal injury or drug-induced rhabdomyolysis in the equine species. And this, it's hard to say if that was the instance in this particular case. If it was, this would be the first case of that occurring. On the human side, in younger humans, young adults, and teenagers, Janus kinase inhibitors have indeed led to drug-induced rhabdomyolysis in rare cases. So could that be related? There's a potential. There was no known injury to this horse, no known excessive work in this horse during that 30-hour window after that drug ingestion to explain away these lab work changes. We lost that horse to follow-up. I don't know what the outcome was in that case, unfortunately, but clinically was doing fine. We advise not to ride the horse and continue rechecking those values pretty closely. So what do we expect to see? Well, historically, we expected to see gastroenteritis in these guys. Now we know that with large chewable overdoses, especially to the degree that we are seeing and with these dogs getting into entire bottles of the medication, multisystemic consequences. We now have one published retrospective study in looking at the multisystemic consequences and incidence rates of oclocidinib maleate overdoses. There were a few of us here at Pet Poison Helpline that put our heads and our hearts together and worked on digging this out and looking at data and getting this out there into the field as quickly as possible, given that allergy season was upon us this spring. And as of April of this year, you can find this in the Journal of Medical Toxicology to give you a more detailed summary of our expectations and these consequences, and to look at the proposed mechanism in more detailed fashion. But in summary, we expect overdoses to lead to nausea, drooling, vomiting, potentially soft stool or diarrhea, typically within 6 to 8 hours of ingestion. Shortly thereafter, you'll see profound sustained tachycardia. We're not talking heart rate 160, 180. We're talking heart rate 240, 250, even in large breed patients. Blood pressures are initially normal, but then with time, they actually become bradycardic and hypotensive. On the ocular side, you'll see third eyelid elevation. You'll see chemosis. Droopy eyelids is a very common description, and you may even see periocular swelling. And dry eye. We're seeing a notable increase in KCS cases in these patients too. It does seem to be temporary. On the CBC side of things, we're seeing leukopenia and neutropenia primarily, but any cell line can be affected. Of note, leukopenia and neutropenia are among the adverse events with therapeutic use of this drug that you'll find in the prescribing information pamphlet associated with the drug too. We're just seeing a rapid onset and more notable changes in overdose cases. We have seen profound azotemia and acute kidney injury, especially in our feline patients, but in some of our canine patients as well, and mild to moderate ALT-ALK-Phos elevations. And mild to moderate liver enzyme elevations were also appreciated in drug safety studies, and you'll find them on the label as well. They do resolve by discontinuing the drug. And we found that to be quite similar in our cases too. On the neuro side, they're usually very dumpy, lethargic, and weak. And electrolytes, you'll start to see hypokalemia, maybe hypophosphatemia. Initially, the ocular, the cardiovascular, and the electrolyte changes look a lot like a beta agonist overdose, like an albuterol overdose. The rest of this looks very different, but it may be that it's playing around a bit with beta receptors, and we do know that Janus kinase inhibitors can indeed play around with beta receptors as well. But mechanistically speaking, what do we think is causing the more multisystemic consequences that we're seeing in this case? Well, our suspicion and our proposed theory is that excessive Janus kinase inhibition and blockade of the cytokines associated with Janus kinase pathways can lead to a very, very profound negation or inhibition of those particular pathways in cytokine production. But with time, we see this drug eliminated. And the half-life to oclocidinib maleate specifically is about 3.5 to 4 hours. We're seeing our clinical signs really kick in at about 6 to 8 hours in line with that elimination of the drug. And our suspicion is that as the Janus kinase pathway is disinhibited, we will see a massive release of pro-inflammatory cytokines and essentially see a cytokine storm and potentially mast cell degranulation, death, or mast cell movement changes. A lot of these clinical signs mimic the clinical signs that you would expect to see with mast cell activation syndrome in humans and with cytokine storms in humans. There is one paper that I dug up that suggested that mast cell activation syndrome is actually a subclassification of the cytokine storm. So to keep that in mind as well. But our suspicion thus far is that this might be related to a massive release of cytokines in a subsequent cytokine storm, and it's leading to severe clinical consequences in our pets. Ideally, you want to decontaminate these patients within 1 hour of ingestion. The Tmax in these cases is very rapid in onset within less than an hour of ingestion of the product itself. So 1 hour, induce emesis, get activated charcoal, and if you can, Could intralipids be helpful? Well, I look at the partition and distribution coefficient of a product or chemical in a test tube to decide if maybe intralipids would be helpful in vitro, in vivo in our patient. And I'd like them to be above 2 in a test tube in vitro if I could. I'll still use intralipids if they're above 1. Well, our partition coefficient for oclacitinib is 1.46, and our distribution coefficient at a neutral pH to mimic blood is 1.9. So we're close and we're over 1. So we have moved to starting with use of intralipids in some of these cases too, but it's early days, guys. I don't have great results for you yet on that one. Could hemodialysis be helpful? I think so. The molecular weight of the product itself is small enough, and the protein binding is low enough that hemodialysis may be helpful. But the Cmax is reached so quickly with that rapid peak plasma level, and the elimination is so rapid with the half-life of 3.5 to 4 hours that you have to hit it fast with hemodialysis. And financially speaking and realistically speaking, that's a resource that most of us don't have. So we may not be able to use that for drug removal in a timely fashion, but we can use it in a severe acute kidney injury case as well. Mainstay in therapy right now is going to be diagnostic monitoring and monitoring CBCs, chemistries, electrolytes, and a Schirmer tear test as baseline. I'm going to recheck my CBC minimally in 48 hours and then every 5 to 7 days thereafter until it normalizes. I'm going to recheck my chemistry, at least ALT, ALK phos, B1, and creatinine in 24, 48, and 72 hours, typically daily while in hospital and 1 or 2 days post-discharge if we see more severe signs. And I'd like to recheck a Schirmer tear test in 24 to 48 hours, depending on the degree of ocular changes. We do recommend IV fluids for a bare minimum of 24 hours. If we do start to see lab work changes or notable clinical signs, we'll push that out to 48 hours. We're going to monitor vitals and blood pressures very closely. And if they're very tachycardic but bright alert responsive or even agitated, let's try a dose of butorphanol first, 0.2 mg per kg IV, and see how they respond. But the vast majority of your cases are going to come in really dumpy and lethargic, and you're not going to want to use butorphanol if they're already lethargic or QAR. So in those cases, we're using beta blockers. In most of my cases, one single dose of a beta blocker like propranolol, 0.02 to 0.06 mg per kg IV slowly, has been sufficient to control the tachycardia that we're seeing in these patients. If we do see dry eye, we're reaching for topical cyclosporin or Optimune as a brand name. It is temporary in nature thus far. I don't have a permanent case to offer for you guys, but tear stimulants and then lubricants, ocular lubricants can be helpful, artificial tears. If we see ALT elevations, we'll reach for a combination of SAMe and milk thistle. So again, something like Denamarin. I haven't had cases where we've seen such severe ALT elevations that we need to move on to an acetylcysteine to NAC of yet, but we'll keep that in mind as well. And we are now moving to suggesting, and this is just of last week, we are now moving to suggesting one single dose of dexamethasone as a steroid. Now, interleukin-6, which is affected by your JAK1 enzymatic pathway and that blockade with Janus kinase inhibitors like oclacitinib, interleukin-6 in humans and its inhibition has been associated with gastric perforation. So at this point, we're just recommending one dose of steroids, but our hope is that one dose of DexSP at either low-dose immunosuppressive or certainly a good dose for an anti-inflammatory purpose can be helpful. Our hope is that it can be helpful in trying to minimize some of the pro-inflammatory consequences of a massive cytokine release. Again, jury's still out on whether or not we're going to see good benefit from that of yet, but we've started recommending it very recently. In the paper that I referenced previously that was published in April, you'll notice that our dose of concern was tagged at 15 milligram per kilogram. We've had an impressive allergy season with a really large number of overdose cases with oclacitinib maleate. And as we analyze that data, we have now lowered our dose of concern in the cat to 8 mg per kg and in the dog to 10 mg per kg. This is an evolving treatment guide for you guys. This is an evolving toxicity and poisoning and an evolving clinical course in our canine, feline, and now equine patients, because we have an equine case as well. So to please know that we'll need a bit of grace as we try to figure out what's best for our patients in these situations and what the best clinical course would be. And again, before we finish out today, I want to make sure to reiterate, I don't want to deter any of you from using these medications in practice. They have proven their safety. They typically have to prove safety at 0, 1, 3, and 5 times therapeutic during their FDA approval process. They have good, well-published, readily available adverse event profiles to assess as you're prescribing those drugs. It comes readily with your product in hand to review as you're prescribing those drugs, to know what to expect with therapeutic doses. The cases that I'm talking about here are significant overdoses, and to know that they still have very good medical benefit. And I, as an animal owner, also still feel comfortable in using these medications. This guy on the right is not the one that was dreaming moments ago. This is her brother, Dandelion. He is my allergy dog. I have lived life with Labrador retrievers and golden retrievers, and I was due an allergy dog, and he's my allergy kid, and he is on oclacitinib. He is on Apoquel and doing quite well on it. This is just to say that we are stewards for the safety of our pets, our patients, and our fur kids. We want to make sure to communicate to our clients that chewable medications and supplements should be put on the third shelf of any cupboard, away from cats that may knock it down and away from counter surfing pups. These are really preventable exposures in a lot of cases. That's going to round me out for the day, guys. I hope we have enough time left for questions, about 10-15 minutes or so, but what can I answer for you? What burning questions or comments do you guys have?
Are there any questions for Dr. 5 minutes?
Holly, just call me Holly.
Questions? That was really interesting. How about a round of applause? And still any questions?
If you guys have any questions as well, you're welcome to reach out by email. My email address is my name. It's hhummerding, HHO, M as in Mary, M as in Mary, ERD as in dog, ING at safetycall.com. You're always welcome to email me.
Contact the lab.
Yeah. Yeah, we can also provide your email from the lab. So
Sounds great. Thank you.
thank you so much.
Thank you guys so much for having me. I appreciate you. Have a great weekend out there, everyone. Take care.
Well, treats are here. Should we, what do you guys want? Because we're going to try to wrap up. Well, we'll get moving along so we can get out of here by 4:30. What we have left for the day, please keep helping yourself to snacks. Just get up whenever you need to. We have, the next one is, sorry, is that case reports?
Yeah.
Some case reports. Sorry, there's stuff happening at the lab and a tech is calling me. So, but I'll take it in a second.
Yeah.
We have some case reports. Dr. Steichen and Dr. Stanger are going to present some things that we've been seeing at the lab. And then after that, we have a toxicology section with Dr. Mostrom and Dr. Steichen. And then after that, Dr. Maddock will be talking about samples. And so just a quick introduction to the four of them, though they probably don't need introductions since you've all worked with them. They're all section heads. Start with Dr. Mostrom. She is our toxicologist. She went to vet. Do you want me to go back to your history? She went to vet school in Iowa many moons ago, but ultimately she's DVM PhD and she has, she's boarded in toxicology. She's been our toxicologist for many years. We are so lucky to have her. She's an expert in large animal toxicology. And if you guys haven't had a chance to come by the lab and see that toxicology lab, I really encourage you to do that. We're happy to show you all the amazing equipment that she and her chemist use. I think Kelly's already gone, but Kelly, the chemist, she works in there as well. So our toxicologist. Then we have Dr. Steichen, Dr. Quinn Steichen, NDSU for undergraduate master's, DVM at Kansas. But she was our resident at the lab and she passed boards last summer. So she's yes, clap, please. It's amazing. Huge effort and accomplishment. End of the day. I woke up at 3. So, Dr. Steichen, boarded pathologist, again, lucky to have her. Then we have Dr. Stanger. She is a PhD level molecular biologist. She runs the molecular lab. I think you did everything at NDSU too, right? It's another NDSU. But Dr. Stanger, expert in molecular diagnostics, including PCR and sequencing. So she can help you with any of your PCR questions, as well as if you want to do any kind of sequencing stuff, any sequencing research projects or just projects in general. Then we have Dr. Maddock. She did a bunch of stuff at NDSU, but also got her master's with UND. She is trained as a medical laboratory scientist, but now she has a doctorate in public health, and we use her for both as expertise in medical laboratory scientist, but also in as a microbiologist, bacteriologist, and public health expert. They're going to take you for the rest of the afternoon, and I'm just going to let them go if that's okay. You guys, please stop and ask questions along the way. You can make this as interactive as you want it to be. These are your laboratorians for the lab, and we are here to help you. Okay?
So Dr. Stegan and I are gonna kind of take through this case a little bit. So it's on a pigeon, which not a normal species we usually get in, but it was kind of vigorous. Okay, so kind of history, a show pigeon that had traveled out of state. It came back, had been quarantined for a little bit, and then started to show some unusual signs. They've had 4 other birds die. They didn't tell us exactly how many birds were at their place total, but they weren't so concerned about the others' death. But 2 weeks, one had a head tilt, bright green excrement. It died, and then that's the bird we ended up getting. They had another one after we received this one that had some symptoms, but again, the rest of the barn had these ones that had traveled were fine. No recent medications or deworming, but they did get the bird to us. And I'm waiting. So now Dr. Stiggins.
Yep. So Dr. Stanger asked me, I was actually the one that did the necropsy or autopsy on this bird. I will use the terminology autopsy, necropsy kind of interchangeably, so don't let that trick you up. So when we do our bird necropsies at the diagnostic lab, they are always done in a biosafety hood. That's just basically because of high-path avian influenza or Newcastle disease. So when I received this bird, unfortunately, it had pretty marked autolysis. Basically, the tissues have kind of started to rot. This is pretty normal. But externally, the bird had a body score condition of 1 out of 9, so very, very thin. I could easily palpate that keel bone on that bird. And then when I opened up the colonic cavity, the kidneys had multiple tan to yellow, poorly demarcated foci, and the ventriculus, also known as the gizzard, if you are not familiar with your bird anatomy. The gizzard head was bright green in discoloration. Additionally, there were multiple rods, which we would expect. Now, unfortunately, I am not always great at taking pictures while I do my necropsies, autopsies, particularly with birds when we're in the biosafety hood. That also adds a little bit of some cumbersome to it. But I did find a paper that had similar lesions. And so here is A, which is showing kidneys, if you've never seen kidneys inside a bird before. And it's kind of difficult to tell, but these were really subtle lesions in this picture and in the actual necropsy. But there's these areas of pallor right there, where there's just a little bit more yellow, again, poorly demarcated. L is showing the ventriculus, and as you can see, it is bright green. Moving on into histology, the rose lesions were mostly in the kidney. That is where I also found the lesions as well on histopath. So when I look at this slide, at this magnification, my eye is kind of drawn to areas of blue. In the pathology world, these areas of blue, I think something's added. Whether this is inflammation, whether this is neoplastic cells, something blue is added into those areas. Additionally, my eyes get drawn here. there are these two well demarcated clear spaces within the kidney. Altogether, at this magnification tells me these are the areas that I want to go down to on higher magnification and figure out what's going on. So on higher magnification, those blue areas were indeed inflammatory cells. And those inflammatory cells were lymphocytes and macrophages. They were infiltrating within the interstitium, so there was a chronic inflammation. And then the tubules are actually ectatic. And so those are those two well-demarcated spaces. And the tubules, meaning ectatic, means they're just distended. The epithelium was attenuated or flattened. And so my diagnosis for this case was chronic multifocal lymphohistiocytic interstitial nephritis. But now is the time that I kind of ask myself, what potentially caused this? Is this a background lesion or is this something more?
So with our bird cases, high path avian influenza is one of the first things that pops up to mind. And spoiler alert, this is not a high path case. It didn't fit the mass die-offs. That doesn't mean that can't happen. But the owners were concerned about it. So definitely something we wanted to keep in mind. Merrick's, no tumors. Again, often high mortality, poultry, we get that through the lab occasionally, not common in pigeons. But then another bird test that we can run in the lab along with high path avian influenza is avian paramyxovirus or Newcastle. High path and Newcastle fall into the foreign animal disease category. So we do the testing as part of the NALN, the National Animal Laboratory Health Network. And so when we run the PCR assays for high path and Newcastle, it's the same assay that labs across the country that are part of NALN and the reference lab at NVSL run. So again, testing, clients were worried about high path or other infectious agents because they had a number of birds. We had been told that they had reached out to other people at that show they had been to out of state. Fortunately, nobody else had been reporting any deaths or birds with symptoms. I did contact Dr. Coons, the North Dakota State Board of Animal Health, because we were going to test for high path and Newcastle. And so the State Board of Animal Health can kind of determine if we're going to go into that foreign animal disease investigation. So we ran the PCR for high path, the matrix gene, and then Newcastle, the matrix and fusion. So results for matrix with influenza, very nice, not detected. Those two curves are just the controls. We have an extraction control and the PCR control, so that looked great. Now, when we did the matrix for Newcastle, not looking so nice. So we did get right here, this red curve, that indicates detection of that fragment. So we call it, or we have to term it non-negative, which basically is a positive. This is a very late CT, not a very high threshold, but it definitely was like kind of an oh shoot moment when we saw that come up. But then with matrix, this is just kind of a general gene that screens for paramyxoviruses in general. And then, so this caused the reflex for the fusion, which the fusion gene, that one deals more with the actual, is this a virulent strain or not? So fortunately, that came out as not detected. And because of this situation, we ran both the Newcastle fusion and matrix twice, just to make sure that the results were the same. So we were looking at more of a non-virulent form of Newcastle, which was kind of, it was nice to know that it was a non-virulent form. Otherwise, we could be seeing a California situation where they get Newcastle outbreaks quite often. And it causes a lot of testing. So again, virulate CT for matrix. We did send this sample to NDSL. So any positive or non-negative high path or Newcastle samples have to get sent to the reference lab. NDSL got a not detected, but I talked with them and they were not concerned about it for a number of reasons. One, the postmortem state. We received the sample kind of a while after the bird had died, and then it was another 4 days before NBSL received a sample. So there could be degradation in that time frame. So the sample tested days later, limit of detection. So that curve was not as high, or did not look quite like our control curves. So it was a later CT kind of at that limit of detection. But then NBSL suspected that it was a specific pigeon paramyxovirus. And so there was no need for an animal disease investigation. And just a little bit on the avian paramyxoviruses. So there's at least 20 serotypes, and they have all sorts of different variants and genotypes within there. So there's dozens and dozens of different strains of paramyxoviruses. That fusion protein is kind of that main determinant of virulence. And so that's what that second PCR assay targets. Some of the species that is pretty common are the double-crested cormorants, doves, pigeons. And again, these species often have a host adapted strain. So they can they co-evolve together. Paramyxoviruses can infect humans. Spread through exhaled air, saliva, secretions, feces, eggs. Pretty hardy viruses that can survive in the environment, but they're inactivated by heat and direct sunlight. So this is the particular genotype that is host adapted to pigeons. And again, that one generally doesn't cause significant mortality. But some of the clinical signs of this genotype, asymptomatic or sudden death, prolonged disease, weight loss, sneezing. But what I have in bold here are ones that we did hear from the owner and the veterinarian that this particular bird had. So it fits. No treatment. There's possible vaccination available. So takeaways, birds can die of other things than AI. Husbandry, nutrition, exposure, predation. Those are some pretty common ones. We've had cases where they're like, we need matrix or AI tested, but it's pretty clearly predation. But again, so please call North Dakota Board of Animal Health or us if you kind of see any indication of rapid mass die-offs in birds especially, or kind of suspect any other the foreign animal diseases like African swine fever, classical swine fever, and foot and mouth disease. We want to know ahead of time before you're bringing in any samples or any animals, because there's kind of a chain of events that we need to put together and get the testing done as fast as possible. We have particular samples that we have to have for testing. We can't just test any random sample for these things. And those samples, call us and get samples to the lab as soon as you can. That is it. Any quick questions?
Okay. I'm here to talk to you about going a little bit past your basic type A. We'll get into that a little bit more here as we go along. So the signalment and case history, August 2020, we had and this is case number 1. I'm going to be presenting 2 cases simultaneously. We had a 5-month-old Black Angus heifer calf. It was in a herd of 150 cattle, a commercial herd. One of 2 calves was found dead after unilateral hind limb lameness was noted. Second case was in August of 2022. So this is case number 2. We had a 2.5-month-old bison bull calf, unknown herd size, but it was one of 6 calves found dead with no previous clinical signs. So the gross findings on this case number 1, pericardial fibrosis effusion, fibrosis peritonitis, scattered hemorrhage in the lung lobes and thoracic body wall, and then left him hind limb skeletal hemorrhage. Case number 2, pericardial fibrosis effusion, sorry, can't see on my slide here, fibrosis peritonitis or pericarditis, scattered hemorrhage in the lung lobes of thoracic and abdominal body walls, and then left stifle fibrosis arthritis. So I'm not a pathologist, but I can tell you that there's a lot of hemorrhage here, and this is unusual. There's also the fibrin strand all over on this section of the abdomen, more hemorrhage. So the histologic findings then, after the pathologist reviewed, in the pericardium, we have fibrinosuppurative pericarditis with intralesional bacterial colonies. Hind limb skeletal muscle had necrosuppurative myositis with peromyceal bacterial colonies. In the intestine, we had serosal and mural hemorrhage with mild enterocolitis, with rare crypt dilation and necrosis. Pleura, diaphragm, left stifle had extensive fibrin and hemorrhage. I should say the case history and all of the pathology is courtesy of Doctors Pecoraro and Webb. Didn't mention that at the beginning. So here's the pericarditis. See the myositis, normal skeletal muscle, everything else is the inflammation. Here's the peritonitis and mural enteritis. The pleural and diaphragm fibrin and hemorrhage. And then so we performed some ancillary tests to complement the histology and the gross findings. Case number 1 in a respiratory culture, we had Pasteurella multocida. It was negative for Mycoplasma, bovine herpes, BVD, BRSV, and coronavirus. Same situation for case 2, except also because the enteritis had included rotavirus Clostridium parvum. And this sample was also positive for type A Clostridium perfringens, and this was done because of that hemorrhage noted in the intestines. Wow, you're showing me a presentation about Pasteurella multocida. What is exciting about this? If you've had a bovine case, you've probably seen Pasteurella multocida. So I channeled little Owen Wilson here with that, realizing it maybe not isn't exciting. But considering the entire picture, so that massive hemorrhage, and then both pathologists actually recognized that this was really unusual hemorrhage for what they were seeing independently, which impressed me very much because neither of them had seen that. They just knew that this was a thing. So the additional studies that I'm going to tell you about coming up confirmed hemorrhagic septicemia. Very passionate about this. I completed all my doctoral work on it, so love some Pasteurella multocida. So I'm excited to tell you a little bit more about it. So, in case you thought Pasteurella was boring, I'm here to prove you wrong. I don't know if you can move this window at all. Yes, go up there. Oh, sorry. Sometimes I'm incapable of working the laptop. But in the meantime, okay, so this is what Pasteurella, or really mucoid strain of Pasteurella, looks like when we grow it up on culture. That'd be the most common sign or colony morphologies we would see with bovine respiratory disease. Same with when we would see them in human patients, they'd be typically that really mucoid. Also seems to have a predisposition for respiratory sites when you get those more mucoid colonies. But Pasteurella multocida literally translates out to killer of many. So there are 5 capsular types, A, B, D, E, and F, and each has a predisposition for certain diseases. So type A, that's what you're typically going to see with cats and dogs. In cattle, that's the primary cause of bovine respiratory disease. In poultry, that's the cause of fowl cholera. Rabbits, that's where we're getting snuffles. And then humans. And guess where humans are getting those from? Typically going to be the cat. Yesterday I Googled Pastorella multocida cartoon, and it came up with a cat biting somebody's hand. So I thought that was clever and also really, really accurate. There's all sorts of studies showing that just the number of bite wounds that are associated with Pastorella multocida in a cat. Perfect. So types B and E are the causative agents of hemorrhagic septicemia. Type D is going to cause atrophic rhinitis, shown here. In swine, there's also some complex interactions with other bacteria, but it's got a special toxin. And then in cattle, it'll also cause bovine respiratory disease pretty commonly. Type F is again associated with cats and then humans, and cats are the reason that's associated with humans. So hemorrhagic septicemia, it's an endemic disease in Asia and Africa, and it's considered a foreign animal disease in the United States. Officially, it was last reported in 1969, but there have been outbreaks in the US in 1912, 1922, and 1965, and those were in Yellowstone and Montana, and those were bison herds. In 1969, that's the last officially reported case. So if you were to Google it and you were to look on the APHIS website, that's the one that shows up. It was dairy calves in New Jersey. And then in 1993, there were actually a case that I found in some case reports, and a pathologist had noted and it presented at a conference in 1993. And it's seeming that there's a global reemergence of this pathogen, or just because we have different tools, we can actually identify it. So in 2020, there was a beef calf in Alberta, Canada. That would have been the same year as our case one, but also in Germany, Hungary, and then in 2009 and 2022 in New Zealand. Treatment, it's really, the isolate is going to be really susceptible like most other pastorellas that haven't been in a feedlot. But there's going to be poor outcomes if there's signalement present. Grossly, so you're going to see swelling in the neck and brisket regions. That would be, I guess, the classic sign for hemorrhagic septicemia. And that's usually what you'd note. And by then it would be too late for treatment for those animals. So our cases, we could just look at it and be like, this is hemorrhagic septicemia. It was a good suspicion. So I had to do some searching and find someone to do PCR testing on it to be able to confirm the capsular type. I did explain the capsule is something that with the bacteria that helps it evade the immune system, and it can also determine the type of disease it's causing. Sequencing, I know one of the talks talked about LPS earlier today that's causing inflammation, but that's also something we can use to differentiate bacteria. But a genome alignment was performed, and our case clustered with those ones from New Zealand and Canada and the 1969 New Jersey cases. It was similar genetically, and they're a really unique lipopolysaccharide compared to the classic cases. All the ones in Yellowstone were this 2,5, and ours were a 3,4. So based on this, was able to create a method. So this is our MALDI-TOF mass spec. So it's this cool instrument that we routinely use for any cultures that are brought into the lab. It identifies bacteria. It makes a fingerprint of proteins and then compares it against a computer database, and it tells us what the identity of the bacteria is. I was able to use that technology and create a model to actually identify what was unique about these strains from other Pastorella strains. And it identified this unique fingerprint that differentiates it from the others. So instead of having to do PCR or sequencing, I could very quickly look and see on the computer in real time that it might be suspicious for this. So there's a publication out on that. And I guess upcoming, like, what are the other steps? I have other Pastorella multocida strains from humans. I've got that publication in the works. There's also an historic collection of all of these strains that I've mentioned that I really hope to get my hands on in sequence. It's all described in a publication, which is really fun. That's how I found out about that 1993 case from California. This is that hemorrhagic septicemia strain. If you remember the other one that looked really mucoid, this is a lot drier. It looks really benign in terms of bacteria. So takeaways for you guys, Pastorella multocida is a fascinating, enigmatic bacterium. It is a killer of many. And just to be on the lookout for unusual gross lesions, and it's potentially particularly in the summer months. Both of our cases were in August. Other situations, they mentioned that they are in like rainy or warmer months, and it does seem to disproportionately affect younger animals, so less than 6 months old, or most of the case studies. And we have tools to investigate it, so it's just something of interest. If you need any more, also had published this case study that just published in the Journal of Veterinary Diagnostic Investigation here in May, and then also went on a podcast, talked about this wonderful bacteria. My references, I guess with that, do you have any questions? Okay, thank you for listening.
All right, we ready to move on? All right, so buckle up because you have to for this talk and I think maybe the next talk as well. And so my case presentation is, I tried to go a little punny with it. It took me a lot longer to figure this out than I care to admit. And it is it really yellow you? And so if you cannot guess by the title and the picture, this is going to be based more on small ruminants. Though there are a few bullet points at the very end on dogs and humans, so I did kind of wrap it back up the small animal seed. And so my case history is I was presented with a 7-month-old Dorset ewe that presented to the diagnostic laboratory. The client just found the animal dead. No clinical signs prior to finding dead, totally fine. They did note that they found this animal dead in the laying down position. Additional history was that the flock was sheared 2 weeks prior. They are current on CDT, which is a clostridial tetanus vaccine, and they were poured for lice. So on autopsy, this ewe had a body condition score of 4 out of 5, so she was well conditioned. But interestingly, she had a very diffuse yellow subcutaneous tissue, or she was very thick. When I opened up the abdominal cavity, the liver was slightly swollen, was soft and red to orange in color. And these are pictures that I took of the necropsy, so I feel very proud of myself that I actually took these pictures, and I did not take them from a publication. And then bilaterally, the kidneys, I know, were deep red, brown to black, almost a gunmetal color. I had a pre-vet student with me out on the floor that day, and as soon as I saw these kidneys, I was very excited. This is pretty much a classic disease that I have never seen come on through the post floor. So once I saw the kidneys, I went and collected a sterile syringe, and I collected urine from the urinary bladder. The urine, as I suspected, was this dark red, almost port wine color. So since our main lesions for gross necropsy were in the liver and kidney, that is also where the histologic lesions were at as well. So in the liver, there are 2 areas I want to point out. First, one, the portal tract and the central vein. Now, the veterinarians in the group, thinking back to microanatomy, the portal tracts contain a portal vein, a bioductal, hepatic artery. Remember, this is where blood flows into the liver. And then it goes down into the central vein, and then it goes back up to the heart. The central vein down here can also be known as the central lobular zone. And in this particular case, all of the lesions were kind of focused around the central lobular zones. The hepatocellular cords are disorganized and dissociated. Hepatocytes within these areas are either swollen and they contain these 1 to 2 well-demarcated vacuole changes, as well as some other hepatocytes were very shrunken and hypereosinophilic or pink, with a very condensed nucleus. Additionally, there were areas where there was this gold pigment, and that's bile. So my morphologic diagnosis was hepatocellular degeneration and necrosis, central lobular, diffuse, moderate with biostasis. Now moving on to the kidney. The proximal tubules were hepatic or distended with this dark red, almost hyaline-like material. The epithelium that lines those proximal tubules, sometimes it was absent. There were other areas where it was attenuated or flattened again. And additionally, there was also areas where they were there, but there was this granular pigment or this colloid material. And so my morphologic diagnosis for this was tubular degeneration and necrosis,
diffuse severe with multifocal tubular granular and hemoglobin counts. All right, so anybody have an idea about what my diagnosis is for this sheep? Be brave. Classic. So at this time point on the gross floor, I went ahead and I called the client because I was pretty sure this is what the diagnosis was. I also called Dr. Mostrom out just to make sure I wasn't being crazy and that I was actually seeing the lesions that I was seeing. I had a conversation with Dr. Mostrom and she recommended that I run a trace mineral analysis. Now the trace mineral analysis we normally run on liver, but this one we ran on the liver and the kidney. The reason being is because in the current case, the liver copper concentration was 233 parts per million. Anything in the liver for copper is toxic above 250 parts per million. However, you can't really see it, but this is the kidney. And the area that I want to show you is the copper in the kidney. The copper was 61 parts per million. With anything greater than 18 is toxic. So this animal had a toxic level of copper in the kidney. Additionally, we saw high iron. This is seen with induced hemolytic crisis. So my diagnosis is a copper toxicity. This is something that I have not seen come through the post floor in a sheep before with these classic of signs. It is something that is taught to us during my pathology residency. There's some classic gross pictures of this. But sheep are really susceptible to copper tox. And usually it's this chronic copper intoxication. Their causes can be anywhere from excessive copper intake, which is most likely what happened in our case. There can also be an increased availability of the dietary copper. This is usually due to low levels of molybdenum. It can also be if this animal is ingesting other hepatotoxins, such as pyrrolizidine alkaloids. So let's walk through the pathogenesis of this. So specifically in this sheep, in our case, they were getting elevated dietary intake of copper from somewhere. That copper is actually accumulated in the liver, in the hepatocytes, and it's stored there. Then there is some sort of stressful event. In the current case, this is when we were having all of the weird barometric pressures going on. Additionally, it was during that time period where we were having 90-degree days, going down to 50-degree nights, 50-degree days. This animal was sheared 2 weeks prior. I did read a case report where they thought that holding feed for 12 hours was their stressful event. So what I took from all of this is that sheep just are stressed in life in general, and they just like to die. But the stressful event here, we don't really quite know, but there was some sort of stressful event. When that happens, there can be insult to the liver, and those hepatocytes rupture, and there is a massive release of copper. That copper then starts to cause lipid peroxidation of red blood cells. This leads to intravascular hemolysis, and that hemoglobin then causes the acute tubular injury and hemoglobinuria. Causes of death in these cases: acute anemia, liver failure, or hemoglobinuria associated acute tubular injury, which is the newer terminology, I guess, for hemoglobinuric necrosis. Okay, so here's the dogs. This is my tie into the small animal. Dogs can also have hepatic copper accumulation. This can be due to a primary metabolic defect, secondary to abnormal hepatic function, chronic hepatitis, cholestasis. It can also be due to a consequence of excess dietary copper intake, like the sheep in our case. For primary metabolic defects, Bedlington Terriers are probably the most described. This has been described since 1979. This is a progressive lifelong copper accumulation. It's an autosomal recessive, usually due to the mutation in the COMD1 gene. Now, there are other breeds that can be associated with copper accumulation. The breeds are listed, mutations are known. Google is helpful in those situations. The big difference between these breeds is that it's not a progressive and lifelong copper accumulation. Other species can get copper tox. Ruminants and pigs can get acute poisoning.
if there is an accidental ingestion of a large dose of copper. Or they also can get chronic poisoning due to feed or diet supplementation errors. In humans, this is known as Wilson's disease, and it is due to a mutation in the ATP7 gene. So my take-home points. Sheep are particularly susceptible to copper intoxication. Usually it's due to a chronic ingestion, so that finding the initial cause of that high copper can be difficult. Additionally, the other big take-home point is if you suspect copper toxicity, if you're a mixed animal practitioner, or you have sheep of your own, really, we want to have you submit liver and kidney. The kidney is the key here, because although they're storing all that copper in the liver, by the time they're having a hemolytic crisis, that copper's gone. It is now in the kidney. There are my references. And I thought this was maybe fitting. My family as well does not ask me about my job anymore, now that I deal with mostly dead animals. So. With that, any questions?
Just one animal affected?
There were multiple animals.
Okay.
So I was the first one that received the animal, and then Dr. Pecoraro did get another animal after that. I believe it was just two.
Just the two.
But there were a couple that were feeling ill
Yeah.
and sick that they had drawn blood on as well. So
No idea what the source.
they submitted feed, but I never got the results of that. I don't think that they found anything in the feed either.
When you talk about sheep's propensity to die, do you have any studies that bring that forward, or is that just massive anecdotal evidence?
Massive anecdotal evidence from either practicing or dealing with them through the post floor. Yeah. And if you love sheep, I'm sorry, it's a joke.
Well, sometimes you wonder how they could not be dead sooner.
I know.
How did they live here?
Okay, with that, anybody else? Going? All right. I have the next one too. I'll be able to. Oh, that's fine.
You can have to remind you. Well, no, I actually moved it over in the.
Yeah.
When Jill started talking about the micro and the words, I was just like.
So, Brianne was one of those sequencing that I needed, and so it's one of like.
So
It was,
Name all of them. Give each individual.
just.
Oh, Chuck.
That option yesterday. Sure.
We'll see.
Yeah, she goes, I won't do it, but if I do present, I correct. And she goes, what? I go, no, I'm like, if you don't present.
Okay.
You can take a break and keep rolling.
Are you guys ready to keep rolling, or did you guys need a break?
Want this now or later?
I'll take it now and. Oh, we're actually, we're not doing it already.
I just think shot. I bought it and I didn't buy it. That's the bag. You know.
Okay. So how this whole topic came up is a couple months ago, we were throwing around different ideas of what to present for this communication. And Dr. Mostrom and Dr. Webb worked up a case of zinc phosphide toxicity. And zinc phosphide toxicity is not something that I commonly think about. And it does have a huge human health implication to it. So we kind of discussed maybe this would be a really good avenue, because if you're going to see this, in my opinion, you're going to see it in the small animal clinics, because it is when the dogs do the ingestion of the bait. So I was wrapped into this. I'm putting on a pathology toxicology hat, but any toxicology questions, I'm having you direct it back to Dr. Mostrom. I thought this was also a really good ploy, that if toxicology gets you all excited, again, we have a residency program starting. You could come work with us. And so again, I'm not a toxicologist.
But the diagnostic lab received samples from 2 different animals from the same owner. The signalment for these animals were they were young, male, mixed breed dogs. Dog number 1 had fresh and fixed tissues, stomach contents, whole blood, and urine. And dog number 2, we just received stomach contents. The clinical history for these animals, they live in town in a fenced-in backyard. And on day 1, the owner fed these dogs. They left. Nobody was home the rest of the day. They came back on day 2. The dogs were outside, dead, next to the fence. Now, the owner did suspect poisoning. So the referring DVM actually did a field autopsy, meaning they did the autopsy at the clinic. They noted there were similar gross lesions in both dogs, and that consisted of dark, partially clotted blood in the thoracic cavity. The lungs were consolidated and diffusely dark. The stomach was gas-filled, had kibble. It also had this gray to blue material within it. And then they also noted that there was no urine present in dog number 2. Important, the DVM appreciated the smell of garlic or DMSO while opening up the animals for the autopsy. Their tentative diagnosis was poisoning, more specifically zinc phosphide poisoning. So we only received, a few fresh tissues, but also the fixed tissues. The organs that we're going to look at today, lung, kidney, and liver. If anybody's dying to know, this is spleen. And so for the lung, the alveoli contain this dark pink flocculent material known as edema. And then there was also a lot of congestion. And this congestion was seen in the kidney, as well as within the liver. And so the diagnosis by Dr. Webb was moderate per acute hepatic, renal, and pulmonary congestion with pulmonary edema. Now, these are all non-specific lesions in regards to a particular etiology. I will say I see these lesions all the time on cases. It's very, very non-specific. However, due to the fact that we didn't have any other significant changes, due to the fact of the history that the RDVM gave us, and that they found that gray blue material and the smell of garlic or DMSO, we also thought that the tentative diagnosis was zinc phosphide. We sent out stomach contents to CAPS, or California Animal Health and Food Safety Laboratory System, for zinc or aluminum phosphide, and both animals came back positive. So what is zinc phosphide? Again, this was not something that I remember learning in vet school, really knowing in practice. I don't even think I really learned about it in my pathology boards, the little toxicology that I took. So zinc phosphide is an inorganic compound. As the name implies, it combines phosphorus with zinc, and it's an active ingredient for a variety of pellets and tracking powders used as rodenticides, mostly for mole and gopher poison. After we decided to do this talk, Dr. Mostrom gratefully brought in this ERAS bait and set it on my desk in my office. So this has been sitting here for the last couple of months. I believe you just bought this over the counter. Yep. So over the counter, this contains 2% zinc phosphide. It is often mixed with palatable bases such as grain or sugar base, and it can be found in a powder, paste, or tablet form. So here are just 2 pictures of 2 different baits. Here's a third one. And then this is what it looks like with the base and the bait together. And zinc phosphide has been around and registered in the United States since 1947. There's 80 products registered that contain zinc phosphide. It is classified as a toxicity category 1 in humans, which I had to look that up because I did not know what that means. That means high toxicity, particularly for oral and inhalation, which are the 2 ways in the veterinary clinic that you're going to be exposed to it. It is especially dangerous to animals that cannot vomit, and I will show you why. And those animals are rats, mice, rabbits, and a horse that we will talk about. The LD50 in dogs and cats, I got this table out of a veterinary toxicology book. It's 20 to 40 mg per kg. Here is a chart for other species. These slides, I believe, were being made available to you after the CE today, so you can have this for your own reference. And the lethal dose, from when I was reading the toxicology book, really depends on the amount of food in the stomach. So I believe it stated that some dog did receive up to 300 milligrams per kilogram, but that dog had nothing in its stomach and was not fed anything else. And therefore it still survived. So the amount of food in the stomach is really dependent on what kind of this lethal dose needs to be. And we'll talk about why that is. There's two other compounds that are related to zinc phosphide, aluminum and magnesium phosphide. I didn't see a lot of case reports of these. These are fumigants used to control insects and rodents in grain silos, railroad cars, grain carts. However, if you do have an animal that presents with this, the treatment and clinical signs are similar to zinc phosphide, as because all of them are going to emit this phosphine gas. Okay, I'm not trying to make anybody chemist here, not trying to bring you back to your chemistry days, but my brain works better when I can visually see all this. So zinc phosphide, again, is an inorganic compound that combines zinc with phosphorus. When an animal ingests zinc phosphide, it reacts with water and it produces this phosphine gas, or this pH 3. That is what is going to cause all of the clinical signs, or majority of clinical signs. And so this is happening in the stomach. The stomach is a great place for water and acid. So when the animal is fed food or fed food afterwards, after it has ingested this bait, that food then allows for there to be an increase in gastric acid secretion. It drives this chemical reaction to the right, and it produces more phosphine gas. So again, that dog that survived with 300 mg per kg in the stomach, it is because it had no food in the stomach. This was not happening. I did find it interesting that zinc phosphide is resistant to hydrolysis above a pH of 4. However, specifically in dogs, when they're eating or digesting, the pH of their stomach is 1 to 2. So again, phosphine gas then is rapidly absorbed across the gastric mucosa and is distributed systemically. It exerts its activity through oxidative injury. And what exactly does that mean? Well, one, formation of reactive oxygen species. Those are basically oxygen-derived free radicals. Free radicals are a single unpaired electron in the outer orbit. We have hydrogen peroxide, superoxide anion, hydroxyl radical. These are all free radicals. And these are highly reactive. They attack and modify adjacent molecules. Additionally, well, I guess I should say, in the body, you're normally producing reactive oxygen species. It's part of a byproduct of your mitochondrial respiration and energy generation. But your body is also removing them at the same time. So it's this balance. Yes, they're formed, but yes, they're taken away. And they're removed by these intracellular reactive oxygen species scavengers. Okay, 2, we have this big production of reactive oxygen species. What happens? Well, they really like to cause lipid peroxidation, specifically when it's with phosphine gas. Lipids are important. They're important because they're part of this phospholipid bilayer. This is what surrounds the mitochondria and our cells. And so when there's lipid peroxidation, it leads to membrane damage. Again, so not only is phosphine gas creating all of these reactive oxygen species, it's also taking away the free radical scavengers. These are enzymes such as catalase peroxidase and glutathione peroxidase. So that scale of formation is being tipped. And we can't even degrade them as fast because those enzymes are being taken away as well. And lastly, it targets and decreases cytochrome C oxidase. Basically, this little subunit right here, it decreases and it takes it away. Therefore, when we're doing the electron transport chain, it cannot produce ATP. ATP is energy, so it's inhibiting cellular respiration. Ultimately, all of this is oxidative injury. And why that's important is because organs with the greatest oxygen requirements are going to be most sensitive. So that's your brain, liver, lungs, heart, and kidneys. Brain, heart, and liver are going to be affected first. And those are the ones that really need to be monitored long-term. Again, phosphine gas has an odor of decaying fish or garlic-like smell. And not only is the phosphine gas bad, but just gas production. Think of an animal with colic. All of this abdominal distension, pain, secondary float. There was a case report of a GDV that along with this. And then additionally, the ingestion of the zinc phosphide, zinc can also lead to protracted vomiting. So for clinical signs, these can be reported anywhere from 15 minutes to 4 hours. Again, it's going to be based on in the stomach. Can also be delayed. There's usually 2 phases, acute phase and the subacute phase. And the acute phase, we can see anorexia, lethargy, abdominal pain. The subacute phase is going to be more stertorous respiration, ataxia, extensor, rigidity, seizures. And AVMA did a retrospective study of 360 cases of dogs that were poisoned by zinc phosphide. And these were the reported clinical signs, either reported by the owner or to the veterinary clinic. So GI tract was 66.7%. I have to wonder these bottom 3, if they were more animals that were presenting in that subacute phase. Death can occur anytime, usually between 3 to 48 hours. And unlike our case, there is a 98.3% survival rate. So the majority of these cases do survive. However, out of those 360 retrospective cases, 65% of them did need veterinary care, whether that was decontamination, gastric lavage, activated charcoal administration. And out of that 65%, half of them needed additional hospitalization. So this is definitely a toxicity that needs to be seen by the veterinary clinic. There were, I believe, 5 non-survivable animals in this case, in this retrospective study. All of them were young dogs. They postulated that young dogs usually have an increase in dietary indiscretion. They usually like to eat a lot more. Usually there is maybe poor owner monitoring or an altered metabolic system. Again, severity of clinical signs depends on food or stomach contents, age, and moisture content of that meat. Diagnostic testing, more so for your information. CBC is usually normal. Chemistry, the abnormalities start to begin at 24 to 36 hours after ingestion. You can have metabolic acidosis, see increased ALP, azotemia. And then in veterinary medicine, we test the gastric fluid or vomitus. And in humans, they do the same, as well as silver nitrate impregnated filter paper. If you have questions about that, ask Dr. Treatment, main concepts, induce vomiting, reduce the phosphine gas liberation, antioxidant therapy, and providing supportive care. We'll go through each of these very quickly. To induce vomiting, choose your emetic of choice, but you want to do this in a well-ventilated area. Remember, phosphine gas or zinc phosphide is a highest toxicity for oral and inhalation. And we will talk about some mortality and morbidity reports from the CDC on people that are veterinary hospitals that have induced vomiting in a non-well-ventilated area. Reduce phosphine gas liberation. You can go ahead and administer famotidine. This is going to decrease gastric acid production. You can also do gastric lavage with 5% sodium bicarbonate or liquid antacids. Remember though, we really want to not do anything oral now to this animal. Anything that we give orally to this animal is going to start that whole process of the secretion of the gastric acid, which is going to drive that chemical reaction to the right and create more phosphine gas. We're trying to reduce that. So really, if you can, try to give everything either IV. Antioxidant therapy, I thought this was just a cute little schematic with the antioxidant free radical cell. And antioxidants reduce free radicals by giving them an electron. That's what that's trying to say. And so this should be initiated early. Remember, phosphine gas is all about increasing those formation of those reactive oxygen species. And so we also are going to see a decrease of those scavenging systems. Glutathione is the most effective antioxidant in this phosphine gas toxicity. The 2 medications that they recommend in veterinary medicine is SAM-E and N-acetylcysteine. And Dr. Holly Hummerding already talked about this, so I won't go into about the fact that N-acetylcysteine IV. And so that's the one that they actually recommend the most over SAM-E. And then lastly, provide supportive care, control electrolyte abnormalities, acid-base imbalance, and hypoglycemia. If there's seizures, treat those. And now let's talk a little bit about humans. So the threshold in humans is 0.3 parts per million. By the time you are smelling the gas, you have already been exposed to a concentration of 1 to 2 parts per million. So you will start to have some clinical signs to that. In humans, ingestion and inhalation are going to be the two most common ways of exposure. Unfortunately, there are quite a few case reports of adults consuming this as a suicide attempt. There's also a lot of reports of young children accidentally eating the bait because remember, it's very palatable. And so they actually eat it and they become sick. Clinical symptoms are similar to animals and treatment's going to be similar to animals too. I'm not going to go through this, but this is just a human toxicology paper that I found and all of the different effects that zinc phosphide and phosphine gas can have in a human. And then this was their therapeutic proposal. All these references are at the end of my PowerPoint, and then that way look this up if you'd like to. I thought it was interesting. A lot of it is the same as animals: antioxidants, decreased absorption, elimination. And so my take-home points are, zinc phosphide reacts with water in the stomach with acid to release that phosphine gas. And that's what's causing a lot of the clinical signs and the toxicity. Treatment should include inducing vomiting, reducing the gas, and antioxidant therapy. Remember, oral administration of any sort of medication should be done sparingly. It's especially dangerous to animals that cannot vomit. Please do this in a well-ventilated area. Even if you don't know if the dog ingested zinc phosphide, if the dog ingested any sort of bait, you're going to induce vomiting. I've been back in treatment areas. I've practiced. They're small, they're cramped. There's usually lots of chairs and computers. Maybe just go outside. Just try to do it in a place that's well-ventilated. Secondary toxicity due to consumption of targeted rodent species is less of a concern. So a dog eating a rabbit that had poison, less of a concern because it doesn't really accumulate in the muscle and it decomposes readily in the digestive tract. However, what is a concern is non-target species toxicosis. So there was a big vet hack paper done a few years ago on wild geese out in Oregon. This was from 2004 to 2011. And this was actually multiple mortality events over several years, ranging from anywhere to 5 to 300 birds. Clinical history of the mortality events were similar. They were found dead in and around bodies of water over a course of a few days to 2 weeks. Clinical signs that these birds had prior to death: weakness, inability to raise the head or to control head movements, impaired locomotion in the water, convulsions. Some geese even developed progressive paralysis. And like the investigators, if I had kind of some of those clinical findings, I would not go down a zinc phosphide toxicity. I would go down botulism, lead poisoning. And so you can see from this chart, they tried a lot of different testing from avian influenza to West Nile virus, lead, and really everything was coming back either not detected or negative. And then they found a cackling goose that the esophagus was filled with grass and the rodenticide. So they retrospectively went back. They always keep some of the samples they were saying from the birds, and they tested these samples with GCMS for zinc phosphide. And out of the subset that they were testing, they were coming back positive. And so what they found out of these mortality events were not believed to be malicious. Out in Oregon, the paper even used the term ferocious. Geese have a ferocious appetite, and a lot of times it's really hard to keep them off of the fields. And so zinc phosphide was applied to control rodents, specifically meadow voles. Apparently these also have ferocious appetites, and they are a huge nuisance to the agriculture sector. And so what this did lead to is a whole bunch of outreach, and outreach to the agricultural industry on how to better educate them. So no application of zinc phosphide if geese have been observed on the field within the last 7 days. Geese have to be phased off of the field with zinc phosphide, and there can be fines if you don't comply with these regulations. The next one I'm gonna talk about is a standard bred filly, so of course. There was a 2.5-year-old standard bred filly that had a sudden onset of anorexia, sweating, and muscular tremors colic that presented to a veterinary school. On nasogastric intubation, I just took this from the journal, but this is what they're doing if you're not familiar with nasogastric intubation. A large quantity of white smoke started to come out of the tube. It had a garlicky odor. Unfortunately, the condition of the mare did deteriorate and she was. Now, the owners of the farm did come back and say, yes, they had rodenticide containing 10% zinc phosphide on the farm. They had no idea how the horse got into it. For lesions on gross necropsy, similar lesions to our own case, pulmonary congestion and edema, renal congestion, and in the stomach, poorly digested oats with this pale beige fluid that had a strong odor. Interestingly, the attending veterinarian that performed the nasogastric intubation was hospitalized by ambulance 2 hours later. They had a sudden onset of neurologic symptoms. They did completely recover. And then lastly, is this morbidity and mortality report from the CDC. This was back in 2012. And so they received 4 different reports of veterinary hospitals from 2006 to 2011 of zinc phosphide poisoning. 2 in Michigan, 1 in Iowa, 1 in Washington. All cases were dogs that had ingested zinc phosphide, and they had induced vomiting in these animals. It said in one of the hospitals, I forget which one, the technician actually smelled the vomit because she was trying to see if there was any other food in there, if she could smell anything else. And then after she did that, she instantly really felt ill, got very bad abdominal cramps, and had to leave the room. Another person was exposed. They were helping with gastric lavage with that animal. Thankfully, everybody recovered, the dogs, including the humans. And very few of the humans, I think even 1 or 2 ended up hospitalized, but that was also because they had pre-existing conditions. So this is something that you can potentially see in your clinic, and it is something, again, that you can become sick from. And so that's kind of the end of my zinc phosphide talk. You know, we get these cases of small animal poisonings, handful a year, I'd say. A lot of times it's somebody thinking their neighbor poisoned and it turns out to be cancer or something else. But there are a few times that we actually do have a case such as this, where it turns out to be a real toxicity, maybe even a real poisoning. And we're always available at the laboratory for you to call and speak with us. But this is stuff that I was hoping that you could print out, keep in your clinic, maybe as some references, just in case you're in the heat of the moment and you can't make that phone call. So you have a patient that dies, now what? Whether they were in your care, whether they weren't in your care, well, you're going to be the best person to consult with the client, the pros and cons for an autopsy or postmortem examination. The gold standard, especially if we're looking at a toxicology case, is that the animal should be submitted to a local accredited veterinary diagnostic laboratory. Check, that's NDSU. And the reason being is because the autopsy is done by a diagnostician that's trained. When I was practicing, you get pulled in multitude of different directions. Being mixed animal, there'd be some days that I deal with a dog with giving a rabies vaccine. I run out, I do a calving and a cow. I run back in, there's a cat that's diabetic. Even if you're doing all small animals, you go through all of those different things. You're fighting so many fires. This is what we do here at the lab. We do autopsies. We're trained to do autopsies. So send the animals to us if you can, when you have these complicated cases. Let us be the people to help with that. Additionally, you should send to a diagnostic lab that has a toxicology section. We have Dr. Mostrom. So again, this is why I say this is the gold standard. Now, just in the case that we just saw, they did an alternative approach, and it worked out perfectly because they gave us some really key information. So you can do just submission of tissues for testing. Case history is really important in these cases. Again, the poison, or when I opened up the animals, it smelled like garlic. That was key to this case. And so poisons have a characteristic effects, most of them. So if you can give us the animal signalement and all of that information, that's super helpful. But when I was reading this paper that kind of laid this all out, these were things that I really didn't think about either. The behavioral patterns of the animals, relationship to the owner,
Have there been any recent visitors? Vaccination status, presence of young children in the household, are they supervised when they go outdoors? These are all additional questions you can ask your client to really get a good case history. I feel like when it comes to toxicology, cases, whether it's large animal or small animal, the more history, the better for us. I'm not going to go through all of this. Again, this can be just for your references, but here are some ante-mortem and environmental sampling that you can do if you just want to send us tissues and how we kind of prefer them. And then for post-mortem sampling, where to do the autopsy, in a well-ventilated area or outside. Fresh tissue, please send us a full set of fresh tissues, large amounts, so that we can go back and do testing if need be. On our website, we do have diagnostic panels. Most of them are for large animals, but you can take this out if you ever need to do a small animal necropsy. I think we all know that a dog is not going to have a rumen or a reticulum. So just forget about those, but this is a good checklist for all the other organs. Formalin fixed tissues, we ask them to be submitted in 10% formalin, the size of a starburst. That's as big as what we need to place in formalin for it to be fixed. So if you remember size of starburst, that is what we want in formalin. Tissues that are commonly missed, abdominal fat, brain, eyeball. I don't know if I've ever collected heart, clot, blood, or serum, or bile. The other tissue commonly missed, in my opinion, is urine. So that's also really important to send to us. Again, I'm not going through all this. This is just a chart. All the toxicities, not all, most of the toxicities over on this side that you might be dealing with in small animals and in large animals. Here are the tissues that you can collect. Down here, it's is C for chilled, F for formalin fixed. And so again, this can be used for a really good reference for your clinic. Lastly, unrealistic expectations do exist when it comes to analysis. We receive submission forms, unfortunately, that say test for all toxins, or even clients say test for all toxins. And I think a lot of that is the CSI human shows where they find this weird toxin for testing. Unfortunately, it's going to cost a lot of money. I believe this is a response that Dr. Molstrom says quite a bit. It's just going to cost a lot because we don't know what we're starting with. We can refer out to CABS for an unknown exposure test, but you're looking at about $400 just in referral tests. Dr. Molstrom, I know you said you've submitted a couple of those. Have you ever gotten a diagnosis from it?
No,
So.
but they paid.
So if we can, and this kind of comes back to case history, if we can get a better case history and kind of know where we're starting with, then we can decide what testing we need to do. But testing for all toxins is just not going to be possible unless your client has a lot of money. Lastly, very briefly, legal cases. Has anyone submitted a legal case to us before? No. So this is something that the VDL offers. It's a service that we offer. It is an additional fee, and I'm going to tell you why. These cases are very involved. The reason being is that anything that gets dropped off to us, and it is a legal case, there is a chain of custody and an evidence tag that gets tagged to every tray, sample, everything. So if you have a case that might potentially go to litigation, it needs to have a legal fee attached to it. We need to know from the very beginning, talk with us about it. But the samples then are hand walked to every single laboratory. As soon as they're done at that laboratory, they get hand walked back. They are then placed in a locked legal freezer. And so these cases, basically with our chain of custody, we make sure there's no tampering that can be done with them. Additionally, on the pathology side, we, Dr. Pecoraro, Dr. Mitchell, and myself, we will do forensic necropsy reports. These are more detailed, they're more time consuming. If you have done or seen our gross descriptions or necropsy reports in general, they're usually 7 to 8 sentences long. These necropsy reports are several pages because we're going through every single thing and documenting every single aspect. How the dog or animal arrived. What did they arrive with? Was there a blanket? Was there a collar? Are there any lesions? And then we're taking pictures throughout this entire time to document every single thing. And this is so if it does go to litigation, we can stand up on the stand and talk about what we saw. So with that, references. So my son is 7. He loves, we call them dad jokes. So he found this when I was preparing for the presentation and he wanted to add it in as my last slide as the tangent. It's a good one. So with that, any questions?
Since you brought up free radicals, your comment on the role of vitamin E as an antioxidant against free radicals.
Oh, man, Dr. Mostrom?
Would I comment on the use of,
Vitamin E as an antioxidant.
well, it certainly can be used as an antioxidant, I guess in these situations. It'd be of limited value, but in what context?
Well, I see big value in it. I do nutrition consulting for large animals. Feedlot and cow-calf operations. And I see the role of vitamin E as an antioxidant, just from the practitioner standpoint.
Well, my PhD was on vitamin E selenium deficiency. So I found in deficiency situations, if you supplement with vitamin E, it surpasses selenium in its protective effects and its stimulation of immunity. So I think it's superior to selenium as far as those comparisons. But I probably, my experience is limited to looking at selenium and vitamin E together or deficiency.
I have vitamin E of the brain.
Okay.
And another thing, I want to thank NDSU for that legal thing, because I was next witness quite a few cases. And that was absolutely important. We won against bigger lawyers just because of that.
We'd like to have chain of custody if they're gonna be shipped in. That's critical too. So if it's coming from cases that have to be shipped in, if you get your police involved to help you document and provide a chain of custody and label everything, that helps us and it'll help your case.
And I
Because
mean, oh, go ahead.
We don't get a chain of custody and the animal comes into us, you've lost a big portion of your case.
That case starts off right away with people signing off on it as soon as it walks into the lab. What time, who received it, who brought it, everything. It starts from the very, very beginning. So if you ever have a case that you think is going to go to litigation, call us ahead of time. Let us know. That's what we're here for. That way we have a good idea of that it's coming in.
And also, many of these cases will have local law enforcement involved already. So if a client comes in with some dead dogs, it's not a bad idea to get a hold of law enforcement, because often they're the ones who will bring, like doctors Mostrom and Sykin said, they're the ones who will bring the animal to us, and it will be much better for your case.
Going back to the zinc phosphide, so you've got a dog that's been exposed, you've done emesis or lavage. Were there any recommendations as far as timeline to returning to oral feeding?
You know, there wasn't actually in a lot of the cases that I saw. You know, AVMA, I think part of that is that there's just not a lot. There's reports about it, but it really just follows them up into treatment. And then it's kind of lost to further evaluation. That big retrospective study really didn't follow them out at all. So no, I don't have any recommendations for how fast we can go ahead and return them back to oral feeding. That's great though. Great question.
You know, in that particular case, if it was ever determined where those dogs
I don't.
got sent?
I don't know in that particular case. I was kind of on the periphery of it. And then, yeah.
No,
I don't know.
they never found a source.
And then
You don't want it.
While they're getting the last one, I will get the certificates out. I'll figure out, we'll lay them out, just pick them up as you go. I think that's the biggest thing. We're all available if you need us. What am I forgetting?
You can view that, well.
Yes, that's what I want to tell you. So everyone will receive a link to these talks, so you can watch, you can view them. And I have the video, but you'll also get a link to all of our notes. And I believe even Dr. Howard, doesn't she have a note too?
She might have a note, which that is proprietary information from the pet poison hotline, so she was not going to.
Yeah, she could share her slides. I thought. So I don't know if you took any notes on the treatments.
Thank you with results.
She gave you her email and we can provide that. To her. So.
So this will just.
And selenium, efficiency, response. I can't, yeah.
Bio break. Dr. Holmstrom, she knows most of you, so she'll be passing those out. And then Dr. Matt back, and it's our last one for today.
Okay, so I'm gonna try to make this not painful, but it is about sample quality, something I'm also passionate about, probably right up there with pastoral and Maltasta. So I trained as a medical laboratory scientist. My master's and doctorate are also on the periphery with medical laboratory science. So it has been pounded into me sample quality and laboratory testing. It may seem like a really trivial thing, collecting a sample off your patient maybe doesn't seem like a big deal, but it really is. We'll talk about why that is. Okay, so goal for this presentation, should be able to describe best practices for sample collection and transport to the laboratory, describe potential impacts to test results due to improper preservation of samples or shipping delays, and then leave knowing that you can and should feel comfortable calling the laboratory to ask questions. So Dr. Steichen teed me up very well for a lot of these discussions and gave her pathology take on that. And I want to emphasize, while I would love for you to use the VDL, you should demand these same things from your other laboratories that you would potentially be using. So no matter where you're sending the test to, there should be, I guess, guidelines for quality samples and what should be collected. So I'm just going to give you a quick intro to laboratory testing. I think it's good to give context. And where I picture it, I was looking for a good meme, just showing in human medicine, we have the perpetual communication breakdown between nursing or clinical staff and the laboratory. The laboratory is perceived as these people that like to ruin the day, basically being like, you're not giving us a good enough sample, we can't run this test. I can remember as a phlebotomist in the hospital overhearing a nurse being like, laboratory rejected my urine. And it was because I put the label on the cap. I think sometimes they just like to make our lives harder. And it's not that. It may sound extra picky, but it is for real. You take that cap off and that sample is no longer labeled, and it is a critical problem. You could be mixing those up, and that's detrimental to patients. These are picky things, but they're really important, and little simple steps can really improve the quality of results. So leading into that, a lab test is generally, and this is compared to clinical, I feel like you guys get to be a little bit more artistic. You're having to finagle live animals. You have diagnostic procedures or ways that you are working with a patient, but you have to be a little more creative. On the other hand, for lab testing, it is a tightly controlled process. We have specific steps we have to follow. All of our tests are designed for certain sample types. They're dependent on the quality, a good quality sample for quality results. And when we deviate from our procedures, so this could be for a sample that we haven't validated our test on, or for a sample that is degraded or old. So when we deviate from that procedure, we have unknown outcomes. So that would mean misleading or incorrect test results. And then what does that mean for patient care? We really don't know. For our laboratory and any public laboratories, so state hospital or veterinary diagnostic laboratories, we are accredited by the American Association of Veterinary Laboratory Diagnosticians. Commercial laboratories are ineligible. So that is something you should pay attention to. If you are using a commercial lab, do they have procedures for quality management? Otherwise, it means there might not be a lot of control to standards. We voluntarily participate in that accreditation, and we adhere to standards set forth by this group, AABLD. So they give us guidance on what they want to see for us to be accredited, but then we have to come up with standard operating procedures to show that we can go to their standards and do a good job. So we have to describe how we'll perform a test, what we will do if something goes wrong when we are testing, acceptable sample types, factors that might impact test performance, validation of these test methods. And when we make changes to test methods, we also have to document that, make sure that it doesn't impact how the test works. And then we have to use known samples or standards that we can test against to ensure that the test performance is valid. And in the context, just for an intro to the life cycle of a lab test, we tend to think of it as pre-test, test, and post-test. The phases that go on in the laboratory are pretty much the test phase, very partly with the pre-test, and of course a bit of the post-test. Pre-test phase is what you're doing in the clinic. So it's when this begins from the moment the patient walks into the room to when you're starting to think about selecting a test, you're collecting a sample, the sample transport, sample receipt, and then when we receive that sample, how we're interpreting your test request. That's all pre-test. Test phase is when we are actually doing our very tightly controlled process. And then the post-test phase is when we are then reporting the results to you. And hopefully our results are clear enough that you can actually take that information and act on it for your patients. So now we're going to get into what matters for you in that pre-test phase. So sample collection, transport, and test selection are the very critical basic steps that we're looking at in this stage. The pre-test phase is the most critical step of that total testing process. So in that life cycle of a test, what you are doing in the clinic impacts that almost as much as the test that we are doing. So it's also the part that has the least control. In a human hospital or hospital system, they have those wonderful service teams that give you the exact collection device they want you to use for particular samples. It's all very controlled. You have the standard set of tools. You all might be out in a pickup that might not have a kit that has all the supplies. You used it up at the last farm, whatever it would happen to be. You have a lot of situations that are harder to control than a nice clinic environment. Even in your clinic, there's a lot of things that are going on. So if you can imagine there, just how much chaos that adds to it, and just trying to think about some of these other things that can help to control that. So we need to think about the right patient, the right time, the right test, and the right sample. So for patient, of course, our lab tests have to be relevant to what you're seeing in the clinic. So you're looking for the presence of those lesions or clinical signalement that are suggested as a certain disease. Will the test you chose help with management or diagnosis of the disease? And then is this the correct species for the selected test? This gets a little more dodgy as you're getting into more exotic species. There might be things that might not apply. So we do have to get a little more creative and come up with ways that it would apply or realize that that might not work for that animal. Timing of collection is really important. So understanding the stage of the disease process, of course, acute versus chronic versus monitoring. Just thinking of bacteria in the acute phase, the bacteria that you would see if it were a bacterial infection are going to be very different than what you'd see in the chronic stages. I right away think of bovine respiratory disease. By the time you're seeing Trupperella pyogenes, you're definitely in more of that chronic secondary phase versus if you're seeing Pasteurella and Mannheimia, that would be more acute. But then in the monitoring, so are you trying to figure out if your treatment is working? So for some of your different tests, even as far as immune response after an infection. Disease process, there are certain disease processes that might require multiple samples. So if you have septicemia, you're going to want to collect that sample. When you have the spike of a fever, you're going to want to get multiple samples. And then pre or post treatment, what are things going to look like? So when you have a culture, you definitely want to collect that sample prior to initiating treatment, if at all possible. Realizing that if you're collecting after treatment has started, it might change how that that culture result. That pathogen might be wiped out and it's normal flora, it might be more growth. It'll really change the picture. So all of this is important. And then test selection. Seems really simple, but you can collect the most perfect sample. And if we have the wrong test selected, it might not matter. So that perfect sample for one test could be totally wrong for the other one that you maybe wanted. Or it's telling you the complete opposite of what you're wanting. So what is the test for? Are you trying to determine prior exposure, whether you have an active infection? Are you trying to determine your treatment options? Are you looking for viral, bacterial, or parasitic? Or maybe you need to think of all three? I right away think of a diarrhea situation. If you're just looking at bacterial, there's a lot of things you could be missing. And we right away with bovine symptoms, if it's asking for a culture, most likely we're going to have the parasites or the viruses that are positive more often than culture, unless it's like a dairy cow. We're going to probably find salmonella plus maybe cryptosporidium. It gets interesting. But then also other things like, okay, great, culture would be awesome, but maybe histopathology or cytology would complement those test choices. And then is that sample available, correct for the test I want? So in a live animal, maybe you want to test for West Nile and you want to do a PCR test. If you collected blood on an animal, the viremic phase is so short that you very well might miss it. So if you're doing PCR on that blood and it's negative, that animal still could have West Nile, but we're not detecting that virus. So maybe for a live animal, doing a serology is better than the PCR. The ideal tissues are ones that you're going to collect post-mortem, so that's not going to help. So that to me is the perfect example of a test that there's multiple ways you can test, but getting the right sample is going to be very important. And big hint, with all of this, the VDL can help you choose the right test. So whether that's calling your lab, looking online, just phone a friend and make sure that you're picking the right test. And then the appropriate sample, it's just considering the sample you want, is that appropriate for the test? Look, a nasal swab and you're looking for a respiratory infection. It isn't going to tell you what's actually going on in the lower respiratory tract. Thinking of the tissue distribution of the virus or host organism, are you collecting feces, but it's a respiratory issue? You know, just making sure that the sample you want is actually going to represent the tissue distribution. You have a neurologic case, but you forget to send the brain. That could be a not uncommon situation. So does the test require certain transport media? Dr. Steichen mentioned the royal blue top tubes for trace mineral testing. You're not wanting that zinc contamination. If you send an EDTA tube, there's potential contamination. You're going to have high values. Another common error, and I think this is the most poorly named transport tube, it's called universal transport. You've probably been bitten by that at one point. Makes it seem like you can use it for pretty much everything, but in reality, it's pretty much only good for viral studies and mycoplasma. So great for those things, terrible for culture or pretty much anything else. Is it a regulatory test? There could be extra labeling or information needed with that submission. So another thing to think about. And that sample might be different than the normal diagnostic test. So it's worth checking. Like Dr. Steger had mentioned with avian influenza, that's going to be very different than you submitting an influenza sample on a dog. There are extra steps needed for that. And the samples might be a little bit different. But check the laboratory webpage, or again, call or email the lab. Thinking about representative samples too. So we don't need a whole bucket of feces to be able to do our testing. Even with 3 or 4 tests, a bucket is too much. This was actually submitted to me by another microbiologist. They were laughing about this giant sample they got. And I can remember getting mason jars. I got one at the lab was a vase of human poop, and they wanted the vase back afterwards. We're going to give that vase back. So we do get some interesting sample containers, but we don't need that whole bucket. At least a teaspoonful will get us through quite a bit. You need a fair amount of feces, at least if we're going to be doing flotation, but not a whole bucket. So trying to get a decent amount of sample without going overboard. So that's going to depend a little bit. Dr. Steichen gave that really good reference of the starburst size tissue. I made the emphasis of not a pea-sized tissue, so not just a little tiny nub. We need just a little bit more. That was a great reference. You might need multiple samplings, so just thinking of that for the representative samples. And then Dr. Mostrom had given the example of not a single plant for toxicology. you're going to look for minimum amounts of these things. And that's the same for the other tissues and even like bone marrow, some of the different things she's looking for, those will have other amounts. So it's going to depend on the test, but a representative sample is really important. If you have diarrhea, you're not sending the one fecal sample that just happened to be a little more formed, you're getting one that is actually representative of what's going on, the problem.
Can I say one?
Yep.
Yep. Talk about tissues. Well, okay, so not the pea size, then, so, okay, starboard size for is stuff like formalin.
Oh, yes.
Yes, versus, for fresh tissue, we need it bigger than that, especially if you want to do like an ICP or a mineral analysis, we need 50 grams. I don't need the whole heart. I often get a whole heart, a whole set of lungs, whole liver. I don't need that either. So there is a happy medium. You know, like this much fresh is more than enough. This much in a jar, a tissue, a formula jar is too much, like this much. So.
And that's remembering tissues expand when they're in the jar.
Oh.
So if it's a tight pack, it's gonna be way tighter by the time it is back to the lab.
I got 2 spleens last week put into this size jar, like the rim, the lid's this big. Well, it's fine to put a fresh spleen in there, right? Because you can wiggle it around, move, but getting that out both times broke. So think about that too. Sorry.
No, that's great. That has context. So, especially when you're going for histopath, yes, you're gonna be wanting fresh and fixed, but the sample size does matter. And as far as with biopsy, maybe a pea-sized amount is all you're going to get. I'm not saying hack off part of the limb.
Yeah.
Definitely context.
We're talking about dip.
So, but it's big. Yeah, just be generalized. So thank you. Okay, so tissue sampling considerations. So this is just another part to actually thinking about what you're looking at when you're selecting to send into the lab. You're going to select tissue that most likely will aid to that diagnosis. Obviously, if you're seeing diseased tissue, you should send some of that diseased tissue. If you're seeing gross lesions, that needs to come into the lab. We are looking, when we are sampling, we are looking to get this margin between the healthy and the diseased tissue. When we're looking for bacteria, we're looking for the diseased tissue. We want the lesions present. And if you have mucus or blood, that is another, of course, great area that you're wanting to sample. This definitely applies for feces. If you have mucus or blood, we want that. If you're seeing granules, those would be other, I guess, great points to be able to look for in your tissues. Again, the disease process specific workup. Dr. Steichen had hit on that a little bit, but I'm going to emphasize it again. So she, this winter, had gone through and made up all these different syndromic checklists, which I know other vet labs have also, but they're really great. They kind of give you an idea of what you need to send for each of these different syndromes. So for bovine, we have the chronic ill thrift weight loss, the abortion, diarrhea, general diagnostic, neurologic, and respiratory. Gives you information on the differentials, the tissue, and the list of tests we might select. But just really good. So when you're on the fly, making sure that you're getting the tissues that you need for the most complete diagnostics. Just want to emphasize that this resource is available and it's on our website there. But some basic recommendations for sampling, a tissue and an exudate is always going to be a better than a swab of those things. So if you have a choice, always send the tissue or the actual material, not a swab of it. So if you have feces, you're going to have a way better shot of getting a complete diagnostic set if you have the actual feces. Again, not that swab of it, not a rectal swab. Go for the source. And then again, for tissues, you're going to be wanting to submit fresh and fixed tissue in most cases, with the exception rabies. Whole slide on rabies. This is for Dr. Pecoraro. But you must submit the whole fresh brain. Do not send formalin fixed brain. We need that full cross section of the brainstem to be able to complete the rabies fluorescent antibody test. So getting that full fresh brain, or sending in the head or the whole animal, just making sure that that whole brain comes to us so we can do that complete test. There's a submission resource that includes this information, but when an incomplete sample is sent, the best we can do is give you an inconclusive result for a negative. It's meaning we can't say it's negative because we didn't get a full cross section. We could call it positive if it were fluorescing. But in those cases, you might then have to have the sample sent to the CDC, which incurs an extra fee. Potentially something that's covered by public health, but it does add a whole lot more time to the process. So making sure you get the entire brain is really important for those rabies cases. Whole section on swabs. So the kind of swab you use, it matters. Cotton is rotten, wooden is forbidden. Those are good things to remember. Both cotton and wood will actually impact preservation of bacteria, potentially with viruses. So you're going to want synthetic sterile plastic shaft swabs for the best results. So you can order those pretty inexpensively online. I think we just ordered a box of 200 for like 25 bucks. So, and that was something we were able to get on Amazon. They're sterile. Just for plain swabs. Of course, there's other kinds of transport media that we'll touch on. But if you're wanting a PCR test and a culture, you're going to be sending 2 swabs, one in the culture transport and another with a small amount of sterile saline in a sterile tube. That might just be a red top tube. We'll go over the in a pinch swab scenarios. And then bacterial transport containers are your best option for culture. So your Amy's, Stewart's, or an e-swab. These e-swabs are really fantastic. You can also use them for anaerobes if they're transported to the lab quickly. There's the Puritan brand, and then there's also a Copan brand. Of course, whatever you can find, as long as it's a commercially prepared brand. They have these really great swabs too that will actually release the material better into the transport medium. These are also things that are commonly expired. We'll often get tubes that are expired by several years. Those are dried out, and at that point, you'd probably be better off with just the sterile swab and sterile saline. It's not really adding to that preservative effect at that point. So it is good to also go through your stash of supplies and just make sure that they're not expired. That's helpful. And again, swabs in a pinch. So sterile synthetic swabs, small amount of saline, tube with no preservatives, plastic if whenever possible. Glass is subject to break, especially during shipping. And then we're kind of out of luck. At that point, they're contaminated. And again, getting it to the lab quickly, especially because it's just in saline. I do have little cards that can be taken home, just little quick reference cards that include all this information on the transport information. Take multiple if you're wanting them for your clinic. They are really, I think, helpful for quick reference. Whole section on microbiology, of course, because our stuff is a little bit more finicky. Samples for culture should be fresh, ideally received by the lab the same day or the next day, so overnight whenever possible. The area should be cleansed before collection to remove the microbiota, so your normal contaminating flora. Needle aspiration is ideal for a lot of scenarios, just to make sure you're avoiding some of that contaminating flora. Transferring it to a sterile collection device afterwards with no needles sent to the lab. If it's a small amount of sample and you're not able to transfer it, it is completely acceptable to put a lure lock on that syringe and send it to us. And then maintaining moisture on tissues. So if you have just a very small amount of sterile saline on tissue, that really will help with preserving the bacteria. A dried out chunk of tissue isn't really going to help too much. Should be sampling only one body site if you are doing a swab. I can remember situations where I think I got like a mouth and a foot. Well, the bacteria that we're looking for in a culture, very different for those 2 body sites. So it's really hard to assess what's normal, what's a pathogen. And there's a lot of contaminating flora on both sites. The collection method is really important for us. So free catch versus cysto for urine. That's important on how we interpret our cultures. And then in a lot of situations, I think it is helpful to combine culture and histopath for the most comprehensive interpretation, especially for those skin conditions, and then uterine biopsies in particular. There's a really great resource from this publication. I'm going to be touching on these publications again here towards the end, but this came out of Cornell. They have printable sheets that actually tell you what tissues to send when you're looking for different sample types. So this is really great, available there. These slides will be shared with you later. But we had little infographics like this all around the human hospital that I worked at. So you could actually just at quick guide, see what you needed for a culture for whatever common sample you're looking for. That is geared towards microbiology, of course. Anaerobes are also special. So if you're looking for Clostridium or Fusobacterium, there is more of a need to work faster and really think about what sites we're using. Many body sites actually have anaerobes as normal flora. So there's more specific cultures that are more appropriate for anaerobe culture. Anaerobes, if you're sending in for a deep wound, instead of just asking for an aerobic, it might be important to also ask for an anaerobic culture. When you've got abscesses, bones, joints, those would be appropriate areas to toss on an anaerobe. Feces, if you're looking for Clostridium perfringens, we require both an aerobic and an anaerobic culture. You can completely miss things like salmonella or other aerobic pathogens if you're just looking at an anaerobe for the feces. Just gives a more complete picture. And then Clostridioides difficile, that's one that we don't culture for, but that is an anaerobe and needs some special conditions there. Delayed transport is very, very much lost anaerobes, so needs rapid transport to the lab. In a human hospital, the guidance is within 2 hours. After 2 hours, they're not going to accept a sample. I realize for veterinary situations, that's not going to work, but we've got to do what we can to try to overcome those challenges. Proper transport tubes really help with that. So like I mentioned, the e-swabs, but then we have these excellent portical vials. But the portical in particular will make it so that you can't use it for other tests. It wasn't uncommon in the hospital to get all of a sample in this vial, and then they decide they want to do some kind of a cytology on this fluid. Well, this gel in this fluid actually makes it so that cellular components of that fluid are trapped and your cytology isn't going to be good anymore. So just important to think of what you might be wanting on it. So if you did want a cytology, make sure you're also sending another sample that's maybe not in a preservative, but still sending a little in that anaerobic transport so you can get both tests. And we always require an aerobic culture when we do for anaerobes. Yes.
We do have a case where we're concerned about that, and there's not a way to get it to the lab within a couple hours. Like, is it that, like, say it's the end of the day, or it will be more than, like, what would be a time frame where it still might be worth submitting?
Yeah, I'm thinking trying to think for over the weekend. It might be if it's refrigerated. If you've got it in an e-swab, maybe it would still work if we were to get it on a Monday, but it would be as much as possible just trying to get it to the lab that same day. Overnight again, I don't really know what to say for the weekend. It'd be like, hey, can you run this into the lab before you leave for the day is the best I can say. I don't really know how to advise on that.
Even if you do everything you can to get to the lab and we're closed, we're not gonna get it until Monday.
Yeah.
So it's an issue.
So it'd maybe be more of the caveat of we can set up the culture, but we might have lost something by then. It's something that we run into all the time with being the weekend lab. Plus, our state is huge and rural.
Yeah.
We're not getting stuff from Western North Dakota. So it's a limitation I accept, but it's as much as possible, especially if you're an in-town clinic, to get it to us pretty quickly. But I understand things happen at 4 o'clock on a Friday. You're not going to make it from Castleton to us. So depending on which clinic you're at. So it would be, I mean, it's not like we're going to reject it if we get it on Monday, but just something to be aware of. I did want to mention ear cultures in particular. It's one we get requests for a lot. And we don't typically recommend ear cultures for otitis externa. Bacteria are rarely the primary cause of the issues. You're typically going to have a primary cause and a secondary bacterial infection. So it's requiring to manage the primary cause first. And I would actually be fine with the idea of culturing just to make sure you have something, but I strongly advise against, we will perform antimicrobial susceptibility testing for the request, but there are definite limitations, and we do report this with these. Our testing is for systemic dosing, and that's designed to predict response for just systemic dosing. So it will not predict topical response. I don't think there's a ton of value. So regardless of the bacteria we find, in most situations, the topical treatment should be achieving high enough, and again, will not be predicted by our test. So it isn't adding a ton of value. I think this paper does a really great job of explaining what I'm telling you here. So it's talking more about that management, getting those extra biofilms out of the ear beforehand, just to improve that concentration. But the concentration you are getting from your topical treatment is going to far exceed what our test is designed to predict. So it really isn't going to be interpretable. And so you might be getting something, say you're wanting to use an enterofloxacin drop, may be resistant by systemic dosing, but that doesn't mean that you can achieve high enough concentrations to overcome that. So to me, it's probably pushing you away from a treatment that you could have used and considered. And it also makes it seem like your options are more limited than they are. I'm not a clinician, but this is also backed. I've talked to a dermatologist that has had 30 years, and I think she said she's never cultured an ear. It's just all it comes down to management and dosing. So my microbiologist perspective on that. Happy to answer more questions about that if they come up later too. And then also nasal cultures. So these are not representative of the lower respiratory tract. Oftentimes we'll see we have a cat with a chronic discharge and that upper respiratory infection. We see a lot of contaminating skin flora, but it's really hard to actually interpret what that is. And I suspect pretty often those nares are pretty tiny. Our swabs are huge compared to that. I mean, they feel huge for my human nose. So you can only imagine what a cat sees when that swab is coming to them. But so there's a lot of contaminating skin flora when we're getting those. And I realize this is a lot more challenging to get, but washes will contain less contaminating flora and are more likely to contain pathogens. But when you are doing nasal cultures or nasal swabs, your viral tests are going to be more valuable. And there's a recent paper on this, and they're big finding by doing a retrospective analysis of their respiratory PCR, where they're looking for mycoplasma and a bunch of different viral agents, found that samples that were acutely collected and giving the most clinically relevant information wound up getting the most useful results for that test. So just something to consider when you are seeing that chronic discharge. It may be more appropriate to consider viral, but also looking at acutely collected or looking at other ways that you can get that sample if you're looking for a respiratory cause here. Another great paper, again, I'll highlight again later, but this infographic is so perfect for all of your common body sites. This is in JAVMA, but shows, for example, when we talk about otitis externa, they do talk about the appropriate place to sample if you are going to sample for microbiology. But just also emphasizing that there are no breakpoints for the susceptibility for topical drug dose. So that little caveat there, but goes through all these different body sites and things to consider. So I think this is a really good infographic, something to maybe look at your leisure. Really captures the main points for sample collection though. We'll go on to sample packaging. So sample labeling is critically important. We do see a lot of samples that are unlabeled, which may work for your clinic because you're only sending one sample out. But that is also remembering that you have a much higher chance of error when it is unlabeled. Yes, maybe you're putting a submission form in there and that's your form of labeling, but at minimum, it is best practice to try to at least get your patient name on there. And ideally, you'd also include your date collected and then the body site or sample type, just to be a little bit more thorough. When we receive samples in the lab, we're only opening one box at a time. But if you are sending multiples in bags and maybe something isn't closed, there is risk for those getting mixed together. So just consider labeling samples more. We do have a new requirement that our samples that are unlabeled for regulatory testing will be rejected. We're not doing that for normal samples, but we definitely encourage making sure you've got a label. Doesn't have to be fancy. You can always use your clinic labels too, but handwriting is great. And then your submission form. Dr. Steichen really highlighted just that importance of that case history. It isn't that we're just asking you to write it down and then we never look at it. We do actually look at your case history and try to make sure that we are hitting those points and making those considerations with the samples that are sent. It does guide our choice of test to select. We might actually give you a call and say, hey, based on this, it might be worth adding on this viral test, or had you considered this? It really helps to make it more complete and help us make more offers for what could be tested or what maybe would be a better test than the one that was selected. And then it helps us with additional safety or zoonotic considerations. So maybe if you are describing something neurologic, maybe we step back and do a rabies before we're actually digging into the animal and sending those tissues around, which can also, of course, help you with your safety. Other things that you might be describing will make us think of tularemia or anthrax or blastomyces. So those are all things that are great impact to human and animal health. We don't want our techs to get sick. We want to know if we detect these so you are not exposed and not being treated. want to, of course, include which tissues or samples you sent with the submission, but make sure they're the ones that are the most significant for the disease process you're looking for. Including information on the specific body site. This is really important for biopsies or cultures. Our pathologists are really great and they have good context clues with which cells are in there, but it really helps them to know where on the body this came from when they're making their interpretations. I also love it for cultures. Again, I'm going to interpret a mouth very differently from a leg, and even a superficial leg swab very differently from a deeper one from the leg. Treatment history is important. Might explain why we're seeing pure growth of a certain bacteria when it was treated with a certain antibiotic, why there's no growth there. Other treatments that might have been relevant for other sections there too. Recent travel or exposures is important, especially like with toxicology, or if we're looking at unusual pathogens that might be, they go to Arizona every winter, and now suddenly we're thinking of fungal infections we wouldn't see in North Dakota. So your suspicions and your observation are very helpful. Like in that case that Dr. Steichen highlighted, that garlic smell was a key note. Feel terrible for that DVM after hearing more about that and knowing how bad it is for the person, but that observation was helpful. And I'm showing this salmonella here because say you submit a lymph node, our typical culture for it isn't going to include enrichment for salmonella. But if you were saying that you're suspecting salmonella, I'm going to put it to some extra culture media to make sure that we can actually get it. A lot of times it does better if we enrich. So there is specific clues you're giving help us change up and customize your test. Sample containers. So this is, you're getting it ready to actually send out to the lab. Samples must be in a rigid primary sample container. It's pretty common to get samples like in a gallon bag with formalin, just Ziplocked. That is not an ideal primary container. So if you think about it, the rigid container is what's actually meant to hold the sample. And the bag is just the, oops, like it's leaking. So it's meant as kind of the backup, not the primary container. So ideally it's going to be a screw cap tube or cup if you're going to be sending especially tissues with formalin, but of course urine, anything that could leak. Leaking samples also, if there's other samples in there, is contaminating other samples. So really having a good specimen container can save you a lot of heartache. Blood tubes, again, ideally plastic. I can still think of a scenario where a practitioner had sent something in just a bubble wrap manila envelope. So it had the bubble packaging, but a bunch of glass tubes. And I think it had gone through some automatic sorting devices and tons of broken tubes. So really thinking about how you're packaging your samples so you, again, have protection for them and they get to the lab in one piece in the way you want them to. And then of course your culture transport container would be another primary container you could send. Again, that Ziploc bags are not acceptable for the formalin fixed tissues. And then if you can, it's a bonus, you can get this wax film that wraps nicely around the tubes. It helps prevent it from leaking. It's easy to open too. If you were to have to open it again, it just pops right open, but it does a good job of making sure that samples don't leak when they're trying to get to us. You do a lot of work collecting them, it's protecting it, and making sure it gets to us so we can do something. And I'm not entirely sure if this is commonplace in your clinics, but if you have someone that is packaging samples for shipment, they do require documented training. I know in the laboratory, every 2 years, we take training from the CDC that guides us through all of what we need to know as someone packaging a sample. And AVMA has policies on the shipment of diagnostic specimens. I have that linked at the bottom here. So there is information specific to clinics on what you need to know for packaging samples. Again, packaged to prevent leaking, and a sturdy box. Ideally, if you're sending it on an ice pack, or something on an ice pack, it probably also needs a cooler insert just to make sure it's firm enough. So getting good shipping containers is really ideal. And then there are also more requirements for select agents. So if you think you have tularemia, anthrax, plague, always call the lab first. We want to make sure it's shipped properly. We're protecting you, any of the shipment or the shipping carriers, and us when we get to the lab. We don't want any surprises when it comes to those big bads. And there's also potential for large fines if shipping regulations are not followed. If you had something break open and blood get everywhere when it's in, say, the UPS truck, that's going to be a problem. And they're going to know there's maybe a problem with how this was packaged. And so you might be getting a phone call. There can be large fines. I think they're pretty They're not consistently applied, but it's something to be aware of that it can happen. I remember when I first started at the lab, getting a phone call that one of our samples, maybe with tissues or a body, had been sent to another spot on campus and it had broken open, and there were warnings of fines for some of these things. So it isn't uncommon, and really a good thing if you can tighten that up.
Dr. Maddox,
Yes.
real quick. So when you guys send us an email that potentially you have anthrax coming in, our front office reads that email, and then our post-mortem technician, Christy, she's the one that's opening up all the packages. Christy will actually take that clinic and write it down on a whiteboard, and then she's checking all the packages for that clinic. So she's really making sure that that doesn't get opened, and she doesn't open it. Our pre-vet students, our student helpers, nobody's gonna open up that package. And that as soon as it comes, she's putting it in a biosafety bag for then Dr. Maddox to start the testing. So that information, you letting us know that you're sending it, is so important, and we appreciate it so much. So then that way we're not exposing Christy, who does an excellent job, and also our student workers there.
And it makes sure that we've got appropriate staffing. It does take an extra body to be able to go in and do a BSL-3 testing. We drop everything and make sure that that's prioritized, but we still have also all the other tests in the lab too. So want to make sure we have that staff. Thank you. Again, another great infographic from one of these papers. I think it really nicely summarizes things to think about for sampling, storage, and transport. Again, all specific to veterinary. So again, linking to that paper, it's going to even talk about temperature requirements. And I think the picture examples here. Transport to the laboratories. You got it in the box, but there are things to be aware of when it gets in that box. So samples are degrading during transport. So when we have delays, there are going to be impacts to that sample. Faster is always better, same day or overnight whenever possible. And again, I realize Western North Dakota, I grew up in Williston. I'm still always blown away like how cushy I feel like I have it in Fargo sometimes, and I'm all of a sudden realizing it's improved a lot with Williston. There are a lot more things that you have access to, but yeah, that's not just normal. So shipping would be one of those things. It takes a little bit longer, not as quick. So just in this little chart, just pointing out for culture, you can have pathogen overgrowth with contaminating flora when it's been deleted. For PCR, we're looking for DNA and RNA that gets degraded depending on the temperature, especially in higher temps. The longer it is in there, so all of a sudden you're gonna have a false negative sample. Serology, you end up with issues with hemolysis, which can cause for a rejected sample, especially if it's on the serum is still on the clot. And then histopathology, you're going to have more autolysis, so it's going to be harder to discern changes in the tissue. All scenarios are going to end up with a false negative or incorrect results, potentially. Histopathology, they can do some great things, I feel like, with autolysis. And there are a lot of times maybe you're coming to it by the time autolysis is already pretty terrible. So understand that that's a factor too, but fresher is better. In most fresh samples, maintaining at 2 to 8 degrees Celsius, so your fridge temp is ideal. The exception would be like your dermatophyte samples or blood cultures. There would be some other ones, but those will be test specific. And again, should be available on whatever laboratory website you're using. Summer, your heat is going to degrade those samples faster. Rolling around in a hot box is not going to help them. So making sure you've got ice packs. Then the winter, freezing is also harmful for those samples. For histology, you can improve submissions by adding, is it a 1 to 10 of ethanol to 10% hormone? That'll help it from freezing, and then that prevents some of that tissue artifact. You can have hemolyzed whole blood. We see that happen a lot with serology samples. So if you're going to be sending anything for tox to, I'm not sure how much it would impact like, it would impact some of like your phosphorus and some of those different things. And then ClinPath, of course, and then reduce bacterial viability too. But again, all potentially wrong result because of those transport temps. Then the laboratory is receiving that sample, reviewing the submission form, and evaluating the samples and the tests requested. So we're then making sure that what you've sent us, we can actually do something with. It is valuable on those submission forms. Besides that patient history that you're including time from collection, we're looking to make sure the proper media, transport media was used, is it expired, and then the animal species. So those are all important to include. And that includes my main part on sampling. I guess, do we have any questions before I go into resources? Okay. Resources. Our website I guess my passion project when I started at the VDL was coming up with resources, and trying to make it easier. So when we're trying to communicate that we need a sample a certain way, that we can actually give you guidance on what are we doing. So we have a whole laundry list of resources, including like those rabies and those diagnostic checklists. Those are all on the website at that link. I absolutely love, so they include information on sampling, but just really great resource for general treatment and management. So that ISCAID guidelines, those are there for urinary, respiratory, and derm. And also just some information on blood tubes. I'm including a link to that article. It just talks about the different blood tubes and what they're appropriate for. But then I also wanted to highlight the JABMA special issue. We have some in this group that contributed, but I had the privilege of guest editing this June issue of JABMA, and it's all on diagnostic laboratory medicine from sampling to test interpretation. So I was able to solicit submissions to JABMA that were specific to the laboratory and had overwhelming response from our AAVLD laboratories. I'll take you through a few of those. If you get JABMA, that should be in your mailbox. And then also did a quick podcast with the chief editor, Lisa Fortier, who is a North Dakota native, which is really cool. And then Dr. Sarah Wright. So that's available if you're interested in listening. But wanted to highlight some of the resources that are available in this special issue. So we had some pathologists that were kind enough to submit their diagnostic, their holistic sampling guidelines. So there's some non-swine practitioners recommendations really help you collect a holistic swine testing to get good results at a diagnostic lab that came out of Iowa. And just a general diagnostic process for infectious disease in animals. And this isn't just me being a medical laboratory scientist spoiled in human medicine. These wonderful veterinary pathologists are also pointing out that no amount of laboratory testing can make up for improper animal selection or poor sample collection and handling. So I'm going to highlight a few of those quotes here. And then that small ruminant reproductive loss also just goes over which tissues are best, and then recommending options for making sure you're getting the best results for those cases. Microbiology. I think this paper, this is the one that had that really great printout. They summarized it best: garbage in, garbage out, quality in, quality out. They had a lot of awesome guidance for microbiology. Also, I cited that top article several times. They did a fantastic job of summarizing good sampling, how to get samples to the lab in an appropriate time. And then actually a bunch of you, or some of you may have participated in this bottom publication. NDVMA sent out a survey link for this paper, and I think North Dakota had 18 participants in it. So North Dakota had good representation on taking this survey, which I thought was really cool. But they did an assessment of antimicrobial susceptibility reports and how veterinarians made antibiotic selection choices based on those reports. Great resources on PCR and for coagulation testing. So again, for the PCR paper for the respiratory acutely collected samples and clinically relevant information should be provided to labs to maximize outcomes. And then again, collaboration. If that hasn't been obvious, collaboration and dialogue between the lab and clinicians is really important. Again, collaboration, so consultation with testing lab for submission guidelines and assistance with test interpretation facilitates streamlined diagnostic workups and effective case management. So help us help you. They give a really good, I don't remember a lot of the coagulation cascades, but they did a really great job of reminding me of what those were and all the tests that I've evacuated from my brain. Toxicology. So this came out of our own lab. So Dr. Mitchell, Pecoraro, Webb. We have 2 statisticians from campus, Dr. Mostrom, Dr. Steichen, and Dr. Hoppy all contributed to this paper. So one of this could be from your cases. These are cases from our region. They assessed the copper and manganese levels and compared them against infectious births, stillbirths, and neonatal deaths in our beef cattle herds. And I think a good takeaway there was the cause of an abortion is more likely to be identified in cases submitted from the laboratory to the laboratory for necropsy compared to tissue sent in from the field. So that might be something to consider for getting more diagnostics on those abortions. That could be really challenging, but also getting some of those additional tests in there, like trace minerals, having serum from the dam can be really helpful.
you guys have other comments on your paper instead of me summarizing?
Placenta.
A placenta.
Placenta is helpful.
I get it. You can't always find it, but if you can't, we always appreciate it.
That paper, but also a website gives you a list of the types of things that if you have to do an autopsy, you at least have a checklist.
Yep.
Go there and make sure you have all the things. It'll just give you a better chance of getting an answer for your producer.
And if you're interested in more laboratory topics, call or email, check out our website. We have a newsletter that Dr. Mitchell now edits. Request a tour of our laboratory. You're in town at a clinic or you're in town visiting. We like showing off the lab. We've also had veterinarians come and shadow us for the day. So actually talking more through what we have. We did our case studies. If we have a cool case study, Dr. Stanger, Dr. Pecoraro, and I have the salmonella case that was really unique. We worked with the submitter to be able to submit that. So we submitted it to a case reports journal. These are things that we could potentially work up and do. If we have something interesting that's helpful for clinicians also. We like getting involved. Again, check us out on Facebook or LinkedIn. Lots of updates on when we're closing or changes to sample requirements. Those will be on our website too. But Sarah Geffro from my lab does a really great job with our social media. Lots of nice stuff on there.
And one more thing too is that clinicians are invited to our monthly rounds by Zoom or in person. And we put that in the newsletter before, but if you are interested in that, when you get the link to the presentations and stuff, you can just shoot an email back and say, I'd like to be on the list. It's for monthly path rounds. It's the first Thursday of the month at 8:30.
Yep. Those are super fun to be at. I'm not a pathologist, but I love it. I learn more about everything. So it's been fun. Yeah.
But I just came across, that's when I was looking up information about this meeting today, but I think I came across that sample submission requirements for Yoni's submissions are changing. Can you briefly comment on that?
I like Dr. Sanger.
That's my role. So we're giving people like just over a year kind of notice. So we're going to require for the Yoni submission that the fecal samples come in rigid, plastic, screw cap, leak-proof containers. South Dakota, Minnesota, many other labs already require that. We have seen kind of the last few years, the sample submissions coming into the lab, getting kind of poorer and poorer quality over time. So like I know in the past, we've recommended the rectal sleeves. Those can be done really well, and many people do, but they can also be done very poorly. And that leads to a lot of contamination before they even get to the lab. And they can become a mess trying to process. So we'll open up a box and there's fecal material everywhere inside the box, all over those samples. We have a hard time trying to make sure that the samples aren't contaminated when we're processing. So it will help you guys get better results. It will actually help streamline processing too. So those sleeves, they take quite a bit of time to go through, match up with the animal IDs and submission forms, layout, get ready to go. We have quite a few people that already send us samples in the plastic containers, and those can be very quick to process. So we can hopefully get everybody results out faster. They're easy to wipe down on the outside of the containers too. So kind of help keeping contamination from spreading in the box when they come. But we're giving everybody kind of a year notice before that becomes a requirement. It doesn't mean that we won't take the samples after that if they come in sleeves, but there'll be extra charges and they might take a bit longer for results.
And we'll definitely be communicating this throughout the year, so.
Yeah, we'll be posting it more and more often. We'll get an email out probably a couple of times, kind of reminding all of our Yoni's clients that this is happening. I would really appreciate it if you could help get it out to some of your clients that may do their own collections. We don't just take Yoni's fecals from clinics and veterinarians. We have quite a few producers that send us samples directly. So if you know of any of them that are doing that, please kind of help get the word out to them too.
Great question. Do you have any other questions? I appreciate you listening. I know it's probably kind of boring, but it is super important and it does really help. Really getting those good quality samples. It's the difference between a mixed bacterial growth and a significant pathogen, which mixed bacterial growth is also an answer. And we'll say that, but you really do increase your likelihood of getting a good result for your patients with just a little bit of extra planning. So, right. Thank you.
Did I get your certificate there over there?
I think everybody has, some people left early.
Okay, that's fine.
And the meeting was a success due to.
Thank you. And then, of course, we always welcome your feedback. So thank you everyone for coming. And we're here if you need us. Enjoy your weekend.
Yeah. What brands did you say? Okay, I'm not, right on tomorrow.